Wonderful to see all of you here. Many familiar faces and a lot of new faces as well, as we undertake what is the third in a series of 4 workshops focused on the Precision Medicine Initiative and the development of a historic national cohort. And we seek in these gatherings today and tomorrow to get input from many of you about participant issues that can help us with the proper design of what we want to be an absolutely groundbreaking and optimized effort that's going to change everything. So I'm Francis Collins. I'm the director of NIH. I'm extremely enthusiastic about the potential of this initiative and also a little anxious that by September we have to have a design for this fleshed out. And we have a bit of work to do. So this is not one of those meetings where everybody already knows the conclusion and can sort of do their email and pay no attention. That's not going to be the kind of meeting we're going to have. This is a fully interactive opportunity for lots of talking and lots of listening and lots of interacting. And appreciate all of you having set aside the time to be here, knowing that in many instances you've got a lot less warning than you might usually expect to do. And that you were asked to drop everything in summertime, the week of the 4th of July, no less, and show up here. And we appreciate the fact that almost everybody said, yeah, of course, this is important. This really matters. I want to be part of it. So there are people in the room who have been already engaged in some of the other workshops that we have been pushing forward with great intensity since the President announced the Precision Medicine Initiative back in January. But there are others who have not been. And so it would seem to be a good idea to set the stage a little bit by going through some of the basic ideas that led to this proposal of having such a cohort and a bit about where we already have come, and then perhaps setting the stage a little bit about what the major questions are that I hope this group can address today and tomorrow. So that's my task. I'm not going to speak for a terribly long time, but I do want to kind of set that stage, and then we'll get into some very interesting panels that will occupy most of today. So the challenges. We have too many diseases that don't have at the present time well-proven effective prevention strategies, where diagnostics are not optimized, and where treatments are either not available or we're not sure whether they work as well as we would want them to. And many of those current options are done in a one-size-fits-all approach because it's the best we could do, and so they have not considered key differences amongst individuals. And that's what we really mean when we talk about precision medicine, is identifying those individual differences in genes and lifestyle and environment in order to make the right choices for the prevention of disease or the management of chronic illness for that person, and not just for a generic idea of what that person represents. On top of that, we would all agree who are involved in research that clinical trials are slow, they cost a lot of money, they take a long time to get set up and enrolled, and then oftentimes you have to tear them all down again, and we're not taking full advantage of the ability to do things more efficiently. Many of those trials end up being small and narrow in scope, and may, because of exclusions, not really represent real-world solutions, which makes it hard then to extrapolate from the results of the trials to the clinical practice. Participants in clinical trials, sadly, have often not really been considered as participants. They are, quote, subjects, a word that I think we should basically strike from our language, but it's still there in various regulations. And we will spend a lot of time today talking about the importance that participants really are participants and they're partners. They're not subjects. We won't even necessarily consider them as patients because many of them are healthy. Research findings, furthermore, often take a very long time, even once they're established, to be implemented into clinical practice. That turnaround loop is much too slow. So there are some serious problems. Now, I'm not going to say that this cohort is going to solve all of those things tomorrow, but it will, I think, contribute in a substantial way to addressing each one of these challenges. So let's hear from somebody who knows a little bit about this. What are we talking about?
So tonight I'm launching a new precision medicine initiative to bring us closer to curing diseases like cancer and diabetes, and to give all of us access to the personalized information we need to keep ourselves and our families healthier. We can do this.
Yes, we can. And you'll notice the chamber rising to its feet Both parties, they don't do that a lot. They didn't have a lot of information to go on about what they were supposed to clap for, but they were clapping because it sounds like a good thing. Well, let's see what we can do here to help the cause of people's health. Well, that was a fairly quick blurb of a bit of intention to what's going on. More information came forth in another 10 days. But I might say this is not the first time the words precision medicine had been voiced. There was a whole IOM report about that a couple of years earlier. And the idea of having a long-term prospective cohort that would look at genes and environment in the United States had certainly been around, proposed by this guy, actually, in 2004, in a commentary in Nature based upon a lot of work that was done by a working group assembled by the Genome Institute at the time. So you might say, well, gosh, why didn't it happen then? Well, this landed with a thud because at the time, the practicality of mounting such a cohort was way out of reach, to be honest. Some of us were being a little bit idealistic because look at some of the statistics. 10 years ago, if you were going to include genome sequencing of hundreds of thousands or 1 million or more people, the cost would have been prohibitive. But look what's happened since then, the profound drop now 10 years later. The amount of time that it took at that point, 2 years, now less than a day. As we'll talk about, the availability of smartphones and the so-called mHealth revolution, mobile health apps that many of you carrying around right now. I have both my Fitbit and my Apple Watch. I'm trying to decide which one I can get rid of because my wrist is a little overweighted right now, but we'll sort that out eventually. But those kinds of apps were really not there 10 years ago, except in a very few places. Now, with smartphones being widely accessible and with lots of ways to utilize them for monitoring health, we have a real opportunity to figure out how that works. Electronic medical records, very few of those around 10 years ago. Now, a percent of providers that are using them, over 90%, admittedly kind of kludged in a lot of places. We have work to do here to get those to be actually meaningfully useful for research. And all of this is going to be a big data challenge, but computing power has come forward. So 10 years have gone by, and we now, I think, could be said to be in a much more facile and appropriate place, and I think that was a strong motivation behind the president's decision to announce this initiative and to say he wants it to start in FY16. That would be starting October 1st. Hence, the pressure upon all of us to figure out, okay, what is it, and how do we do it, and what is it really going to look like? And Harold Varmus and I wrote a piece for the New England Journal that came out the same day as the White House East Room presentation of what this was all about. And by the way, if you're not already tracking it, we're trying to put information up about precision medicine on this website and keep it updated all the time so that as this very fast-moving process plays out, you have a place where you can go and see some of the documentations of where we are in terms of the plans and the design. So what is it? The vision. It's to build a broad research program to encourage creative approaches to precision medicine, test them rigorously, and then ultimately use them to build the evidence base needed to guide clinical practice. That's the big, broad vision. But it has two components. In the near term, to apply the tenets to a major health threat that is ready for expanded effort in this space with a great deal of promise for advance, and that is cancer. I'll say a little bit more about that in a second. In the longer term, to generate the knowledge base necessary to do this in virtually all areas of health and disease, and that's where this million-person cohort kicks in. In terms of the cancer approach, and Doug Lowy is here, the acting director of the NCI, over in the corner, has put a lot of time and effort into this since he stepped into that role in April. The idea here is to take what is already starting to happen and scale it up in a big way to be able to identify the drivers of malignancy in individual tumors from individual patients, and then try to connect that up with optimized targeted therapy based upon that molecular understanding. So it's not one-size-fits-all chemotherapy. It is individualized targeted therapeutics. NCI has a program just announced in June called MATCH. This will enable MATCH to grow into different areas, including new cancer subtypes, therapeutic targets, There's a wonderful opportunity for partnership with the private sector here because we need access to targeted drugs, and the idea that multiple companies would make drugs available for a single trial doesn't always happen, but they have agreed to do so here. We can expand efforts on childhood cancers. There's an opportunity to go beyond monotherapy to combination therapies, which are going to be critical in the view of most of us if you're serious about not just remissions, but actual cures. And to understand and combat drug resistance. When it doesn't work, why didn't it work? And what could we learn about that in order to offer better opportunities? So this is a front end of the Precision Medicine Initiative, which is what might say ready to go except for the dollars. And the dollars have been put forward by the President, $70 million for FY16. And in fact, the Congress seems very favorably inclined, judging by the appropriations decisions that have been put forward in markups just in the last 10 days. We're not at this meeting talking about the cancer part. That has been discussed recently at the National Cancer Advisory Board and the NCI Board of Scientific Advisors. But you should know that this is a significant component of what we're trying to do, and we want to be sure that these two parts are connected as much as possible, particularly when it comes to issues such as data science. But we are going to be talking about this longer-term effort to generate a knowledge base that can move precision medicine into the whole range of health and disease. And that is going to be bold indeed. It will require a lot of creativity. We will hope to recruit a lot of very smart scientists to enjoy the opportunity of taking part in this because there's going to be a need for lots of talent and vision. And we want to try to tap into a wide array of technologies as well. But the real idea here, and the reason for gathering us all at this day and a half, is that participants who are going to be asked to take part in this are going to play a very significant role in the design. So let me talk a bit more about what's involved. Patient partnerships, electronic health records, again, as an opportunity now that wasn't there 10 years ago, but now is, to be able to track medical experiences, laboratory data, drug prescribing, and so on in a fashion that is not going to require going through reams of paper. The ability to tap into technologies, as I've mentioned, the so-called mHealth opportunities, to utilize those and to test out their utility in ways that we have not previously rigorously looked at. The use of all kinds of genomic technologies with the expectation that the already impressive cost curves coming downward are going to continue to fall. We should have the opportunity to do very extensive genomic analysis on 1 million people. And all of this creating a very significant data science challenge and opportunity when you put all that data together in a way that you need to mine it and understand what are the most critical observations that you can make. So the vision is a national research cohort, a historic development of at least 1 million U.S. volunteers, and I will confess I would love it if it was more than that, but let's start there. And where do those come from? Well, there are numerous existing cohorts, and we talked about this in the previous workshop in Nashville about a month ago. Such places as Kaiser Permanente and Mayo and Marshfield and Geisinger and Intermountain, who already have started this kind of effort, enrolled in some instances tens of thousands of people. There's the Million Veterans Program of the Veterans Administration, who've enrolled 400,000 veterans and already done genotype analysis of about half of those. And it would be very helpful, I think, to actually put together this kind of cohort by taking advantage of the work that's been done and the money that's already been spent, if we can do so in a way that is fully comfortable for those participants, some of which will be excited about joining a larger effort and some of which may want to think about it, but we need to have that conversation. But that's not sufficient. We need clearly to do outreach to underrepresented groups. We want this cohort to be highly useful for understanding health disparities. And unless we make a specific effort in that regard, we may miss that opportunity. We'll be talking about a lot at this meeting. And ideally, we would like any volunteer in the country. My brothers all want to take part in this. None of them happen to be in any of these cohorts, and yet they would like to sign up. And every time I talk about this, several people come up to me and say, sign me up, where do I go? I want to put my name in. Well, we would not want to discourage that, but obviously the ability to do so in the absence of some kind of medical care framework may be a little challenging. We have to figure out how to make that work. Participants, again, are not subjects. They're participants. They're partners, centrally involved in the design, the implementation. In order for this to work, we have to have sharing of data, genomic data, lifestyle information, biological samples, and all linked to electronic health records. And I would say one of the great values of this particular cohort will not only be that you can follow these people longitudinally, but that they have the opportunity to be approached about taking part in clinical trials of therapeutics or of devices, and they can say yes or no, but it provides a wonderful way to try to do enrollment, which currently takes much longer than it should, and to build upon a framework to make clinical trials happen much more efficiently and cost effectively. So this is proposed effectively as a new model, emphasizing engaged participants, open, responsible data sharing with privacy protections. Now, you can already sense sort of a little tension there. You want open, responsible data sharing, but you want privacy protections. How do we do those things simultaneously? A lot of work has been done thinking about that. I'm sure we'll talk about that at this meeting as well. So what would you do with this cohort if you had it? I mean, it's a bold idea, but what kind of revelations could come forward? Well, one is you might actually, by having a lot of people with common disorders and a lot of data about them, begin to realize that the way we classify disease, which is based on mostly information that's decades old, is not optimum. Maybe diabetes shouldn't just be type 1 and type 2. Maybe we've got lots of subsets of diabetes that we could recognize and that would correlate with natural history and response to therapy. Mental illness may be particularly an appropriate place to look at this, because our classifications of mental illness, I think we would all agree, are pretty shaky in terms of being symptom-based and blurry, and the opportunity to try to make that more precise and to figure out, therefore, how that correlates with therapeutics would be extremely useful. Pharmacogenomics, I'm going to come to in a second because I want to play that out as maybe one of the early results that we could be almost counting on coming from this. The idea of being able to use information about the individual, particularly genetic data, to choose the right drug at the right dose, because we all know that it doesn't always work in the generic one-size-fits-all approach. Can we actually use, with such a very large cohort, information to obtain an unbiased determination of future disease risk? Again, right now what we have is okay, but it could be better if we had more individualized data and the ability to follow people prospectively. And of course, that would be enormously helpful in planning individualized prevention if we were better able to say who's at risk for what. Undoubtedly, we have an opportunity here also because we're not just studying sick people, we're studying a cross-section of Americans, most of whom we hope are going to be reasonably healthy, but some of them maybe shouldn't have been healthy, judging by their environmental exposures or their genetic data. What's resilience about? This is an area that we would love to understand better, because if you can uncover the causes of resilience in people who had some reasons not to be healthy, but they happen to be, that tells you something useful that might be extrapolatable to other people to help them stay healthy as well. And of course, an awfully powerful test bed for doing a better job, not just of researchers deciding how people are doing, but people telling you how they're doing, patient-reported outcomes, improving the utility of electronic health records, evaluating this wide array of mHealth applications, trying to understand environmental exposures in a large population in ways that we need to know more about. Those are some of the possible uses. So how have we been approaching this? Well, we have this working group of the advisory committee to me, the ACD, which is the place where we have often asked distinguished leaders to help us design or answer important questions. This is, we had a working group of the advisory committee that basically helped us design the BRAIN initiative, which you might have heard about. Well, this one is focused on this cohort formed in March and working prodigiously hard. Thank you, all of you who are part of this group. I'll give the roster in a second. Their charge is to develop a vision and advise on design. We've already had this initial workshop, April 28, 29, here at NIH to look at unique scientific opportunities. The workshop in Vanderbilt a month ago, looking at digital health data, electronic health records. How are we going to make most of this? What about existing cohorts, and how can we glue them together? And here is the roster of the folks involved. The co-chairs, Rick Lifton, here in the front row, Bray Patrick Lake, who you're going to hear from in a moment, and Kathy Hudson, all of whom have put a lot of their time and effort into this, and we're not done yet. And here are the members, many of whom you will see today taking part as panel leaders for the discussion we're having, and all of these folks also having rolled up their sleeves and no doubt set aside other things they were planning to do this summer in order to make this all happen. And a very distinguished group with a wide variety of expertise, as you can see from this list. So, considerations to date, just to sort of say where we are, but there's still many things that still need to be resolved. We want this cohort to be efficient. We want it to be inclusive. We want to leverage these existing cohorts if we can, because it will allow us to move forward more quickly and inexpensively and take advantage of data that's already been collected. But we want to be sure to include underserved and underrepresented groups in sufficient numbers that we can look at health disparities. And one possible way to do that is through the federal qualified health centers, the community health centers, which we believe might be an ideal place because they have electronic health records and serve many individuals who are underrepresented traditionally in these kinds of research studies. We've had a discussion already about children, and we are leaning strongly in the direction of including children, although there are consent issues that are obvious. We want military members and veterans to be able to participate, but we don't want to assume that anybody would just sort of be folded into this because they're taking part in some other cohort. We want to be sure that consent is obtained from all as part of this initiative so that people know what they are getting into and what they might get from it. There are obviously going to be very significant issues about the data. It has to be highly secure, but also broadly accessible. Again, that tension that we have to try to hit correctly. At the moment, we're talking about a hybrid data model that is partly centralized, but partly distributed. Other folks who are here can talk more about what that model looks like in the way that it's shaping up. Again, strong de-identification to try to increase the research use and to maximize individual control. We want that control. We want individuals who are part of this to have flexibility about how and when to participate, to be made aware of research studies they might want to participate in, but there needs to be this open, responsible data sharing with privacy protections. There are policy issues here that need addressing. IRBs can potentially be a really important part of this, but as we all know, if you have 39 different IRBs reviewing the consent form, that doesn't always provide a lot of added value. So we're going to want to look for the ways to do this through single centralized IRBs. The privacy standards will be talked about at this meeting in terms of exactly what they should look like, and they need to be very strong in a circumstance with this many people involved in sharing their medical data. But we also want to encourage this data sharing issue, and clinicaltrials.gov, which is going through an increased area of openness, will help with that. We also, policy-wise, would like to strengthen the way in which inappropriate re-identification of research participants would be discouraged or even punished. So those things are also in the mix here as far as discussions. Just to finish up here, in terms of imagining the possibilities, I mentioned pharmacogenomics. I do think this is an area where we could potentially get results relatively early on with a lot of people involved and their genotypes available. Down at the bottom of this slide, you see the FDA already has 150 or more pharmacogenomic biomarkers in drug labeling. That is, the drug label says there is a known genetic variant that influences the dose that you might want to give of this drug. Most of that information is there, but it's not being utilized because it's not accessible to the physician at the time the prescription's being written. And so if you have, on the other hand, for 1 million people, that information's already been obtained, you can really test out the idea about whether having that results in better outcomes. And there's a long list of drugs, blood thinners, antidepressants, drugs to treat hyperlipidemia, and so on, for which this information could potentially be quite useful, but it hasn't really been put to the test at scale. To make that more of a practical example, although this is hypothetical, imagine Melissa, who's a participant in the PMI. She wears some various sensors. She's a cohort participant. She's diagnosed with hypertension. She gets her genotyping done. The pharmacogenomic results are made available to her because we want information to go back to participants as much as possible. And that actually turns up the fact that perhaps the drug that she's taking for her hypertension is not ideal. And with the change, she ends up with a better outcome. Meanwhile, all that data goes back in the cohort database, contributing to understanding, and it's part of our research efforts to see, does pharmacogenomics actually improve outcomes? Just a very quick snapshot of an example. Well, here we are today, July 1, 2, and the goals here and the considerations are that we really want to focus on how participants can be part of this effort, including in the governance. How can we ensure inclusion of underserved and underrepresented populations? What kind of health information will participants want to receive, and how do we make sure they get it as a benefit of being part of this effort? And how do we keep the volunteers engaged and active over time so that it's not just a one-time thing, okay, I signed up, and then forget about it? Because we want this, if it's going to be successful, to extend over many years. The value of the information will grow with time as more and more data is collected and medical experiences are encountered by the participants. So, I guess the bottom line is, for all of those who are considering this possibility, participation is critical, but it needs to be really substantive. The country is interested. Yesterday, there was a Twitter chat that went on that Kathy Hudson and DJ Patil, who's the White House Chief Science Officer, and Josh Denny and a few other people were involved in. Here are the statistics. 71 million impressions occurred during the space of that Twitter chat over an hour. So what's an impression? That means that people who tweeted, who had followers, you add them all up and you get to 71 million. You can see who were the top 10 mentions for the PMI network influencers there, and that's quite an impressive list. But down in the lower right corner, Twitter actually keeps track of what's trending on Twitter. And we got to be number 10. We beat out a whole bunch of other people. We didn't quite beat out annoy your partner in 5 words. I don't know what that was about. And obviously Chris Christie was sort of having a day announcing for president, and that wonderful Misty Copeland story about a ballet. But nonetheless, for PMI Network to get on the list here of what's trending across Twitter is pretty impressive. So bravo to all those who tweeted. And we will be doing more of that during the course of this meeting. Many of the people in the room are inveterate tweeters, myself included, and we're going to have a buzz going, and you will hear in a minute from Bray about how you're going to learn from that. So finally, this quote from the president on January 30th, when more details were being put forward about the Precision Medicine Initiative, and you can see the DNA double helix in the same photograph. I think that's Eric Green's model of DNA, but what the heck, it was in the East Room for that point, saying, I'm proud we have so many patients' rights advocates with us here today, because they were invited in significant numbers on January 30th. They're not going to be on the sidelines. It's not going to be an afterthought. They'll help us design the initiative from the ground up, making sure we harness new technologies and opportunities in a responsible way. Well, that's what we're here to try to live up to, that promise, and I'm sure with the group that's assembled here, that's exactly what is going to happen. So, thank you all for being here and for listening to this initial introduction of sort of some of the context, but I now want to introduce Bray Patrick Lake, co-chair of this working group. Bray has a very important background that fits here. She's currently serving in dual roles at Duke University as the Director of Stakeholder Engagement for the Clinical Trials Transformation Initiative and Director of Patient Engagement, although I think she's probably distracted a bit from those duties by what we've asked her to do as part of precision medicine. She knows about patient engagement. In 2010, she founded the Patent Foramen Ovale Research Foundation after experiencing herself a lack of definitive scientific information regarding this condition when she was a patient in a clinical trial that didn't go well. So she's a rabble-rouser, just the kind we need for this. And she's brought her expertise and disruptive sensibilities to bear. She's been heavily involved in previous conversations with FDA, at the IOM, with AHRQ, with PCORI. She's a member of the PCORNet Coordinating Center's Executive Leadership Committee. She's highly committed to the cause. She works tirelessly as co-chair and brings her amazing expertise and energy to the PMI. So please welcome Bray Patrick Lake.
So thank you to Francis for that was a lovely introduction. I'll be reminded to shorten my bio after this meeting. Okay, so welcome everyone. As Francis said earlier, we know that the 4th of July vacations are upon us. And thank you so much for taking time to be here. But I actually think that that is very important because on the 4th of July, we celebrate the birth of our nation. And today we are coming together to celebrate the birth of a cohort of our 1 million research volunteers and to begin our research revolution of we the people. So the Precision Medicine Initiative is a team sport, and so I ask you, instead of a declaration of independence, to make a declaration of interdependence. Under the bold leadership of the President of the United States and Dr. Francis Collins, and perhaps we can actually liken them to George Washington and John Adams, although perhaps Francis would like to be likened to Sam Adams because he has a cool beer named after him. But regardless, you are the Army, and the Army is now marching, and together we are here to liberate the data for the good of our nation. So we have this tremendous opportunity in front of us to enact real change. We've talked about it for many years in many different settings, the power of participant engagement, the need to address and eliminate health disparities, and the promise of a human genome. And frankly, being from the participant community, I think we've waited way too long, and now is the time. So we still have a few threats that are out there, and I think the pressure of early wins and the temptation to take shortcuts or sidestep the tough issues. We know that there have been important advancements in science, but there are instances where we know we also could have done better. But we cling to familiarity, and that's because we're more comfortable failing in a familiar way than actually embracing change. So I want to interject a thought here, and that is, do what you always do, get what you always got. And I want to say that again, do what you always do, get what you always got. So we know what we need to do. We know what the tough issues are. We're here today to explore them and to come up with solutions and to make recommendations to the working group on how we can actually solve these problems. But I will tell you, we're going to get out of our comfort zones very rapidly with the Precision Medicine Initiative. We have some new things to try, and I think we need to all be okay with that. So many of us here have been to a number of meetings, and we are tired of talking about the issues, so I encourage you all to be really driven in your comments to give us solutions and tell this working group how we can solve these problems, because it is time to push the boundaries of science, technology, and partnership with participants. And it's really time to get out of our comfort zone and embrace the opportunity to change that we have presented before us. So on behalf of the Advisory Committee to the Director Working Group on Precision Medicine, otherwise affectionately known as the ACD-PMI-WG, we are going to explore some issues today. And so we're going to ask you some specific questions around helping us understand the key design features of a participant-driven, inclusive, and diverse cohort. We need you to help us engage and meet the needs of communities that have been historically underrepresented in research. We're asking you to share your thoughts on how Precision Medicine Initiative can build and sustain public trust through governance, policy, and implementation. We're asking you to help us learn more about the direct from participant cohort model that we're seeing pop up a lot in the patient-powered research network model. And then also, what are the new models of active engagement that could be deployed in our existing cohorts as we talk about how we might have a hybrid model and bring in and leverage the resources and the data from existing cohorts. So we have a jam-packed, exciting 1.5 days planned together. And I really want to thank the team that organized this workshop. If you were part of the workshop organizing team, would you please raise your hands? Yes. Okay. Thank you. And then out of that group, there was a subset that was literally held against their will on one day when I said, we have to get this agenda nailed down. So no joke, some of them went to the airport at 4 in the morning. They attended an all-day meeting. They went to a dinner meeting, and then I think I held them against their will, probably until 10:30 at night. So if you were one of those people, please raise your hand. In a bar. Thank you. I didn't say in a bar. Thank you, Kathy Hudson. But it was, okay, it was in a bar. But I don't know. It was still, I just was so impressed that nobody actually just got up and walked out. Basically, we are looking to this session to have heavy audience participation. So there are microphones planted around for the working group. There are 2 on the stands, and then we've got 3 that can be circulated throughout the day. So each session actually has built into it time for discussion. You have heard that this workshop is being webcast, and you can follow the Twitter discussion at #PMI. My fingers are still bleeding from yesterday's tweet chat, so I will be tweeting less today. But if you participated, it was just a super rapid-fire, amazing event where you could hardly keep up with the volume of information that was coming in. And a lot of you that participated in that, we actually have the experts and the thought leaders in this room. And so I am going to ask you to continue your tweets and also make sure you get to the microphone and help us pull out the nuggets that we're going to need to write this report. And for those of you that are online right now, if you are comfortable doing so, go ahead and tweet your primary lens or a particular community that you identify with, and just let us know who's out there and participating in our tweeting, I guess it's not really a tweet chat today, our tweeting today. So the flow of the day, we will have a break from 10 to 10:15. Lunch will be from 12:30 to 1:30. And then we'll have another afternoon break from 3 to 3:15, and our meeting will adjourn at 5:30. We have what I would call at the PMI ACD at WG an extended lunch. We've never had a full hour before. So I ask you to take advantage of that opportunity. We have experts and thought leaders from many communities here. So sit with people you don't know. Let's brainstorm and let's really work through a lot of the issues and the solutions and share our knowledge and information over lunch. During the breaks, live analytics of the discussion on Twitter will be displayed in the room and on webcast. And then in addition, the NIH is encouraging those of us who are here in person at the meeting to participate in the Faces of Precision Medicine Initiative video collection. So there's actually a camera crew on site who can actually help you shoot a short video about PMI, and so we would love it if you could go down to the video booth on breaks or over lunch or briefly at the end of the day. It's that way, and the room is GG 607. So, with that, I would now like to introduce you to our ACD PMI working group member, Dr. Tony Coles, who is the chairman and chief executive officer of Humanity Therapeutics, and he will moderate our first session with our opening speaker, Ms. Vernell Branch, on envisioning a participant-driven cohort. Thank you.
Thank you, Bray, and good morning to everyone. An exciting and interesting day, and I can't think of a better way to begin the day than by hearing from someone who, at the ground level, has been a real force in the conversation on behalf of patients, survivors, and most importantly now, participants as we think about the project that is in front of us. Vernell Branch is a 20-year veteran in the world of patient advocacy. She is herself part of a moving force called the National Breast Cancer Coalition and is a survivor of that disease by 20 years. She is, if you will, the prototype of the participants that Francis talked about in the opening comments, mostly because not only is she a survivor of a horrific disease, but she is herself on the front lines of advocating for all of the people who suffer, both patients as well as their family members. So please give Vernell a warm welcome, and I'm sure that you will enjoy hearing what she has to say, and then we'll come back and we will take a few questions in the open session. Vernell?
Thank you, Tony. And thank you for all of the planners of this meeting for inviting me to speak to you today. When I was diagnosed 20 years ago, the science was not quite what it is today in helping patients to make health decisions. So I really had to rely on information from my oncologist and also get second opinions that I obtained also. Also, in 40 years, I've moved like 13 times within different health systems, and the internet and the Google were not what it is today. So we are in a very fast moving age where everything is available for the patient. But I remember 20 years ago, my husband said to me, he said, I really want you to be around to rock some grandbabies with me one day. And I said, honey, I said, nobody's going to have those 3 boys. I said, first of all, they're high maintenance, and they're mama's boys. And here I am today, 20 years later, and all 3 sons are married, and I have 6 grandchildren. So I am a survivor. When I first heard the President Obama's announcement about precision medicine, initiative, I thought this is really a complex problem from the patient and from the provider's point of view, with lots of components that are going to be need to be considered. I think there's going to be a lot of barriers, then the design study itself and transparency. And Dr. Collins alluded to all of those today. With the rapid sequencing of tumors and the pathways involved with progression of disease, this has now become an issue for patients with the burdens of tissue extraction or blood. How often does this need to be done? And who pays for this if it's not approved by the insurance companies? So it needs to either be government or industry. Some challenges will be from the payers of these new diagnostic tests and drugs. Will drive up the health care costs, but I see this will be a savings if we can do the tests that will give the right information. So the treatment will be more impactful to the patient. With the designing of this study cohort, it will be beneficial to think about how to prevent disease with some of these new discoveries for the Precision Medicine Initiative. There's a need to think outside of the box when creating a model for recruitment to this cohort that will include community in the efforts, and especially the rural and minority communities. This is hard work, but the efforts need to be done because people want to know the importance of their participation and to be asked. I remembered when I was working on a really important study called the Sister Study, and women were so willing to participate in this study because they felt like this was going to make a difference for the next generation. So women signed up by the droves. We were looking to recruit 50,000 women, and we got 55,000 women. And these were women who had not had breast cancer, but their sisters had had breast cancer. So I think we need to take a look at models that have been really good at recruiting and look at how they did that recruitment. And this is one of those. This is hard work, but the efforts need to be done because people want to know the importance of their participation and be asked. There's also a need to do some work with primary care providers in order to make this initiative work for retrieving records and encouraging their patients. Patients will look to their long-term providers for advice about participation because they trust them. This is where we need the patients to be involved in clinical study designs for patients that are going to be in the recruitment to have more of an impact for showing improved care. When talking with patients, they often don't participate because of randomization, which I understand is done because they don't want the study to be biased. But that is why so many of these studies don't get the number of patients they need to conduct the study and end up closing. This is a disservice to those who did enroll and also a waste of valuable resources and money. Targeting in this cohort throughout the U.S. in areas for minorities and rural communities with a strong educational component is key. It is difficult, yes, but there is something that needs to be done in order to accrue the patients to get the answers to these questions for precision medicine research. My experience in the minority community is very personalized for getting patients involved with studies and screening programs. Because of this outreach, using methods that don't allow the researchers access because of not being known in the community, but training others within the community for ownership and pride for bringing something of value to the community that will eventually be beneficial. Transparency, people who participate want to be informed of the outcomes of their participation, and this has not been achieved in a timely way in the past. Social media has been a terrific tool for some recruitment and informing people about research. However, researchers do not like to inform patients until they have published their outcome results. This also needs to change so that patients can feel the value of their participation in research. There needs to be a way to keep participants in the cohort informed so researchers can still publish results. I will end with the fact that 20 years ago I was never offered a clinical trial or study to be involved in, but I have since been involved in several studies that have been collecting data. I do this because I want to add to the information for other members of my immediate family and extended family members. This is an important element for getting people involved with this cohort, for making it not about them, but about the future generations. Information achieved from the precision medicine research helps to take prevention within families to a new level of understanding and implementation. I think this is going to be a real key for patients to get involved. I think that when you make it not about them, but about that next generation, they will want to be involved in this particular cohort. Thank you.
Thank you, Vernell. This is, I think we've got about 20 minutes or so to engage in some conversation. So I'd love to open up the floor for questions for Vernell. And this is always that very awkward moment where no one raises a hand and I've got to fill time. So luckily, I actually have 3 questions to kick us off, but please don't force me to use them. All right, I see a hand just here. Would you mind, actually, if you don't mind, using your microphone, and if you'll just say your name so our colleagues across the room will be able to identify you.
Got it. Is that better? Lucia Savage, ONC. One of my jobs is helping people understand, what their privacy rights are, and physicians understand what their privacy obligations are. And I was really struck by what you said about how we speak to our research cohort and how we get people involved in research. And I was wondering if you could just give a little anecdote about what it is the language that makes people interested in joining a cohort. Was there a particular language that spoke to you or your sister's study that might not have been used in earlier activities? Because I think we have to speak in different languages to different audiences.
Yes. One of the things that we used for the sister study, and NCI really helped us with the messaging. And I think that that's going to be a real key for outreach in the communities. They helped us with our message because we actually got women from all of the different communities, whether it was Native American, Asian community, Asian Pacific Islanders, African Americans. We had women that had enrolled in the study. So we had them talk from a personal point of view. With their sister, the sister who had breast cancer and the sister who had not gotten breast cancer. And we framed the question so that this spoke to the community of how important it was. This was going to be a long-term study that was going to last for about 10 years or more. And so I think when you bring the faces and use the people that are in the community, and we worked very, very strongly with the faith-based community. I went to a lot of Baptist conventions and Methodist women's associations, worked with sororities. So we went where the people were. I think that's what you're going to have to do. They're going to have to be boots on the ground. They're going to have to be, I think, one group of women that I really worked with very closely was in the promotores in the Latina community. And they were so willing to get out there and get people enrolled in the study. And I think this is another way of doing this. But you really have to, it's going to be one by one, but you can do it on a large scale. And sometimes messaging through billboards and things like that don't work. You really have to it has to be a personal level.
I see, and I'll remind our colleagues on the sides of the room that there are floor mics. So the gentleman here in the blue shirt.
Thank you. I'm Mike Lauer. I'm at the National Heart, Lung, and Blood Institute. I really enjoyed your talk, and I was intrigued by the comments you made about randomized trials. And I was wondering if you could extend on them a little bit more. Some of us see this cohort as potentially a platform which would enable rapid execution of randomized trials in precision medicine. What are your thoughts?
And I think that's why people don't enter in trials, because in talking to patients, they said that because they don't want to be randomized. They want to have a choice. And that's why I think we only get 3% or probably less of patients in clinical trials. If we could design a trial where patients can choose, I think you'll find that you're going to get the numbers that you need on each side, whether it's on the standard of care or on a new investigational drug or device. I think that you can design it differently so that people can have a choice. People want input into what they're going to participate in. And I think that that needs to happen. I don't know how to do it, but there are some smart people out there that could probably do that.
Thank you.
Lots of questions, but Vernell, let me, if I can, just interrupt the flow from the floor and just ask you a question. You know, one of the things implicit in Mike Lauer's question is this notion that there are some barriers to the broad inclusion of all communities in clinical trials. How do you think about building trust, building bridges, both trust bridges and infrastructure bridges, to address this particular problem and remove some of the barriers? How have you been successful?
I think one of the ways is, really talking about my own, keeping it personal, my own experience. And I think you have to, I remember working on a spore at UCSF, and we as patients, we actually talked about our own experiences and really built that trust within the cancer community so that people were more willing to donate tissue. And I thought that that was and we told them why it was important and how it was going to be used for research. And it was going to make a difference, maybe not for them, but at some point in time, it would be a useful way of designing drugs to target their cancer. So it was a matter of talking to patients in a way so that they understood. And that's where education comes in. I think a lot of the language that is used now is so over a patient's head that they don't really understand what it's being used, what tissue, what blood is being used for, and how it can be useful for research.
So translation and trust is what I hear in that answer. There's some more hands on the, yes. Name first, if you will.
Hi, Claudia Williams. I just wanted to thank you so much for that great presentation. And what's been remarkable about this whole effort is NIH's skill in bringing in so many voices that have expertise in this question of how to create a participant-driven cohort. So just want to invite the whole room to help, maybe in response or reaction to what Vernell said. What does it mean to you? What would it look like? What would success look like if we've succeeded in creating a new model that's open, creates responsible data sharing, and truly is participant-driven? Would love to hear your thoughts. So just an invitation to everyone as you comment to also share those insights.
Vernell may have a thought, but I see Pearl and Esteban. So why don't we? Why don't you kick us off, Vernell, and then we'll go to Esteban and then Pearl.
Well, I really don't want to see anyone excluded. Anybody who wants to be a part of this cohort should be a part of this cohort. I think it's going to be imperative. I think I told you I moved 13 times, and I said a lot of that, my medical health records are paper. I lived all over the country, and some of these places, I don't even remember who my provider was. So that's really, really, I think over the last 20 years, I could probably go back, but I'm 65 years old now. Forget those previous years, but the last 20 years, I could probably get my medical health records. Some of it's going to be paper, and some of it is going, and I think you're going to find in the rural communities, it's going to be paper records. They haven't gotten into the electronic records in some communities because the communities are so small. So we need to really think of how we're going to use, be creative, and how we're going to be able to include these people in this cohort without electronic health records. And it might be easy to convert those, but we need to think of how we're going to do that. But I think it's going to be imperative, and I think you can be real targeted too. Say, we would like to go to this particular community because this is a very underserved community, and there may not be medical electronic health records but let's see how we can work with this community, because you want to be able to get people from all walks of life, not just the urban areas, but in the inner city, but really go out into communities that are really having some severe. And you have you can go to the cancer registry and see where the disparities are and see where the tumor burden is, and look at those communities and being more targeted maybe in the areas for recruitment into the cohort.
Okay. Esteban and then Pearl, and then to the floor.
Hi, Esteban Burchard. Thank you, Dr. Branch. That was
I'm
informative.
not a doctor.
Dr. Cole, too. What you said was informative. One of the questions I have, and I've thought a lot about this, in 1993 we had the congressional mandate requiring inclusion of women and minorities. You've thought a lot about it. We haven't made a lot of progress since 2015. We're still talking about it. So an honest assessment, what do you think what has prevented us from achieving our goal of inclusion and maintaining folks in the cohort? Because we've been talking about it for a long time.
I think some of that has to do with, yes, you haven't been able to maintain the cohort. Are you saying that?
Almost everything you said is exactly spot on and right on, and it seems pretty simple to implement. And I'm asking you, for your opinion and Dr. Cole's opinion, why haven't we done it so far? And we're still talking about it. It's been more than 20 years since Congress required the passage of the law to include minorities.
Mm-hmm.
So, Vernell, let me just take a stab at it. And this, of course, is an opinion. But let me offer the following. I had a really interesting conversation with our colleague Carol Horowitz on the ride over from the hotel this morning. And we got into a conversation about race being a social construct. But, of course, genetics and genomics are not. They're scientific constructs. But we conflate those two all the time and get worried about both the collection of data, the interpretation of data, and the application of data. So there are some intangibles, if you will, that do stand in the way of scientific progress in this particular area. And one of the questions that I've got in my own mind as we advance our work here is how do we break down some of those connections that are just conflated connections between race and genetics and genomics as scientific tools and disaggregate them so that we can, as scientists and participants, look at them objectively. So that's just a conversation that I think we should have, because no legislation, I'm reminded of my university days, legislation, you can't legislate folkways. So no legislation, if you will, is actually going to help break down the barriers and disaggregate that particular conversation. That's got to be some of the work that we do here. I want to take some more questions, so let's go to Pearl and then we'll go to the floor.
Hi. Thanks, Pearl O'Rourke here.
Hi.
Thanks so much for your time and your talk. I am interested if you have any suggestions for us to consider regarding how do we reach out to the communities that don't think they have a disease. I mean, there's an automatic community if you're going after, such as breast cancer or Sisters of Breast Cancer, but we really need those resilient people. In terms of the messaging, I think for you and for also subsequent speakers, it would be very helpful to know what's generalizable to those who are not quite yet diagnosed.
You know, I speak to a lot of groups, and especially doing breast cancer awareness, but a lot of them don't understand genetics. And so I said, we're all living with cancer. You know, it exists within our bodies already. But what they don't understand is how the disease progresses and eventually turns into cancer. And so it's a lack of understanding, a lack of education, and that's where we need to do better at educating the general public, because I think that when they understand that we're all going to get some type of disease during our lifetime, and cancer is the fastest growing. I heard a statistic the other day that in Virginia, where I live, cancer is the #1 killer right now. It has surpassed heart disease. And our legislative body has decided that they need to do something about this. I'm going, oh, really? and they haven't really concentrated on this. And so now they really want to look at how can we educate the general public out there about healthy lifestyles, prevention, and screening programs. And a lot of people don't take advantage of the screening programs. For colonoscopies, lung cancer, and we just need to do a better job of talking about how prevention and healthy lifestyles and how can we prevent certain diseases. I don't think we've done a real good job of that.
I want to get in as many questions as we can. Let's go to the floor, Mike, and then we'll come back to this side.
Thank you. I'm Dr. Darrell Roberts. I'm a researcher with Battelle Memorial Institute, and I had conducted research several years ago with some of the most underserved populations in Baltimore City, children living in some of the worst neighborhoods, trying to look at whether asthma predicts apnea, apnea predicts asthma. The hardest part we had was getting the message out to those communities that don't have telephones, don't really have that much access to the broader community of research. I ended up going door to door in some of these very poor neighborhoods and saying, I'm a scientist, you have children, I know that there are problems. Can you help me, through a snowball technique, get to the people that need this research? We ended up recruiting about 78 children to this study, and it had great future to it, but because of the limitations and access to the community, we just couldn't go any further than the R21 grant that we've fulfilled with this. How can we use what you're promoting to increase the availability of information to this community so that we can conduct these studies that will be important to identifying problems in this population that allows them to grow healthy, normal lives?
Well, when you conduct the research, there need to be solutions to help those families. I find that a lot of times when people, they are doing the research, but then there needs to be some really positive outcomes. How can we reduce, the burden of disease? So there need to be, so if you're going to do the research and gather information and data, then offer some concrete solutions to really reducing the burden that they're going through, specifically in asthma. There are some things that could be done to reduce the burden and the triggers that cause the asthma attacks. So, there need to be concrete solutions if you're going to do the research itself.
We're going to take a question here from the floor.
Can I respond to that on the...
Sure.
Esteban Burchard, I'm responding in my role on study sections. One of the criteria that we as study sections should enforce, and we don't, and I'm responsible as well, is that we don't look at the ability of the investigators and their track record of recruiting. And so oftentimes there's a disconnect in the ability to do high and complex statistical analysis on genetics of complex populations and an ability to recruit, and they often don't go hand in hand. And I'm going to suggest to study sections that we actually hold people to their feet to the fire on that, that if someone is asking to study and get money to reach out to communities, that they have the ability and track record to do so.
Okay. I do want to come back to that point throughout the day. So let's take a question here, because that's a really critical point, because after all, this is about practical solutions and what we do differently. So question here.
Question and comment, if I may. I'm Jamie Roberts. I'm with the Clinical Trials Transformation Initiative at Duke University. Bray is one of my colleagues and invited me here, and I'm very excited to be here, and I loved hearing your discussion and talk. I want to address also the study section thing, because I'm formerly of NINDS, and as one of the people at NINDS at the time charged with monitoring recruitment to our studies, I asked for that very thing to be challenged in CSR all the time. And I was essentially told that we don't want to give them any other reason not to fund us. So that, and that was...
Could you elaborate on that?
Sure. So when I brought it up to my colleagues when we were rewriting the RFAs as they expired, and I suggested that we needed to have a much more stringent review of an investigator's ability to recruit, based on past performance and future performance and any formative research that they had done in terms of their ability to select sites appropriately based on their ability to recruit. The response I received was, we don't want to give them any other reason not to fund the studies that we're bringing in. So I really appreciate that comment, and now that I'm no longer a member of NINDS, I feel a little freer saying that. But that is some of the response from I think, probably not just NINDS.
That is a dark open door in our system, that we actually don't have an enforcement policy on that.
Well, let's take that one up. We're going to take one more question, if we can, because Bray's looking at me, and you want us to end the session right on time. Despite the great conversation. Susan gets the last question, and I'm going to do a very quick wrap-up summary.
I was really responding to, I'm responding to something said earlier, but I think if you're going to get people to participate, you've got to also, it's not a we-them, so you have to ask them what questions they'd like to see answered. And have them be part of directing what research is going to be done. Because if you're doing research that they find interesting and useful, then they're much more likely to participate than if it's something that researchers have thought of to do, when it comes down. So it's not just bringing everybody together, but it's actually asking the community what questions they feel are needed to be answered. And the second point is that healthy people are very, I think you have to go through women. I'm a little biased, but women control all the health. They control the men, they control their kids, and they control themselves. And so if you recruit through the women, you can actually probably get the whole family. But if you aim it at trying to get the men, they're not going to pay attention.
Thank you. Thank you for that last comment. So now just a quick wrap to at least what I've heard in this particular session. 4 specific things for us to consider. If we take our cue from what's happening in the national conversations around police reform and criminal justice reform, having the tough conversations about why we have these particular sets of issues is really going to be important, recognizing what we said about legislating folkways. Number 1, building trust in the community. And Vernell has given us some practical ways to do this. There is a history, if you will, in the communities of color of mistrust for very good reason in the clinical trial and the cohort area, and we have to confront that. Number 2, translation of what it is that we're absolutely trying to do to ensure that we are speaking in a way such that we capture the imagination, the attention, and the shared enthusiasm for the project. Number 3, education for all, and I do mean for all, but that's bidirectional. So our education of individuals, and to Susan's last comment, their education of us in terms of what it is that they'd like us to see. And then finally, the build of the infrastructure. Esteban and our colleague here started a very interesting conversation around the infrastructure challenges that we have, and I think they deserve closer inspection. Vernell, thank you very much for your participation, and thank you. I'm now going to introduce Kathy Hudson, who is the Deputy Director and one of the co-chairs for the ACD PMI WG.
Good morning. I'm pleased to moderate this session where we're going to hear 2 presentations about input that we have received that's very relevant to today's discussion. So I want to talk a little bit about what we already know about participant perspectives before I turn to them. So as Francis mentioned, this idea of a large national cohort to understand genetic, environmental, and behavioral contributions to health and disease is not a new idea. And back in 2004, he proposed this idea. And following that proposal, there was a serious consideration of the issues surrounding the challenges and opportunities to put together a cohort by the Secretary's Advisory Committee on Genetics, Health, and Society. And that was in 2007. So we have many years of experience in thinking through these issues. The Secretary's Advisory Committee made a couple of recommendations specifically about public engagement that I thought would be interesting to review after all these years have passed. Specifically, they recommended that before embarking on a large population study, that we should assess the public's willingness to participate in such an extensive endeavor, and further that the Secretary should ensure that public engagement occurs throughout all aspects and stages of the research process, from conceptualization through design, planning, implementation, conduct, data analysis, and reporting. So this notion of having participants deeply engaged in the planning and implementation and governance has really been with us from the beginning. Back when the idea was originally proposed by the Genome Institute, there was funding that was provided, and I think it will be interesting to come back and have some conversations about what kind of funding do we want to have on going through the cohort to look at public engagement, social science, behavioral, legal issues, and the like. But back then, there was funding provided by the Genome Institute specifically to look at public attitudes about participation in a large national cohort. And specifically in 2006 to 2008, there was quite an extensive body of work that was done both qualitatively and quantitatively to understand attitudes. That was phase 2 of that was done between 2010 and 2013. And much of that work has been published and is available for your consideration. We can post that on the PMI website. In addition, there was work done specifically to look at veterans' attitudes, and that was important in forming the basis for the consent and the agreements between the Veterans Administration and their Million Veterans Project. So there's an extensive body of work that we can now sort of bring forward into 2015 and think about how have things changed since this initial groundwork research was undertaken, and how can that inform our strategies in moving forward. So we're going to have 2 speakers in this session. First, we're going to hear from Vince Bonham from the National Human Genome Research Institute, who's going to talk about what we heard from the community in response to a request for information that was recently posted and closed, specifically asking questions about strategies to address community engagement and health disparities. And then we're going to hear from Dave Kaufman, also from the National Human Genome Research Institute, who's going to present a very interesting results from a national survey that we conducted through the Foundation for the National Institutes of Health of a representative sample of Americans, asking them what their views are about how exciting a cohort will be, and their willingness to participate in such a cohort, and their concerns about that. So I'm going to start with Vince, who is right here, and then we'll turn to Dave, and then we'll have an interesting conversation. Vince.
So good morning. On behalf of the Health Disparities and Community Engagement team, I'm pleased to present to you today the responses that we received from the public with regards to the 2 areas that Dr. Hudson identified. One related to what are potential strategies that we can use to increase the diversity of the cohort. And second, what are the transformative opportunities to use the national cohort to understand, address health disparities. So the request for information went up on May 30th and closed 3 weeks later. We received 69 responses that were substantive from 23 different states and 44 different cities, as well as 2 international responses and 6 that are unknown. And so you see here there was a diversity of the areas of the country that we received responses from, which included researchers, general public, and a variety of different individuals within the general public across our country. I'm going to start by focusing in on issues that we were provided information about community engagement strategies to increase the diversity of the national cohort. And we had 5 questions that we focused on. One was factors and incentives for participation in the national cohort. The second, community engagement and strategies and partnership opportunities with the national cohort. Barriers to participation in the national cohort and strategies to address those barriers, and ways to avoid stigmatization of populations with the national cohort, and safeguards to assure net positive potential of the Precision Medicine Initiative and the national cohort participation. There were a number of common themes that were identified, and the members of our team went through and read each of the responses, 2 individuals reviewing each to identify common themes, and then each group came together to explore and to make a consensus of what were the common themes that we saw related to the responses. With regards to community engagement strategies, we identified 9 common themes that we will present to you today. First, and you've already been hearing this morning, which is interesting. You're going to see, I think, here throughout the day, a number of the same themes. And again, that question is, how do we take that and really make strategies to address those issues? Meaningful engagement of communities and continuous communication, transparency, partnership, privacy protections, education. And again, this is both education of the public as well as healthcare providers. Removal of barriers of participation, strategies for that, active governance and oversight, and trust and trustworthiness. So I'm going to go through and identify a few themes where I want to focus a little bit more depth and provide you actual quotes from respondents. And these quotes are examples that are really reflective of things that we heard from a number of the respondents, but I've identified a few as illustrative of the theme. And first, related to engagement. Meaningful involvement of community members from a very early stage in the development of aims, procedures, analysis, communication of results. Communication. The major component of reassurance of the positive benefits of this will be constant communication, including listening, education, and dialogue involving people are respected and trusted by the community. Transparency. This project must operate with the highest level of transparency possible, including frequent project updates to key stakeholders. And partnership. Build national and local action boards who will partner equitably with researchers. This issue of community boards came up time and again in the responses that we received, that there needs to be a structure in place to provide for continuing community engagement. One of the quotes that we articulated about the issues of benefit, making sure that the benefits of participation in the national cohort are articulated to communities. For people from historically underserved communities to participate, this must be relevant to their lives. The only way for that to be true is participation to be authentically initiated, designed, conducted, analyzed, and communicated within the communities with members of the community as true leaders and facilitators. You see these common themes here that are related to participation and governance. Other strategies to address barriers to participation included the issue of education. Ensure materials are available, low literacy in multiple languages and multiple mediums. Develop additional strategies to educate and engage non-English speaking participants and those of low general literacy. So this issue of how do you communicate information, it should not be one size that fits all, but a variety of different ways to reach different types of communities. There will be variation among communities in terms of existence of electronic medical records and access to various models of mobile phone technology. Consider alternate methods for patient entered data. Again, following up on this question about in certain rural communities, certain types of communities, will they have the same access to the mHealth technologies or the types of electronic records that may be in the larger healthcare systems? And so the question is, how do we make sure that it's available for everyone? And then ensuring that structural factors such as coverage for transportation, cost, and childcare are covered by the research study could be a mechanism to facilitate participation in research. That there are structural barriers, particularly for those of lower income and from some communities in participation, and what are the strategies that we'll put into place to make sure that they can participate in the national cohort. So It's been talked about already for this first hour this morning. It was a major theme. I would say it was the major theme of the 69 responses that we received, is this issue of trust and trustworthiness of researchers and of the National Cohort Administration. Trust is particularly critical given the unfortunate legacy within medical research where participant rights have been not equally protected. Trust requires time and effort to develop, but is easily lost. And I really want to focus in, as we saw this quote, I particularly was interested in this last statement that trust is easily lost, and highlighting that as one of the themes that was identified from the respondents. So now I'm going to shift and focus on what was identified as research opportunities to address our understanding of health disparities received from the information from the respondents. And here we also had 5 questions that we asked respondents to provide information for NIH. One was regarding priority health disparities research questions to be addressed by the National Cohort and the Precision Medicine Initiative, opportunities to study various types of determinants of health with the cohort, and obtaining new scientific knowledge. What are different types of knowledge potentially that could be received that would be valuable in understanding disparities, and novel methods for gathering data on health disparities, and finally, novel ways to assess health disparities data, ways to analyze the data that we may not be doing on a regular basis today. Again, we had a number of common themes, and these themes were related to the types of studies and opportunities that may be available uniquely or that the cohort could actually move forward. And so there's a number of areas here where there were research opportunities that were identified. And I'm not going to go through and read them all, but you see here that there was different areas of the types of science that could actually be conducted with the national cohort that may help us better understand and address health disparities within our country. So I will again focus in on several themes with more depth and with quotes from the respondents. First, multidisciplinary studies. Study the multiple determinants of health and their interactions, personal, social, economic, environmental factors on disease risk, disease mechanism, and individual responses to therapy. Social and behavioral studies. Critical to include careful, valid, and robust measures of social factors across the life course, including socioeconomic, psychosocial, and environmental conditions. Genomic studies. What are the genetic and environmental factors across the lifespan that influence the development of disparities in risk and incidence or progression of hypertension, chronic kidney disease, and other chronic diseases? And health literacy, which was an interesting area with regards to research opportunities. What new literacy approaches will be necessary to ensure that patients and families understand precision medicine? Will these vary within subpopulations? So other research opportunities that were identified and explored in a number of the themes included the importance that this national cohort have the ability to study differences based on sex and race and ethnicity as key elements when developing research questions. And I want to highlight, we received a number of comments about the extreme importance that the cohort be designed in a way that we can look at sex differences and conduct research to understand sex differences in health. And that was identified by a number of the respondents. The issue of the Precision Medicine Initiative being able to be an opportunity to be a laboratory of research on how to best recruit and sustain the participation of individuals was identified. The Precision Medicine Initiative cohort provides an opportunity to identify and test strategies to overcome study participation barriers. And finally, that the cohort provides an opportunity to examine the neighborhood factors that contribute to health disparities. The neighborhood factors meaning social and environmental factors of where people live and how that influences health and disease, and how does that connect with the other information that's collected with the national cohort. So as a final quote with regards to the research opportunities with the national cohort to address and understand disparities, I will leave you with this. Adopt a multi-level systems approach when analyzing the PMI data in order to fully understand the root causes of inequities and the interactions between those causes. Further PMI data could be aligned with other data sets, including public health data, community health needs assessment, and electronic health record data to create an even fuller picture of the systems that give rise to and perpetuate health inequities. So, I want to leave you with 6 take-home messages that we identified from the review of the responses. First, build trust. Genuine community engagement is necessary throughout the design, development, and implementation. Transparency. Communication is critical for a sustainable cohort. Transparency came up within the comments in a number of different ways of this importance of making sure that the participants understand the process and how this cohort is operating and what kind of research is being conducted and returning information to the individuals. So the issue of transparency was a major theme. Benefit of participation. It's important of communicating the benefits, information coming back to the participants is very important. Partnership, formal and informal ongoing community engagement with communities. Again, this issue of governing structure, community boards was a theme that we received within the responses. And communities are diverse. They're not monolithic. Partner early and equitably with communities, but recognize that each community is different and how we engage and recruit individuals in different communities may be different, and that is important to recognize. And finally, with regards to cohort design, incorporate within the cohort design the ability to investigate multiple determinants of health. So not just look at one type of determinant, but to explore them together, and the richness of the cohort is the ability to do that. I want to acknowledge my colleagues, the team that has been working over the summer very hard and moving very quickly that helped to develop this RFI that was presented on May 30th to the public, and over the last week have analyzed this data to help to identify these themes. These individuals are from various institutes here at NIH, and it's been an honor to present on behalf of them today. But I don't want to close without thanking those individuals that took the time and provided detailed responses to 10 different questions that to help us as we move forward in developing this national cohort. And so I want to acknowledge and thank the respondents, and I believe that the ACD working group will have some very rich data from the RFI that will be helpful as we move forward in designing the national cohort. Thank you.
Thanks, Vince. So I think we'll hold questions till the end. We're running a little bit behind. I want to bring up Dave Kaufman now, who's going to present the very new results from our national survey supported by the Foundation for the NIH.
Thanks, Kathy. It's really an honor to be able to present these data to you that are the work of several people on the PMI team. So let's get started. We wanted to do a nationwide survey of adults to get a handle on sort of how people feel generally about the idea of this cohort, whether or not they'd be willing to participate, some of their feelings about the cohort, and asking about some examples of study design. And so the Foundation for NIH was a fantastic partner and initiated this survey and was generous enough to share the data with us to present to you. So the survey was administered online by the company GFK. I can tell you more if you're interested about their sampling strategy and why we chose them. Basically, they get us a pretty nice representative sample of people to talk to. The survey was in the field very recently, so the data are only a couple of weeks old. We fielded the survey in both Spanish and English and oversampled both black non-Hispanics and Hispanic participants. And we wound up with 2,600 U.S. adults who participated. Median time to complete the survey was 21 minutes, and we got a respectable response rate of 57%. So I don't want to spend a ton of time on this slide, but I wanted to give you a little bit of a flavor for the demographics of who participated. Here is our survey participants and compared to the U.S. Census in 2010. And you can see with respect to gender, we did well. Here you see the difference in our oversample and the U.S. Census. The sample was a bit older than the United States generally. And particularly, we should note that people in the lowest income bracket and people with less than 12 years of education were underrepresented. And so we need to think about those things as we look at some of the data. And to deal with some of these differences, when I tell you that the nation said this or the nation said that, we use a statistical technique called weighting to try and get the numbers to be sort of closer to what the U.S. population looks like. And I definitely won't tell you more about that because I want you to stay awake. Okay, so we showed people a short description of the study that we tried to make as unbiased as possible, and then asked them, based on the description, do you think the study should be done? 79% said they felt it definitely or probably should be done. And looking at the responses to that question across demographic groups, the first thing I think to see on this slide is that support is fairly uniform across all these demographic groups. We do see that support increases with education. Oh, and these little red asterisks represent statistical significance in a multivariate regression. So we're controlling for all the different variables you see here. And so in a regression model, we see that increased education increases support. The people in the lowest income category had significantly lower support for the study, and people in urban areas were more supportive in general. Why do people support the study? We fed them a couple of reasons. 80% agreed that the work is important to do, and 86% agreed that with sort of the goal of the study could be reached to lead to improved health care. So people support the study, but would they take part? Again, based on the description, would you take part if you were asked? 54% of people said they definitely or probably would take part. 16% said they definitely would not. And again, looking at the answers to that question across demographic groups, we see that Hispanics, well, again, we see sort of not uniform, but completely uniform, but fairly uniform across willingness across demographic groups, and this is both definitely and probably would participate. We see that Hispanics were significantly more likely to say they would participate if asked, and within Hispanics, the people who took the survey in Spanish, there were 255 of them, were also more likely to participate. Again, the trend with education, more likely to participate. And here's something that we've not seen before. As people, the older participants, significantly less likely to participate as well. And just before I go on, as we sort of think about the talks we've heard already, it's, I'm not naive enough to think that just because people say they're willing to do something means that they're going to do it. Obviously bridges need to be built, and those bridges need to be built by us. Boots need to be on the ground. But I think what this shows us is that the notion that any particular group of people simply won't participate, is not willing, is incorrect. So why would people take part in the study? What's their motivation? 82% of people said it would be interesting to receive the results of the study. And 62% said they would take part to help advance health research, altruism. And the one thing to note here is that there's a 20% difference in those two things. So 1 in 5 people are interested in the results, but not so much altruistic. And so it just brings to the fore what we've heard from Vince that and Vernell that bringing information back to people is going to be very important. And we see that here. we asked how important the following incentives would be to people. Number one, learning information about my health. 90% of people said that was somewhat or very important. More important than receiving payment for their time. More important than getting health care while participating in the study. And more important than getting free internet, a free Fitbit, or a free smartphone. So getting information, important. What kinds of information are people particularly interested in? Lab results. We told people we suggested cholesterol and blood sugar measurements. Lab results, equally interesting as genetic results. And people are interested in other things, ancestry, their medical record, water and air quality, and I think importantly, information about other research studies related to my health, which is something that Dr. Collins sort of raises another potential benefit of routing people into other studies. So some people are willing to do the study. What exactly are they willing to do? We asked people how long they would be willing to take part in the study if they actually joined it, and 41% said, I'm not going to join it, but 25%, 1 in 4, said that they would stay in for 10 years or more. And 36% said 5 years or more. So I thought that was pretty good. I mean, what do I know? But what kinds of we're asking? We'd like to ask people for all sorts of different things. What would they do? 75 to 85% of people said they would give all these different kinds of information to us. 73% said they would give a blood sample to us, and I don't quite understand this one. 45% said they would share their social media information, much lower than all these, and mystifies me because I don't know that much about social media, but my understanding is some of it is already shared. So we'll have to dig into that a little bit. We've heard that there's a lot of interest in sort of mobile data collection. 82%, I think, of people had either a cell phone or a smartphone in our sample, and so we asked those people how often they'd be willing to answer a text or a prompt on their phone to answer questions from the study. And 60% of people said that they would do this at least once a day, which I was astounded at because I am in this category, never. So I thought that was pretty amazing because I can't figure out how to respond to anything on my phone. So we asked a little bit about consent and data sharing. We did a bit of a little experiment here where half of the people in the survey were randomized to see one of 4 different consent models. We showed them either a short description of broad consent, of a study-by-study consent, consent for each use of the data, a menu where you could choose what categories of disease you'd support at the beginning of the study, or a dynamic consent model where you could sort of use a website to go in at any time during the study and change your preferences. And we asked if people would consent to share their samples and information under those models. And you can see here that study-by-study, menu, and dynamic both enjoyed about the same level of support, and that broad consent was this difference is, I'm pretty sure, significant, but about 8% lower. So I said we showed these things to half the people. The other half of the people we showed the same scenarios to, but we added a statement that said there's also going to be a website that you can go to see exactly what the study is doing. So, and that was with your samples and data. And so just a little bit of added transparency. With the transparency, no differences. So broad consent is sort of raised up to the level of the other models. So transparency is going to be important and gets you a little bit, especially if you need to do broad consent. And I'm not saying we will or won't do broad consent, but these are again just thought experiments. So we asked people who they'd be willing to share their data with, and researchers at the NIH fared nicely. 79% said they would do that, compared to 44% who would share with other government researchers. And we should acknowledge that this category is extremely vague and extremely broad, and we're sure that if we had named particular branches or institutes, we would see different things. Academics in the U.S., 71%, 52% would share with, this is a U.S. Industry, so half would share with industry. And we've seen this time and time again, the lowest category sharing with academics abroad. That's an issue that we're going to have to look at. And just one quick thing before, I'm NIH researcher, patting myself on the back, very happy. Before we get too excited about this, I think the thing we need to realize is that people are putting maybe more faith in NIH researchers. That mostly means that people have higher expectations for us, and that we're going to need to meet those. So, we can't rest on any laurels if there are any to rest on. We also asked people if they'd be willing to share their information, research results on the internet to anyone if their personal information was removed first. 43% of people said that they would do that. So finally, just a little bit about participation and about privacy. 71% agreed that research participants and researchers should be equal partners in the study. And we asked people a little bit about particular areas where participants might be able to engage. And the top three things that people thought participants should be involved in were sort of governance-oriented, helping decide what kinds of research are appropriate, what to do with the study results, and I think this sort of includes shortening the feedback loop and making sure that results come out faster and are more people are able to sort of see them, and helping choose what research questions to answer. And there was interest in these other things, but a little bit less interest in sort of the nuts and bolts, designing the study, recruitment and analysis, all the stuff that, yeah. And then we also asked people what they themselves would want to do, and we see the same thing. 35 to 45% of people said they'd be interested in participating in those sort of aspects of governance, and still reasonable significant numbers would be interested in participating in these other aspects as well. Finally, a little bit about privacy. We asked people about several design concerns, and I'm not going to talk about all of these, just to point out that the most important concern to people, somewhat or very important, that researchers keep my information private. 92% of people, and you can see that was very, very important to most people. We asked a few more questions about privacy. 2/3 of people agreed that the study can't guarantee my privacy. I mean, we're all sort of aware of, everyone sees all these things in the news and knows that there are no guarantees. But 76% felt confident the researchers who use this data and samples would do everything they can to keep people's information confidential. And so we're getting the benefit of the doubt. We can't abuse that, but people trust us to try and do the right thing. And finally, at the end of the survey, we asked again, now that we've needled you with all these questions, now would you participate in the study? And the response rates were fairly similar. 56%. Slightly higher said they would definitely or probably do it, although 19% said definitely not. And the interesting thing here is that 30% of people, shifted their category one way or the other. 15% of people were slightly more interested in doing it, and 15% were actually less interested in doing it. And I think the take home there is that when you have people sort of think about the nuances of participating and some of the risks and the benefits, it helps inform people's decisions. So just in conclusion, again, these hypothetical scenarios, and so these absolute numbers are not absolute truths, but we see that majorities seem to support the idea of doing this work. That willingness to participate seems relatively broad. That lower SES and older populations, as well as other groups, may need special attention and engagement. That we need to give health information back. That broad consent seems as acceptable as other models if you're being transparent. That there's enthusiasm for participant involvement, especially in governance aspects of the study. Privacy protection is going to be critical to people. And we think that engagement and information is going to help people make informed decisions about whether or not they're going to take part. Oh, and thank you to all of my colleagues and coworkers, and of course the survey participants, without whom this would be very boring.
and Vince join us up here. And we have we're going to go until 5 after 10, and then we're going to have a 15-minute break. So we have an opportunity to take a couple of questions. And we have one question that came in via Twitter, which I'll pose to you, Dave, which is why didn't we include a category of LGBT in our survey? And I don't know the answer to that, and I was involved in the survey, so I'd be interested in your thoughts. It's the face. There you go.
We blew it.
Yeah, we blew it.
Yeah.
Tony.
This question is for Dave. Dave, your very last question about willingness to participate in a cohort study, if you broke that down by demographics, did you see any significant differences generally and specifically by race?
Tony, I don't know the answer. I'm expecting that it's reasonably similar to when we asked it at the beginning of the survey. I will look at it as soon as I sit down and let you know. If I had to guess, but I shouldn't. I'm guessing there's probably not huge differences or the same ones that we saw, but I will certainly let you know.
If you could, that'd be great, because I did notice there were some shifts in terms of the before and the after.
Yep.
Yeah. You know, the difference that I thought was particularly interesting was the one with the Spanish-speaking respondents, which I'm intrigued by. The other thing I want to say to both Vince and Dave is they had these data for a very small amount of time, and they were very generous in sharing them. And particularly Dave, we probably blew our chances to get a good publication by sharing it all with you now. But that's sort of in the spirit, I think, of the cohort. So let me go from here to here and then back again, and then I'll go to Shariki. Can you say who you are?
Consuelo Wilkins with Vanderbilt University and Meharry Medical College. So I applaud you for the RFI and the opportunity to get input on community engagement. I realize that typically the RFIs are out a month or so. I think the information that you received is very rich and accurate, but perhaps there are a number of us in the room and certainly outside the room who could have told you all of those things, as well as pointed you to places in the literature to find that information. I say that because I think if we're really looking for innovation and opportunities to do this differently, we need to ask people who probably wouldn't respond to the RFI. So how are you going to get that input from people who might not have even received or have known about the RFI? I think those people who are doing really good work, engaging some of the underrepresented groups, are the ones that we need to hear their voices.
No, I would agree with your comment that there needs to be what I would describe as really grassroots engagement and conversations with the public about their perceptions. And I know that there are conversations of those types of activities going on over the next few months involving various parts of the government.
Yeah, and when this notion of a national cohort was first, and I showed you all of the different kinds of engagement, we did focus groups and town halls and community leader discussions across the country, and I think we probably need to repeat and expand that kind of grassroots engagement. Over here.
Nancy Roach, Fight Colorectal Cancer. And I had a couple of comments, not really questions. First of all, on the slide where you asked people how they'd like to help, you said help decide what to do with the information, and you couch that in terms of dissemination. But also, participants bring a very different perspective to the analysis and the writing of the information. So I would encourage you guys to all think about that. The second thing is, in terms of community engagement, science is so siloed off from most people right now. I mean, the average person, when I say I went to see a lab, they go, what does that look like? What does that mean? And I think the reason, there are a lot of different reasons for the silos, but if you want to break down those silos, you need to invite people in and actually listen to them and invest your time in hearing what they say, because until you listen to them, they're not going to engage. And I think that's very important, and I know you all know that, but doing that is hard and uncomfortable. And I don't see it happen very often.
Thank you for those comments. Shariki, why don't we go to you, and then we'll go here and here.
Thank you. Shariki Kumanyika, University of Pennsylvania. I think this is a question for you, Vince. The themes that you pulled out struck me as more prevention and population-oriented, expectations that root causes will be identified, that environmental risks will come up forward, whereas the other image is almost like PMI is having an identity crisis, because the other image is very specifically magic bullet treatment. And I wondered if you could comment on what that expectation that came out in your data actually mean for PMI.
So, and actually that was kind of directly addressed with some of the respondents, that you need to make sure that the cohort is both exploring genomic and pharmacogenomics, but understanding the context of lives and health. So one of the issues that was a clear theme was that the cohort should be designed in a way so you can do both things, so that you can study the social and environmental context of health and differences that we see in our country. And so that we have this opportunity. And so that was kind of a message that was there, is to make sure that it's designed in a way that you can do both things.
We're going to do lightning round because we have 4 minutes and 4 questions. So quick
Paul
question.
Kimmel, NIDDK. Question to Dave. To do good genetic environmental studies, we might have to use gizmos that sense the environment. Do you have any data from the survey regarding privacy concerns and information, repositing regarding whether these gizmos would be acceptable and subgroup of responses?
I think our data is not the end-all and be-all on this, but we did ask how concerned people are about privacy of different things, their medical, financial, genetic information, and information off their mobile devices and Fitbits. And concern is very high for privacy in general, but people's concern for mobile data and Fitbit data was about the same as for genetic data. I think about 75% of people said, I have some concern about it. So, it's, again, we're getting the benefit of the doubt, and we're going to have to show people that we deserve it. And I think, that's a new thing, and we'll have to, really pay attention to it.
Over here.
Hi, just a couple of comments. I'm Donna Antoine Levine from Jackson State University, Jackson Heart Study. And what I would like to suggest is that the funding agencies allow for community engagement to really take place. Oftentimes, we're given a timeline that is unreasonable based on community time. They're not on our time. When we go to them, we're on their time. And it takes time to penetrate churches. Churches are a political system. You have to penetrate that church. Organizations, you have to be able to get into the organizations. We've been very fortunate over the years. We've built a sustained, long-lasting, trusting relationship that has been challenged at times, but we seem to be doing okay. Also, I'd like to say that when we look at funding, that we look at CBOs that have longevity and have community roots and allow them fiscal opportunities also. They're always at the mercy of our universities or other academic or medical institutions, and they never get the dollars that they need to do what you want them to do in the community. So I urge, those in control of the dollars to seriously consider funding CBOs to manage something on their own, because they can get to folks quicker than we can. And that's it.
Thank you very much.
Jim Perrin, American Academy of Pediatrics. Just wondering if you queried anything about adolescents, diverse community adolescents, adolescents with or without chronic diseases. By the way, they are often willing to share very interesting mHealth data.
So one of the interesting things about this, the way in which we fielded the survey, is that it is a very large panel of people, and we surveyed a subset of them. As a consequence, all of the demographic information, and actually a really rich body of information about those people, has already been collected in advance. And so we don't need to waste their time or the time of the survey, the 21 minutes, re-asking questions. And that's actually germane, I think, to the LGBT question that Dave's had a minute to think about. So Dave, do you want to respond to that, sort of both
Sure.
the
So
adolescence question
we
and
didn't
LGBT?
ask specifically about adolescents. We asked about 4 questions about children in general, and my mind is a sieve, and so I don't have the numbers in my head, but I'll be happy to tell you what they said. With respect to the LGBT, I think we may be able to go back to GFK and ask them for the data about whether our participants were LGBT or T. And if we can get that data, then we will certainly do the analysis. If we can't, then this isn't the last chance we have. And so if we can't do it now, we will do it in the future.
And then, Andy, you have the last question.
Andy Fawcett Geisinger. I kind of want to combine what Vince said and what Dave said in the sense that trust was a really important issue. Dave, in the survey, did you ask if these individuals had a medical home? Because I wonder if the data would be different if you surveyed those who had a medical home, so they had a trusting relationship with the healthcare system in general in some way, and would that skew the numbers at all?
Andy, it's a great question. We actually had it on the survey, and you know how these things go. You've got like 500 things, you only can ask 100, and it got left on the table. So again, it's something to follow up on, especially as we focus on what homes we'll be working from.
Because that's one of the things we consistently hear in our focus groups, and I think it's important as we design the study, because often research centers are kind of where you go when you have a critical issue, and they're not your medical home. And can we link those patients back to their medical home as we try to pull them into PMI, I think will be important.
Great. Thanks, Andy. So we are going to now take a break until 10:20. Please join me in thanking our panelists today.
So I'm Shariki Kumanyika, and I'm a member of the ACD PMI WG. We're all learning how to pronounce that. I think the purpose of this session is to really get more into the weeds of what the promise is of the PMI for answering questions related to health equity. I think we all feel in a very general and maybe still abstract sense that PMI won't be successful unless it advances our ability to address health disparities and achieve health equity. And so this panel is going to talk about what that might actually mean. We have three panelists, Dr. Sarah Gellert from the, I have a title here, E. Desmond Lee, Professor of Racial and Ethnic Diversity at Washington University in St. Louis, Brown School of Social Work. Dr. Rick Kittles, Professor of Surgery and Public Health and Associate Director of Cancer Disparities at the University of Arizona Cancer Center. And Dr. James Perrin, who's the immediate past president of the American Academy of Pediatrics and a professor of pediatrics at Harvard Medical School and the John C. Robinson Chair in Pediatrics, an associate chair at Mass General Hospital for Children. So what we're going to do is we're going to try to be as efficient as possible and ask each speaker to introduce him or herself in terms of perspective on this issue, and after those introductory comments, we will go around and talk about three specific questions that the panelists have been asked to address. They will speak from their places without slides, and we'll try to do this as quickly as possible while taking the time to frame some of these issues and stimulate your thoughts about them. And then we'll have 25 or 30 minutes for questions from the floor. So I'll start off with Dr. Gellert to introduce yourself and give your perspective.
Okay, as Shariki told you, I'm the E. Desmond Lee Professor of Racial and Ethnic Diversity at Washington University in St. Louis, and also serve on the Board of Scientific Counselors of the National Human Genome Research Institute. And I'm a social scientist by training, and my publications focus on social influences of biology and health outcomes, especially influences at the neighborhood and community levels of influence. So I was glad when Vince brought that up. I've worked in health disparities for about 20 years, and I was principal investigator of the Center for Interdisciplinary Health Disparities Research at the University of Chicago, which is one of the National Cancer Institute's Centers for Population Health and Health Disparities, before I moved to St. Louis. And my colleagues at the University of Chicago and I continue to study the determinants of the disproportionately high breast cancer mortality among African American women. And the breast oncologists on our team, which are Fumi Olopade and Suzanne Konzen, realized that even with optimal treatment for all, the disparity would decrease. but it wouldn't disappear due to social factors. So with others, investigators from the Centers for Population Health and Health Disparities, we developed a multi-level model of cancer disparities that includes 7 levels of influence, from the biological genetic to individual risk factors like smoking, to social relationships, to neighborhoods, factors like social cohesion in neighborhoods, to institutions of various types, to social conditions and policies at the societal level. They all impact health disparities. We found these levels interact in very complex ways across the life cycle. You may have seen an article in, excuse me, the New Plus One that links, reports a link between living in unsafe neighborhoods and shorter telomeres and increased risk of death. And this is the sort of area in which we're working. So the PMI has the promise of really extending research like this by bringing these factors together in the same research models with adequate sample sizes for subpopulations, which is what excites me most. And over time, I've become increasingly interested in poverty and cancer, and now work with the St. Louis Department of Health to design interventions for women living in 8 zip codes of North St. Louis that have the highest levels of poverty and the highest breast cancer mortality. And these women are important to mention, I think, because they lack stable sources of care. If they do have records, the records probably are with a federally qualified health clinic. They may be at several emergency departments. But these women tend not to have what you would really call fairly medical homes. And they also fail to have stable housing. They're not affiliated with organizations or with advocacy groups, and they live more marginally and are very difficult to reach. Yet I would love to have them involved in this initiative. And we can talk about ways of doing that. I just want to point out that they're not unique, that in the United States, well, in 2013, 45.3 million residents of the United States lived below the federal poverty line, which is $24,250 for a family of 4. And many of the people with whom we work would be happy to have that kind of income. So just really want to make a case for poverty in the PMI. Thank you.
Good morning. My name is Rick Kittles. I'm a professor in the Department of Surgery and Public Health at the University of Arizona in Tucson. My research focus has been on the genetics of complex diseases that disproportionately affect populations of African descent. Some may call that disparities research. And early on, it was focused mainly on genetics, but one of the things I've learned is that genes should be placed in context, and that context being the environment, be it physical or the social environment. So my focus mainly has been on cancer genetics, mainly prostate cancer, exploring gene-environment interactions. And since I focus on populations of African descent, like African Americans and Black Hispanic or Black Latino populations, one of the things that I've had to develop has been the use of genetic ancestry. And so myself and others in this room and outside of the room have been actively involved in trying to understand genetic ancestry and the role genetic ancestry plays in health, and in particular, health disparities. I had to sort of do that because studying African Americans, one quickly understands is that there's a lot of heterogeneity, a lot of stratification because of diverse genetic background and also environmental background. And so that was one of the sort of leading sort of reasons why I initially started to study that. Presently, I'm in the middle of a big oral one where we're looking at serum vitamin D levels and modifiers of vitamin D, be it biological and environmental modifiers of vitamin D and prostate cancer risk. This is a big prospective study of over 4,000 men in the Chicago land area. We have public and private hospitals where we're actively recruiting, and 60%, over 2/3 of the men are men of color, Black and Hispanic men. The great thing about this project is that it actually explores disparities as it relates to prostate cancer across issues of race and ethnicity, but also social strata with the public county hospital differences and the private institutions and VA participants. We are collecting genetic and biomarker data, also have access to the EMR data for the patients, and are exploring presently treatment modalities and outcomes. So I see this PMI as an enormous opportunity to further advance our understanding in terms of disparities, health disparities, which for the most part are socially determined, but there are some specific biological components for particular disparities that actually we should be able to address. And I'll talk more about that later.
Thanks. Nice to be here. I'm Jim Perrin. I'm immediate past president of the American Academy of Pediatrics, which is an organization of 64,000 pediatricians and pediatric subspecialists around the U.S. I'm also a professor of pediatrics and a researcher at the Mass General Hospital and Harvard Medical School. Much of my own work has been in the area of chronic disease epidemiology in children and the real changes in that epidemiology over the last 30 or 40 years' time, and the implications for both children and families and for public programs and policies in that area. I'm really obviously here partly to recommend the inclusion of women of childbearing age and children and adolescents in the PMI cohort. We think it's incredibly valuable to do that. We know so much more today than we did even a decade ago about early life influences and their dramatic impact on children's resilience, children's health and development over time, the critical importance, especially of the first 1,000 days of a child's life, with the 1,000 days beginning at conception. These are critically important times for children, and we know so much more about that. We also know more about the life course aspects of child health and development, and the fact that it's not a single spot in time, but rather an accumulation of events over time, positive and negative events that really do influence brain development, influence resistance and resilience, and related such things. We also know much more about increasing evidence of perinatal and early childhood antecedents of adult chronic health conditions, including heart disease, pulmonary disease, diabetes, cancer. Many of these do have important antecedents that we have initial understanding of, but frankly, having the PMI initiative would be extraordinarily valuable in bringing together a vaster array of data to help us deal with that. We have seen in this country, and really increasingly across the world, major growth in rates of chronic health conditions among America's children and adolescents. This has been predominantly among the big four, which are really asthma, obesity, children's mental health conditions, and neurodevelopmental conditions, including autism. We had a lot of growth up till about 1980 in survival of relatively rare chronic conditions like cystic fibrosis and so forth, but really since that time their rates have been pretty flat. But huge growth among these, and what we're seeing today in this country is that young people in their 20s and 30s are already suffering substantial health disabilities with limited employment, education, and quality of life. And we also know, not well enough, that disparate populations that are more disparate in our country have much higher rates of these conditions. We also understand that including children is not easy, that there are really important and complex issues about consenting children, getting the right kind of consent over time in developmentally appropriate ways. But I think it's important that we've had experience doing that in a number of important longitudinal cohorts, some respiratory asthma cohorts, probably more than any others. And there are some very good researchers who've done some super work in the area of community-based participatory research, which is including children in imaginative ways and getting the right kinds of consents. I think the point is it can be done. These are not insurmountable problems. They are really achievable problems. So why address disparities if we're talking about children and youth? Well, first of all, children and youth have more disparities in the sense of language, culture, race, ethnicity than any other age group in the United States. I might also say, in talking about M-Health, they also have more experience and competence in mobile technologies than any other U.S. age group. But I would think I'm going to end by just sharing a couple of clinical examples where we could do much better if we had high-quality research involving populations that are quite disparate. One is attention deficit hyperactivity disorder, one rather common condition among America's kids. One for which we have lots and lots of clinical trials about stimulant medications, and almost all of those trials have been done in middle-class white children. So in fact, I can't say as a clinician whether a stimulant medication that I prescribed for a child in Dorchester, Massachusetts, that comes from an African-American family that has limited resources is really going to be an effective treatment. I actually don't have the data to show that. Yet this is a common disorder for which we don't have adequate information. Another area which I've been particularly interested personally is the area of childhood autism, where we've seen a huge growth in autism and some very interesting data about whether that growth in autism, well, first of all, what is the cause of that growth in autism, and where the perinatal, especially aspects of that, are probably absolutely critical, and we desperately need much better data about perinatal experiences and exposures in that population. But the issues of disparities in the area of autism are also quite striking, because at this point in history, most of the evidence would say that there's a relatively broad-based rate of increase of autism among all classes and races and ethnicities in this country, with the potential exception of Latino kids. But we also know that services are available almost entirely to white kids, and that has really affected what we do in the sense of our understanding of this clinical disorder. So thanks very much.
To the panel for really getting us off to a great start at thinking about the kind of compelling issues that need to be addressed and that PMI could help with. I wanted to give each of you a chance to elaborate more if you have other examples on the issue of the types of major health disparities that could be studied perhaps only by the PMI cohort. You can ask, if you want to comment more generally on how PMI can do this at the same time, just so that we use our time efficiently, please go ahead. So I'll give each of you a few minutes, and I'll start with Dr. Kittles.
Well, a lot of disparities could be addressed, but I would focus my attention, though, I think, on the two major disparities in terms of mortality among underserved and communities of color. And so hypertension, obviously, cardiovascular disparities, and then also, of course, cancer disparities. So we think about something like hypertension, where we know the rates are much higher in African Americans. We know medication is one of the most effective ways to treat hypertension. Of course, ancestry and SES and diet, stress. But I think there's such a plethora of responses to hypertension medication that something like the PMI could really help to better understand what the most effective targeting and treatment would be. And so we wouldn't necessarily have to continue this trial and error and in terms of treatment. And this actually ties into pharmacogenetics, which we know there's enormous disparities for particular drug responses. So we know biology contributes to differences in drug response, and this would provide a good platform to really explore that. Another sort of cardiovascular disease would be like heart failure. And I think the BIDIL study or the BIDIL history of BIDIL in terms of targeted sort of therapies focused specifically for African Americans is an example sort of where ancestry is potentially playing a role in trying to understand what the important genotypes are for efficacy would be something that could be explored in the PMI.
You want to just explain what BIDIL is for people who might not have heard that particular story?
Well, I'm not a cardiovascular person, but
I mean, what the concept is that
right.
you're talking about.
But this
right?
is a drug for treatment of heart failure, and it was specifically approved for treatment in African Americans, and which is a very sort of broad macro ethnic group. And so, if you think about it, what does that mean in terms of targeting for a person who's considered African American? Is it self-report, or is there some kind of skin color measure, or is it some genetics? And so I think that it was one step in the direction in which we all want to go, which is more individualized or what we call precision health. But it was not the end. We needed to continue and go further to see what the important genotypes were. So we know that clinical trials, in particular for drugs, are underrepresented in terms of populations of color. And so this, once again, would provide an opportunity for some of that. You think about cancer, real quick. Yeah, maybe quick. Prostate cancer in particular. Not because I study it, because it's important. And the reason I say it's important, and actually it's sad when you think about it, African Americans disproportionately are impacted by prostate cancer in terms of incidence, mortality, and there hasn't been sort of a clear sort of concerted effort to really explore what the biology and environmental risk factors are. Out of all the disparities in terms of cancer disparities, prostate cancer probably has the strongest biological component to it in terms of accounting for that disparity between black, whites, and Asian descent populations. So I think that the PMI could be an opportunity to really explore if the recruitment or the engagement of African American men was sufficient to really explore this issue. Because if you think about the focus historically in terms of the genetics of prostate cancer, it's been mainly focused on white men. But the disease disproportionately impacts African Americans. And there's very little in terms of understanding why that is. And so this would be a perfect opportunity, given the recent work in the last 8 years where we see this strong genetic signal on chromosome 8q24. We see this strong association with genetic ancestry, West African genetic ancestry. We need to sort of go further with that, and this would be a perfect opportunity for that. And then, of course, lethal prostate cancer, which we know very little in terms of the molecular mechanisms for that. And I can go on and on about other cancer disparities, triple-negative breast cancer and the like, which are disproportionately impacting populations of color.
Dr. Gaylor?
Now it's on, but I still miss working with Rick Kittles. I'm in prevention and control at our cancer center, so I'm really excited about the possibility of developing more accurate subpopulation risk estimates by virtue of having larger and more representative samples through the PMI. Members of the American College of Medical Genetics and Genomics Working Group on Incidental Findings in clinical exome and genome sequencing were highly concordant for the return of incidental findings on 64 conditions or genes, including hereditary breast and ovarian cancer. 75% of the work group members said that these findings should also be returned in children. This worries me for subpopulations because our estimates of risk are largely based on majority population. Our estimates for the prevalence of BRCA1 and BRCA2 mutations for African Americans unselected for family history are primarily based on 2 studies. One from Northern California, a Northern California site of the Breast Cancer Family Registry, and another from participants in the NICHD CARE study who self-identified as African American from 5 cities. And based on Dr. Kittle's work, we know that the European genetic contributions of those people who self-identified as African American vary widely across those 5 cities. So it's 10% European genetic contributions in Atlanta, but 35% in one of the other 5 sites, which is Seattle. And I like to think that the PMI would give us much more accurate pictures of risk. The second thing that also these things come from our personal, from our work, but we have one of the transdisciplinary research in energetics and cancer centers from NCI, and I really see the possibilities for the study of obesity, which contributes to many common conditions and is high in subpopulations like Native Hawaiians. Increased sample sizes through the PMI would allow us to better understand the roles of social factors and inflammation and develop and target interventions to decrease rates of obesity. Thank you.
Jim, do you have
Thanks, Ricky. So I mentioned before the growth of the big 4 chronic conditions among children, and those are highly, all 4 of them, more common among kids of color. Why is that? Why do we have higher rates of obesity, asthma, and mental health conditions among kids of color? So the simple answer is we don't know. We have relatively little information to explain that. We have small studies which provide a little bit of evidence for the causation of that, but relatively little. So the PMI actually provides a tremendous opportunity to gather data prenatally about the onset of some of these conditions. And we know things like asthma, for example, certainly do have some prenatal antecedents that are really critical to its development. And those probably do vary by a variety of sociocultural variables as we go forward. A little bit of evidence to support that. But that's just one example of where the PMI offers a tremendous opportunity to have a much more diverse population to study well over time in understanding that. But that's really generalizable to the other major conditions of childhood. Obesity, Dr. Geller just mentioned. We know increasing amounts about the perinatal influences on obesity, more from animal studies than from human studies, but some interesting human studies from Scandinavia recently in this area too, which really do show that certain kinds of exposures during pregnancy are associated with higher rates of obesity, regardless of all other variables, is just one example. But I think we're getting to understand where, again, population studies that would allow us to examine this and how this is implemented in different kinds of risk populations will be really helpful. Finally, I just want to say that all of us face a tremendous confounding of race and ethnicity with socioeconomic status in this country. Excuse me. And the ability of the PMI to help us disaggregate these phenomena would be a tremendously ravishing step forward. Our ability to really understand some of the issues that Dr. Kittles and Dr. Geller raised. Thank you.
I think that the panel has really done an excellent job of laying out the specifics. I want to just reinforce some of the things that you said so that those who are going to comment from the floor will really be able to help us figure out how can we do justice to the importance of these issues. And then I'm going to ask the panelists to kind of describe in the last few minutes of our part of the time, the last few minutes, what would that ideal cohort look like? You know, not in terms of your sample size calculation, but what would the cohort look like? How would you measure success of getting the kind of cohort that's needed to do justice to these issues? So I think that the main thing that's come through in what you've said so far is that most of the data come from the part of the population that is lower risk and that the high-risk populations, we actually are guessing about how to address the issues, and that comes from all three of you. And I think also that the strategy of targeting a whole social political group is not very precise and specific, and could even do harm, because the genetic overlap, is different in different populations, and so PMI could really give us a chance to get beyond using the Census Bureau categories as in that aggregate sense. So what does this cohort have to look like? A million people sounds like a lot of people, but what does it have to look like in your view from the kind of research that you do in order to allow you to study some of these issues? So let's see, should we go in the other order and take children first? Jim?
I hope I'm not losing my voice in this context, but I think there are two or three things that are really pretty critical. One is having a cohort that is large and diverse enough to be able to deal with racial, ethnic, and sociocultural differences in ways we've not been able to do up to this point. So that breadth is really critical. The second part of it is it needs to be large enough that we can actually examine the antecedents of a number of the less common pediatric chronic conditions. So again, I talked before about obesity, asthma, mental health, and developmental, but thinking about sickle cell disease or about kids' arthritis or about things like cystic fibrosis, it needs to be large enough to be able to have samples that develop with those kinds of conditions over time. The very rare ones, obviously that doesn't make any sense to include that kind of set of conditions within the context of the PMI. That we have other strategies, research strategies addressing extremely rare conditions, but that's, I think, another critical part of it. So those would be the couple elements I would consider to be critical for development.
Who wants to go next? Are you?
First of all, I want to just emphasize that disparities occur in all major diseases by race, ethnicity, socioeconomic status, but also geography, rural, urban, which we haven't mentioned too much. And there are many types of disparities and many subpopulations affected. I don't know if you've seen a supplement to the American Journal of Public Health that came out within the last day or two on PMI. And there's a small article by folks from the National Cancer Institute led by Shobha Srinivasan that I would really urge you to look at, because it has an algorithm for figuring out how to include subpopulations. Srinivasan and her colleagues talk about pockets of communities that are significantly underrepresented within the general minority and underserved population. And if they're not included, we'll have an incomplete picture of health disparities in the United States. Let's see. I think that the PMI holds a promise of decreasing disparities in two major ways, allowing us the information on what's fueling disparities that's really eluded us to date, which will allow us to better prevent disease for everyone, but I think for everyone ultimately, but especially for those who are disproportionately affected. Also, to devise interventions for the people who I talked about initially, who really are driving disparities in the United States. Too often, we devise interventions for the people who are easiest to access, who are most like us, because they're in our clinics, they're in our waiting rooms, they're in our data sets, thus bringing them closer to us in terms of health outcomes. So in essence, you've decreased the disparities, but really leaving the health of others who are harder to access unchanged, and really, I think, marginalizing them further. If well done, the PMI has the potential to build trust in medicine and in research. I think that if we go to neighborhoods, if we use some of the methods that we've heard about, we can break down some of the barriers. Again, if we treat people respectfully, we don't expect them to come to us. We go to them and communicate through their channels, not necessarily our channels. We can break down the barriers that keep a lot of people from participating in care in clinical trials. Ensuring representativeness of clinical trials is a major concern, as we've heard. The president of the American Society for Clinical Oncology, for example, recently wrote in the New York Times that low participation in clinical trials threatens our continued progress against cancer. If done in an inclusive fashion, I think the PMI could add to trust and increase the public's understanding and familiarity with research and increase the representativeness of clinical samples. And I think, again, that success, we will have done it right if we include people who aren't in stable healthcare situations. And this will require, I think we need sampling specialists on this team. And we also need to come up with new methods for working with small data, like Bayesian statistics. We need to really sort of push the envelope. And I'd urge us to consider that.
Thanks. So we're about at our time, but I want to give Dr. Kittles the last word on this issue.
I couldn't have said it much better than Sarah and James. I think there's several algorithms out and several models in terms of how the numbers should look and all of that. And a lot of it really depends on the research question. But I will say this one thing. I think as a person who really tries to understand genetics of human populations, I think we all know that rare variants have some role in terms of health and drug response. We also have to understand that communities of color have a higher proportion of these rare genetic variants. And so here's an opportunity, I think, to really understand the role that these variants are playing in terms of health. So I'll just end that with that.
So we will take your questions. I'll stand up so I can see who's...
So we're trying something new. We're going to walk some microphones around. We have Gwen, Sally Oken, and Josh Denny running around with microphones. Raise your hands. If this doesn't work, we'll go back to the lines.
This side here. Do anybody want to?
Yeah. So you're at the mic, but the mic isn't there, right?
Oh, go. So people with microphones, go to the people with their hands up.
We're going to disrupt the usual way you do this.
Right. Yeah, you have them. Okay. So we're going to take you first, and then we'll come to the working group, right?
Yes.
Yes. Please.
Just some comments.
And introduce yourself as you speak.
I'm Sue Baca, and I'm a professor of nursing and biomedical informatics from Columbia University, and I am a PI, a cohort of about 6,000 Dominicans that live in Washington Heights, Inwood, in New York City. And so one of the pleas is, of course, for Hispanic subgroup, a type of things. We have gathered this cohort through a very community-driven approach. We have examined the predictors of willingness to consent for three important aspects of precision medicine: sharing of electronic clinical data, sharing of willingness to be recontacted, and then also consent for provision of the biospecimen. One of the things that strongly predicts across all three of those aspects actually is health literacy, although overall our panel is quite low in literacy level. But we found with working through building up the trust in the community with community health workers and other Dominican staff that we've been able to have a high level of participation and agreement. We have also continuously fed tailored data back to the community from our survey. So we have the social determinants of health and health behaviors from our survey. We have the electronic clinical data, and then we have the biospecimens. I'm going to raise an issue that I probably could raise in any session, but one of the interesting things is I can't actually deposit the specimens in dbGaP because the study is funded by AHRQ. And so this is a $9 million federal investment of our tax dollars, but it came through AHRQ. And currently, the policy for deposit of the specimens in dbGaP is that they're NIH or you need sponsoring from an IC. So I think one of the things we need to think about for getting the specimens into dbGaP is what might be the mechanisms for inclusion of samples gathered through funding mechanisms other than NIH to be part of PMI.
Okay, thank you. I'm going to look right over at the NIH table for an answer to that question or a comment, unless you want to.
We were just saying, gosh, that doesn't sound right, because dbGaP is supposed to be the place where data of all sorts can be deposited, and I am frankly unaware that it requires an IC sponsor. We should talk.
So, sorry, I just wanted to chime in. The issue with sponsorship has to do with having an IC that's willing to have the data access committee, their data access committee, review the study. So it is something we should be able to work through, and I'll be happy to talk to you afterwards.
Okay, thank you. Thank you. Yes, next.
Yeah, I'm Laura Hensley Russell. I got here from New York to Philadelphia to the wrong neuroscience building to the right neuroscience building. So I'm very pleased to join you just a little bit late. And I have some unique perspectives. I was sick for 20 years and now I'm not. And I've spent 3 years not only by the grace of God getting healthy again, but diving into this because there's a lot of potential here. I had not just cancer, which was kind of a bump in the road, and thank God to people like Dr. Susan Love, I have my lymph nodes and my health. But then I had fibromyalgia and all that mystery stuff going on, and then a year of accelerating, weird autoimmune, neurological, psychiatric, dermatological disease, you name it. And it turns out that I have a unique perspective on chronic disease now, which I'd like you to address, which is that it's really not that complicated. They're really an engineering problem. They're not really, in all cases, a medical problem, and they don't all need drugs. What they need is to look at what genetic glitches we are blessed with as genetic snowflakes and what toxins we are cursed with in the external environment, unfortunately within our bodies also in terms of not just, it's not all diet, drugs, and exercise. Medical devices. Unfortunately, I was poisoned by my dental fillings. I have methylation glitches. I have a glitch, so I was poisoned by the mold that my parents' condo got through no fault of their own, and they didn't remediate properly because they were old. What was the other thing? Oh, Lyme. It didn't respond to the many times I had the cheapest generic. It just needed one that was still a $7 copay. So, and I can tell you, I cost Harvard Pilgrim Health Plan a fortune. I saw so many specialists, it wasn't funny, and they all looked at one part of the body or one system. And
So
never the whole
I'm
picture.
sorry
So
to, excuse me, I'm sorry to interrupt, but this session is on
Sure.
inclusion
Yeah.
and health equity.
Sure. So what I want to
yes.
say there is much more important than all the things I've done in terms of demographics and age. You need to do basket studies on everything. I wonder, and the people in this room could figure out, is there something called human methylation deficiency disease that underlies a whole host of particularly what Dr. Perrin was talking about? If we could look at methylation issues, immune glitches, and the mold toxicities, you're going to find out a lot about cancers, and you need to include
All right, thank you.
dental.
We are going
So
to
you need
move on
include
to our
dental.
next speaker right now.
If you
Thank
don't include dental,
I will kindly ask you to please, thank you. We have a lot of people to hear from today. All right, if we could go to our next question.
Thank you.
Thank you. My name is John Birch. I'm a private investor. And I have a specific question, and I hope a short one for Dr. Perrin. You talked about the need to keep data starting prenatally and for 1,000 days starting then. What is the state of the current electronic medical records for collecting that data?
Well, it varies a good deal from site to site, but there are places now where, in fact, those kinds of data can be aggregated and put together. It's not typical that if you're in a clinical setting, that I, as a pediatrician, for example, will have easy access to the data on the mom or the dad of the kid that I'm seeing. That is not true at this point. Although there are ways from a research basis, I can actually get those data and really make use of them. So I think there's actually a lot of good experimentation on that with a variety of strategies for putting together patient databases effectively to be able to look at that over time. It's a matter of making sure we're collecting the data and collecting all the data that's relevant that we're talking about here, which is going beyond what's in medical records.
That really was, I guess, the question I was getting at, was to what extent is the data that you would like to see collected part of standard protocols?
It's not, in general. I think the reality is that we don't have much genetic data in medical records. We don't have much in the social determinants data in medical records. So some key variables are painfully absent.
We're going to move over to here for a moment.
I was just going to echo that the electronic medical records are made for billing, not for research. And so we shouldn't kid ourselves that they're hidden mines of wonderful data.
Just to make a quick clarification there, medical records are for treatment. They're not for billing. Claims data are for billing. And claims data are much, much less rich than EHR data are.
But the way that the electronic medical records have been set up is really not for research. It's really much more for billing, and it sometimes can help with information.
It is for clinical care. I'm sorry. It is not for
Okay,
research. It is for clinical care. It's not for billing purposes.
I know, but they don't work very well for clinical care. So,
Okay.
Improvement needed.
We're going to come. Are we back over on this side of the room? Okay.
Thank you.
Yes, please.
Sue Friedman from Force. There's a lot of discussion about returning the data to the people participating, but how do we assure or build into this that underrepresented people have access to the technologies that come out of this research so that we're not increasing health disparity because, the research leads to very expensive technology that their insurance won't pay for?
Any of the panelists want to comment on that? Have you had experience with that or ideas?
That's always been my fear. When we talk about precision health and individualized medicine, is that if we're not careful and if all the communities aren't engaged early and properly, it will actually increase the rift in terms of these disparities because of the knowledge base. But then also the information in terms of treatment and the technologies that this is expensive stuff in some cases, and so you'll have situations where these high-end clinics will have the technology and the opportunities for their patients, but then those with who are underinsured may not necessarily get the same thing. So I think there's an opportunity here to really engage and to explore how to make sure that doesn't happen.
Yeah,
I don't know exactly what it is, but I think it's important for us to talk about it now.
Absolutely. I think that will help community engagement as well, too. If people understand they're participating, and at the end of the day, they're not participating and showing up and volunteering for something they won't have access to. Thank you.
Let me just make a comment while we're transitioning to the next question, because this is at least the second comment about changes that might be needed in sectors outside of the health system. If there were, do we need a change in the way in access to digital technology and in the way it is costed? In my experience, a lot of people have periodic access to cell phones, but it's not the plan, the 2-year plan. In the great phone, it's when they can find the money to buy a car to use it or something, which would mean it's very haphazard. So I think if we can keep a list of the things that really mean we should change the way business is done in any part of a system that could influence our ability to be successful, that we can maybe look at those and focus on those issues at some point. So, thank you.
One just baby step that we've done at the Cancer Center is to work with public libraries and our medical librarians to at least make the web accessible to people so that they can get information. It's just a tiny step, but again, it's part of what I was saying earlier about moving into communities and not expecting people to change or to come to you.
Right. Yeah.
One of the incentives for adolescents to participate in some trials has been a better rate plan for their iPhones, frankly. And I am amazed by the ability to use iPhone technology to gather vast amounts of data
really
on young
incredible.
people at this point. And kids are generally remarkably willing to share that.
Thank you.
Hi, my name is Laura Beirut, and I'm from Washington University in St. Louis. And I want to bring up a group that I often don't hear about, which is people who use substances and the addiction area. So if I look at the most likely causes of death in the United States, cancer, heart disease, lung disease, a variety of diseases, but when you look at the modifiable factors behind it, it's smoking, alcohol, drug use. And so, oftentimes these individuals are not receiving any type of treatment. I'm going to comment that I view drug use problems as actually a pediatric disease because the use is initiated in early adolescence, often not queried by pediatricians. And we really have to think about this. And there's the issue that, let me see if I get my regulations correct. CFR 42 Part 2, I believe, is the regulation that removes substance use treatment from the medical records with the sharing. So there was a recent editorial in JAMA about how the substance use treatment is being removed from the Medicare records. And so the intention is to protect individuals with addiction, but what's actually happening is that it is harming them and removing them from the treatment. So I want to advocate for that population, which is often poor, and disadvantaged in so many other ways.
Thank you. Let's see, we have a mic over
Yes.
here. Yes.
Hey, I'm Leslie Alexander. I'm at the Georgia Regents University Cancer Center. I'm super excited to be here. I think the initiative is incredible and powerful and exciting. But it makes me as nervous as it makes me excited when I listen to the discussion going on. Because it seems like, and of course it's a part of beginning any big project, is you think big. But Dr. Collins, when you said you need more than 1 million people, when I listen to what's being described here, we need way more than 1 million people because there's no way we can tackle everything that's been raised so far realistically with a cohort of 1 million people. And unless we're going to follow those 1 million people from prenatal through their death, we're still not going to be able to answer a lot of the questions that are being raised, particularly about the really rare, the subvariants. It seems to me there's going to need to be, and I have no doubt, because I've worked with Dr. Collins in the past, that the LC issues are huge around this project. And part of that relates to this issue of trust with the community. If we're going to engage people, and I really want to commend everybody who has spoken about these incredibly hard to reach populations. I live in Augusta, Georgia now. It's a new experience for me. But there are a large group of people when even if care is free and even if you're going door to door, they do not want to engage with the medical community. Even if you're offering people who call for free lung cancer screening, when you say they need to have a referral, if they don't have a PCP, you offer them one, they hang up. Some of them do not want to engage, and we've got to figure out if they're the ones we're most concerned about, how do you get them in? But to wrap up, I'd say we better be careful not to overpromise and underdeliver with what we're talking about in the cohort, or people really won't trust, and it'll be one more example of this is what you told me, you promised me all these exciting things, but much of what we're talking about, unless this is going on for life, will be funded and will collect how people use the healthcare system, because the outcomes part, when you talk about the prostate cancer in African American males, at least in Georgia, we're thinking a lot of it is because these men are not being offered the same options for treatment. They die 3 times as often as white males. So I just think there's got to be some caution around this as well.
Let me just say one thing. We've talked about recruiting, or going to talk to people in sororities and churches. And one thing we've found is that We need to work through shelters. We need to work through laundromats. We need to sort of change our thinking about how we go out to talk to people. And that really sends a message, too, I think, that you're willing to go an extra step, that people don't have to come to you. So I'd urge people to include that in thinking.
Yeah, and we are having a next panel on recruitment issues, so we'll be able to explore those issues a lot more on the next panel, right? Yeah, I'm pointing the person with the mic, right?
Yes, thank you so much. My name is Stephanie Oki. I'm the mother of 2 teenagers, one of whom is living with a chronic illness, an aging father who has a chronic illness, and probably what occupies a lot of my time, I'm head of North America and senior vice president at Genzyme, and we make products for people with rare genetic disorders. Here's the good news. This is so exciting because nothing that has been discussed today is insurmountable. In my 20 years at Genzyme, reaching out and recruiting people for studies and keeping that heartbeat of communication going, it's not easy, but it can be done. Someone said earlier in the day, there are solutions that exist, and I think what's great about this forum is we're bringing together people and answers to discuss. To your point, what's going to be the most difficult? We can do anything, but we can't do everything yet. There's the power of yet. So when we start somewhere, that can be done. The other thing, I'm a synthesizer of a lot of things to get a big team behind doing things. There are people in other rooms around the United States and the world today that are thinking about technology and how to advance systems and access people of all types of social situations. Let's get the deals. Let's get people to donate. We can do this. It's a matter of just clearing the path and recruiting the right people. This is very exciting, and thank you for opening this forum up to a lot of voices.
Thank you. I think we have a working group member who wants to comment. Did you want to comment, or the gentleman? There was someone up here who wasn't getting a mic, and I just wanted to point that out.
We have a couple ahead of them.
Okay,
though,
all right.
You're not on the working group.
Okay,
And after these 2, we need to wrap up. Thank you.
Okay.
Hi, my name is JB Smalley. I'm from Pecori. One group that I have not heard anybody talk about this morning is people with disabilities with regard to disparate populations and people who experience tremendous disparities with equity and access. So I was wondering if maybe the panel could say a few words about consideration of people with disabilities for the PMI initiative.
So I thought I tried to say that pretty explicitly about the large numbers of young adults today with chronic health conditions that create disabilities. There's a huge overrepresentation of minority populations in that group. So we know that disability is much more common in people of color. It's very clear. We've sort of ignored that fact in much of the research. I would completely agree with that. But hey, the evidence is really there. And those of us who work in childhood disability know that clearly.
My name is Marcela Gaitán, and I work with the National Alliance for Hispanic Health. My question has to do on relation to racial and ethnic groups, but looking beyond like their own diversity. When you look at Hispanics, look at how diverse Hispanics are, and the same thing with Asian Americans and African Americans and other communities. So what has been your experience? And I'm thinking about children, for example, Dr. Perrin. Like, for example, rates of asthma that are different in looking at Puerto Ricans, Mexican Americans. So maybe you guys can talk about your experience working with the diverse groups, but also looking beyond just being racial in one ethnic group.
Well, one thing comes to mind. Physicians, when they're screening for diet, I'm talking about cancer, tend to look at Korean Americans and see people who don't have a lot of body fat. And when you ask just tacitly down the list, do you eat vegetables? Yes. But Korean Americans have very high rates of gastric cancer. So I think it's extremely important, your point's well taken, that we don't sort of lump people together and assume a homogeneity that isn't there.
Yeah, I think that's an important issue, and that's something that I tried to address earlier in my comments when I talked about genetic ancestry. The heterogeneity in Hispanic and African American populations is enormous, and so we have to take that into account in any study, or else you can have serious confounding due to stratification. And so I think that there are a lot of folks who are involved in that research and who see the role that ancestry may play in terms of some of these outcomes. I know, for instance, Esteban looking at drug response for asthma and seeing some very strong signals related to ancestry. So that's something I think could easily be addressed.
Yes, well, I think I've been instructed to transition this to the next panel, but I will say that because the topic of the whole day is inclusion and equity related, reframe your question as it applies to another panel during the meeting. So I would now like to, first of all, thank our panel for really putting in the thought to share some ideas with you. And then I will turn the podium over to Dr. Esteban Gonzalez Burchard, who will moderate session 4. There's no break.
Good morning. My name is Esteban Burchard, and I am your moderator today. I am from UCSF. I am a physician scientist, pulmonary specialist, and I study genetics of asthma, particularly in minority populations. We have 3 panelists, and I will ask each panelist to say 1 or 2 sentences about who they are and what they do. And then I will come back around and I will give a brief overview of how I view the field and the problems that we have at hand. And then I'll ask each person, each panelist, to speak 5 to 7 minutes. And finally, we're going to build this session around addressing 4 questions that the speakers have, or the panelists have received. But then at the end, and I'll be very strict about this, that we're going to open this up to the audience, that we like to have audience participation, not only from you, but actually the audience out there as we see it on Twitter and social media. So with that, I will begin. So can I have each of the panelists introduce themselves and say 1 or 2 sentences about what you do?
Good morning. I'm Lucille Adams Campbell at Georgetown Lombardi Comprehensive Cancer Center. I am an epidemiologist. I'm the Associate Director for Minority Health and Health Disparities Research and the Associate Dean for Community Health and Outreach.
Hi, everybody. I'm Carol Horowitz. I'm from Mount Sinai, New York City, and I'm from Center for Health Equity and Community Engaged Research, and that's the kind of research I do, as well as being a primary care doc.
You touch his face.
Okay. Yeah, my name is Kyung Liu from Northwestern University. And for the last 30 years, I've been involved in several large longitudinal studies sponsored by HLBI, Cardia, MESA, Hispanic Community Health Study, and some other. So my field is cardiovascular epidemiology / biostatistics.
Great, thank you. So I'm going to take 2 minutes and just give a background. And we specifically asked the panelists not to use slides, but I'd like to take poetic license and show you some pictures. This topic of inclusion is very important. And it's something I've actually made my career on and focused on. And primarily, we focused on children with asthma. Asthma is the most chronic disease in children in the United States. And this is the most commonly used albuterol inhaler, asthma inhaler. And this is actually important because the long-acting form of this is described in this insert. And this is a package insert that you guys get and I get when we get medications. It's the first thing we throw away, okay? And I'll tell you why you throw it away. I'm not being alive, but I'm better. Look at the text highlighted. It specifically says, if you look at the text, and I've highlighted it, and you need a magnifying glass to see it, but it specifically says if you're African American and you take this medication, you have a 7-fold increased risk of dying. And therefore, in order to derive benefit from this medication, you need to take another medication. The combination of the two is about $350 a month. That is a tragedy, and that's why we need to make sure that we have good representation in all clinical trials. And this is why, because when we look at death rates for asthma in the United States, we see that huge disparities. Medications for asthma have not changed in 50 years. We continue to do the same old to study populations outside of the United States, generate clinical information, and bring that stuff in, bring that data in and generalize it to the rest. Well, how about if you're Asian? This is the package insert for the #1 seizure disorder medication, carbamazepine. But if you're Asian and you take it, there's a 4,000 increased risk of you developing a life-threatening condition called Stevens-Johnson syndrome, where all your skin sloughs off on the outside and the inside. It primarily affects Asians, and because we didn't do studies in Asians, we missed it. But this is the FDA package insert. So you have to be a genius in order to read through this whole thing and then find this line that says, if you're Asian, you need to get genetically tested. We don't do genetic testing in the United States. It's a calculated risk. And that's a problem. But we do it in Asia, and since the initiation of genetic testing, all cases of Stevens-Johnson syndrome have been ablated. So these are the demographics of the United States. Currently, 40% of the U.S. population is non-European. And this is where we're at with respect to modern genetic studies that have been done worldwide up until 2011. 96% have focused in on European populations, 4% non-European. This is what we need to address. We need to fix this problem. I'm a pulmonologist, and what we did is we asked the question, how have we as the NIH done in funding research in pulmonary research in the last 22 years since the initiation of the congressional mandate requiring the inclusion of minority and women? This is a complex slide. I'm going to walk you through it, and I'm going to stop after this. On the y-axis is percent of publications. On the x-axis is the year. And we see that the total number of publications have gone up for minorities, but still, in general, in 22 years, less than 4.5% of all publications, at least with respect to pulmonary disease, we replicated this for all diseases, include what the NIH considers non-European populations or minority populations. This is a travesty. But this is not the NIH's fault. And I take responsibility as a reviewer on a study section, and I think people here, the scientific community, should take ownership on this because we're falling down on the job. We are not holding our criteria, we're not holding our investigators to the criteria that the NIH has set that require the inclusion of minority and women in research. So I take responsibility, but I also want to give responsibility to the other panelists here that are on study sections. Having said that, I'd like to open it up and have each of the speakers talk about the 4 questions that we received, and I will read them so you know. One of the questions says, what are the challenges that have arisen in recruiting and retaining diverse and disadvantaged populations? Are there historical patterns of cultural differences across ethnic groups, education or socioeconomic status, related to sharing of genomic information or other health data? What are the best practices in overcoming recruitment and retention issues in longitudinal and genetic studies? And how can these solutions be applied to PMI? So I will ask the first speaker closest to me to speak, and you got the first 5, 6, 7 minutes.
I'll do the best I can. I'm going to come from the perspective of being the co-PI of the Women's Health Initiative, and we were one of the 10 minority sites, and that's gone on for 20 years, and also being the co-PI of the Black Women's Health Study, having recruited 59,000 Black women over 20 years, and still going funded by NCI. I don't find the title exactly the issues that I go through in terms of challenges. I think that we have sort of mastered in some ways the way of dealing with the communities. And one thing is, I'm at Georgetown. You think about Georgetown and you think about minorities and inclusion, you probably think it's oxymoron. But when I came there, the idea was to co-locate in the community, to make certain my faculty and staff were all located in the community, and they are. And that helps because we are definitely part of the fabric of the populations that we're interested in. But also involves having community advisory boards, involving the community, and we've heard that already all morning, making certain our community advisory board encompasses the residents. Also, doing a needs assessment. You know, I spent 3 years doing this at Georgetown after coming from Howard, after being at Howard University for 18 years, because it's very important that you establish this and not just go for the grant and fix just have people in the grant just for that moment. So we want to build this trust, and I think we've done a good job. And I think that it's really important that we do a needs assessment, and we've heard it already talked about in terms of focus groups and all, but we have to know what the community needs. We have to have our fingers on the pulse of the community, and I think that's the only way we can do it. But one of the things that's really important, and I think is a big barrier to inclusions of minorities, and that has to do with study design. Particularly therapeutic trials. We know, for example, when I published something in JCO many years ago, just talking about the eligibility criteria. If the study designs are based on cookie-cutter models, where I've asked that question in public forum, how do you determine the eligibility criteria? Well, we really just cut it from what we've done all these years and take it forward. And we have to understand if it's really biologically plausible, some of the things that they're asking, if it's meaningful, if we need to see a certain level for castration rates or a certain number of hormone positive receptors. Is that absolute cut point the important thing? Is it more important to maybe look at a 15% change? So we have to think about the eligibility criteria, because many minorities, in particular African Americans, get excluded if you talk about certain things. So we have to be more robust in terms of our eligibility criteria and think about it not as the mouse model, where the mouse model you can engineer the mouse to have exactly what you want, but in real life, this is what you get. So we have to take that approach. Also, I think what we have done is we have come up with some rapid clinical trial designs. And that is, when people come in for a study, and they have really worked their way to come, and they got their nerve up to come into a study, and the first thing you say after 5 minutes, you're no longer eligible. Think about why people are not eligible, in terms of they might not be eligible because of some of their lifestyle practices or whatever, obesity, whatever it is. But we started trying to create small spin-off clinical trials that addresses the issues and needs of the community. Again, going back to what's been deemed important for that individual. Also, when you think about getting the message out to people, dissemination is so important. We created Minority Health Matters newsletters that we don't mail out. We hand deliver to the communities, to the grocery stores, to the neighborhoods, to the churches and all, so that the people can get that information. Because at our institution, things are mailed to the alumni. And I know if you think about the universities that you went to, they're not where you're living now. So you've mailed everything away, but nobody knows anything locally. So I think that for me, the idea of the PMI is an important idea, but I'm not quite certain what the questions will be. Mm-hmm. I'm not quite certain what cohort really means as epidemiologists. Are we doing a longitudinal study? Are we just talking about having have the capacity with maybe 1 million people in it to create smaller studies? So that ambiguity in terms of where we're going is important, because we don't even think about sample size because we don't know what the question will be at this point, you know. And I think that when it comes to biospecimens, I just want to jump into that in terms of genetics that we are talking about so much today. People say that minorities aren't interested. It's all about the education. It's all about the education. If you get people to buy in, I think that many of these things can be done. But if you don't educate, and it's not just educating the participants, and I heard when Dr. Collins spoke in the very beginning about we want to make certain we get the buy-in and the contributions from the participants. But you know, if the participants become more educated than the providers and the healthcare providers, then we're going to have another disparity, because if they don't know what's going on, then it doesn't matter what the participants do. And if we have all these fancy variants in order to give back to the participants to hand to their doctors, it might get put in the trash can. So we just have to make certain we continue that. And I think that cultural relevancy is important. Sometimes we wonder, I do a lot of lifestyle exercise interventions, nutrition intervention studies for breast cancer and women at high risk for breast cancer. And the idea about cultural relevance, I wouldn't design a study for swimming for black women. We'll talk about the hair later. But I'm just saying that you have to address cultural relevancy in some of the designs. And I had a Korean Olympian as my exercise physiologist who was a swimmer. And I said, we're not going to design that study today.
So can I ask you a question then? And for all the speakers coming up, I'd like to somehow show your credentials as to why you're at the table, so people know that you actually have experience, and then for you to share your experiences. Go ahead.
I want to make a quick clarification because I didn't want the ambiguity about the plan for the million-strong cohort to be persistent. Basically, we do intend for this to be a longitudinal study with ongoing data collection from all the participants for a very long period of time. That is the design we're aiming for. It may very well also be a foundation for other specific trials of interventions, be they therapeutics or devices or whatever. But the main study is a longitudinal cohort.
So keeping the main study being the longitudinal cohort, keeping that in mind, think about your experiences as panelists, because you were invited because you have a track record. My track record is we recruited the largest pediatric study of minority children in the United States for asthma, gene environment study. We recruited about 11,000 individuals. I've had 15 years of experience and of good experiences, bad experiences, ups and downs of doing that, and I would like to share that with the committee. You guys, each of you have experiences, and I'm going to go to the next speaker. What can you start off with what you have done, what have you done lately, and how could we as panelists benefit from that?
Sure. I have been recruiting and retaining diverse populations into multi-site trials to prevent and control chronic diseases. Most of my work is focused in northern Manhattan and the South Bronx. So that's the world I live in. I'm relatively new to genomics, but I'm going to share what my experience has been like, give some suggestions, and then tell a story about our genomic study we're working on right now. So unfortunately, unlike the panel I'm having the pleasure of sitting with right now, I'm a rather typical health equity researcher. I care, I work hard, but I'm a well-paid white professional who drives her hybrid to the suburbs after a day of work in Harlem. So I am an outsider in every way, and until we radicalize how we're training and bringing people into research, I'm going to be a lot of what researchers look like. So now this is the research I do, and I want you all to imagine you're an older African-American woman who lives in Harlem, you're sick, you're economically insecure, racism is your everyday. Now what do you know? You know researchers have behaved badly in the past. You haven't had the most positive experiences getting health care, and you figure the same kind of folk who take care of your medical problems are probably going to be the ones researching you. You know all about drive-by helicopter research, right? Researchers go into all this stuff and leave no trace. The studies you know about happen that way. You don't see them making your community any better. You know, one of my community leaders said to me 15 years ago, you guys keep coming in, you leave, and we are still fat and sick. Nothing is happening. No one you know has gotten information back about a study they've been part of, not even a note, what the research team learned and what they'll do with it. You don't feel the questions we ask are ones you're interested in. No one's ever asked you what you think we should be researching. And the little you've seen of research, you don't think there's anyone like you steering the ship. Instead, you see people like me, not from the communities and not from the racial, ethnic, socioeconomic groups that are disproportionately and unjustly impacted by poor health. And you've experienced many times that we doctors and probably researchers blame you for your illness. It's all non-compliance, it's low literacy, it's attitudes like fatalism, and you don't want to be part of research that further disparages your community. And you're not 100% sure about research. What is it? Come to think of it, you can't name one thing in your world that's better because of research. Now, there might be a lot of things, but no one's ever really made it totally clear to you. So now, imagine someone from my team calls you at night at home or intercepts you at a doctor's visit and says, and asks you if he, a total stranger, can ask you a bunch of questions, do some measurements, and take your blood. What would you say? So I think there are ways that we can do better, and I know everyone I'm here with on the panel has done better. It's building, as we've said here, I think it's an important theme, teams committed to research and participants, including people from the target community. While rare disease advocates are groundbreakers and essential, when you move into my world of chronic diseases, common chronic diseases, we need to engage those people, and it's harder to engage. We need to always look through participants' lenses. Patient-centeredness does not damage research rigor, it enhances it. We need to design everything with inclusiveness in mind. People should want to join. You know the difference between a team and a pickup game, right? A team means if you're part of it and you're not there, people go, hey, what happened? Where were you? These have to be teams. People have to be proud to join. They got to have their t-shirt or something saying, I'm part of the PMI. This is awesome. And their friend should say, how'd you get in? I want to get in. Not somebody gave me $20. I don't really know what it was about. We need to evaluate our research and recruitment strategies, and I think we need to be really honest about it. I think we need to figure out a way to have a journal supplement or meeting where we all come out and talk about what didn't work. Because right now we can't get it published, and we don't want to talk about it because we're afraid we won't get more research funding. We are under tremendous pressure to recruit people for our studies. I know lots of people have lost funding because their study didn't recruit enough people, but we can't bow to that pressure by just cherry-picking easy-to-recruit patients. We need to use this pressure to collaborate and innovate, not just dig in. We need to spend as much time and effort and creativity on recruitment as we do inviting people to a party or getting people to buy cookies at a bake sale. I think a lot of times when you think about these strategies, they're an afterthought. They're not a center thought. And we need to disrupt business as usual. We need to share our results with participants and communities. I'm completely and chronically in disbelief the NIH does not make us send letters to people in our studies telling them what we learned. We should do that. And we need to democratize data, right? It's as much there as it is ours. So I'm going to end with a little story about the work we've begun in genomics, because it's new to me, and I think we've learned a lot. With NHGRI funding, we're partnering with community leaders and clinicians from a large network of federally qualified health centers in Harlem and the South Bronx. And what we're doing is we're testing people of African ancestry for a genetic variant of APOL1 that increases their risk for kidney failure, okay? We're returning the results to patients and their providers through the EHRs, and we're following them over time to see the impact of it. So as a disparities researcher, when my now partner, Erwin Bottinger, approached me with this topic, I thought he was crazy. I'm recruiting Black people to test their genes? I'm like, wait, race is a social construct. And white genomics ethicists, I asked, said, do not do this. You will set the disparities movement back decades if you touch this question. And I thought they might be right. But as you heard earlier from Tony Coles and Rick Kittles, ancestry, there's biology there, right? So what do I do and how's the community react? So as I hope PMI will do, I first asked people I trusted. And the first person I asked is my colleague, who's a Black pastor, Elder Mimsy Robinson. And I said to him, Elder Mimsy, there's a gene variant present in 1 in 7 Black people that increases their risk of kidney failure in some groups by 5-fold. Should you and I get into research about this? And what he said totally surprised me. He said, maybe now when white doctors see Black people on dialysis, they won't think we didn't try hard enough. They'll recognize there's more to sickness than bad behavior. I never thought about that. I was a white person saying, no, don't do genetic research on Black people. I didn't know anything. So we actually found that more than Elder Mimsy believed this. We got funded and built a board, like you said, built a board of community leaders, clinicians, patients who have the variant, and we took every research step together. We did rigorous, formative, qualitative research to test all our steps so we knew what to expect and we could make corrections. Our design is through a participant lens. Our participants are patients and, like you were saying, the FQHC clinicians, because a lot of clinicians are unfamiliar and uncomfortable with research. Every action we take has inclusiveness in mind. The board we designed new consent forms. The board got the IRB to change their boilerplate language. I couldn't do that. We have well-designed marketing materials. We phone, we text, we meet you at night and weekends in the hospital, in the neighborhood. We have a team of recruiters from the community who are equally committed. We have an app you can go on, which we're finishing building, that shows you what research is, what it means. There's a verbal consent form. You get the results of everything, as does your health provider. We study actionable things, and we don't give people inflicted insight. You have this, and there's nothing you could do. We learned how to explain genes. Folks don't necessarily want a whole dissertation on genes when it's about disease risk or pharmacogenomics. And we learned the community has questions to ask, like the relative and interactive impact of the APOL1 variant, body mass index, poverty, stress, adherence, the environment. life chaos, and perceived racism, and how these impact blood pressure and kidney function. And together, we're going to find out. Thank you.
Great. Thank you. Ken?
For the last 30 years, I had served as a PI for the Chicago Cardiac Center. The cardiac study consists of half Caucasian, half African American. And we recruited them when they were 18 to 30. And now, after 30 years, that's a long time now, they're in the middle age. And also, I served as I'm currently still serving as a PI for the MESA study. And the MESA study, we have 4 different ethnic groups, Caucasian, African American, Chinese American, and Hispanic American. I just want to share some of the experience about the recruitment and retention, because that's what we were asking to do of these cohorts. When I think it's a good idea for this large research study to include the existing cohort, as well as you taking advantage of the HMOs and so on to recruit people. But I think the majority of the participants probably still will be from the community, and one of the important things is how do you reach them, and how do you recruit them. I think one of the challenge is the trust. I think Lucy, all the people mentioning about trust. The main reason it's not a historical, just a historical problem, but now no matter you want to use email to recruit, use telephone, use letter, and so on. There are so many scams, and they don't know whether that's real or not. So that's really the problem. I think really to get to the community, not only get the community organization support, but you really need to publicize the study and the purpose of the study. How do you do that? You probably want to have a flyer and to in every clinic, church, community organization, and so on, to let people know what the study is about. And you target the community and do that. And also, you probably want to give a lot of lecture. That's what I did when I recruited the Chinese participant in Mesa. I gave 10 lectures. I went to, I think this morning somebody mentioned about the women. It's very important, dominate a lot of things. Actually, I went to several Chinese Women Association and give a lecture, and that's true. It's very helpful. But anyway, I went to churches and so on, churches and the community center. I think this is very important to publicize the study, and then you can send a mail, and then you follow by the phone call to recruit people. If you don't do that, they are going to throw away the mail, and they are going to. They have a call ID. They have enlisted number. You're not going to be able to reach them, and so this is the problem. And how do we reach the community? Because how do we get the name? There are some commercial company. They provide the name of the residents in the community, and they give you the address, the name of the household, and plus. If it's listed, they give you the number and so on. You can try to do that. And we did some tests when we've used that in some of the study. We see whether they actually cover pretty much the area, and the result is pretty much covered. They missed a little bit here or there, but it's pretty much covered. I'm not trying to advocate for doing that, but that's one way of doing that, to really get the name and so on. And also for the older people, we use the CMS. The information and apply that and try to get a letter and so on, to send a letter and to recruit, and has been quite successful. In terms of the retention, I think the retention it's very important. We in cardiac, for example, after 25 years, currently we're doing the year 30 exam, but at the year 25. That's the last exam. I have the statistic. 74 in our center, 74.4% came back to receive the exam, the year 25 exam. Every 5 years we provide the exam, and we still have contact in our center, 88% of the people, we still have a close follow-up. So a little bit lower in African American, but higher in Caucasian. However, I want to mention that for younger adult, the African American men is a challenge because many of them, they move around and the cell phone number changes. So that we need to pay attention and find a good way of how to keep them. And in terms of the second question related to genetics, whether they are participating, we asked them about whether they let us to store the DNA and to do the genetic research in the future. So both MESA and CARDIA. And a very high percent agreed, like in MESA, 98.9% of the Hispanic Americans agreed to participate, and 97% of the Caucasian and Chinese American agreed, and 93.3% of the African American agreed. And for CARDIA, it's even higher. The younger people, they are higher, both Caucasian and African American, 97% agreed. So it's a very high percent agreed. But of course, this is different from the previous presentation. These are the people who already participated in the study, and so they tend to be much higher. But that shows that no matter which ethnic group seems to be, they tend to agree with this. And also this morning, I noticed that in the previous lecture and in the survey that you identified the factor that people want to participate in this. One of the important things is that they want to know the result. Okay, and in all these studies, we always give them the result, and especially the abnormal result, the clinical abnormality. We either we give to them, and if they agreed, we send to their physicians and so on. And if they don't have physician, we try to make some referral, make an arrangement for them, and they pay for them. We don't pay for them. But I was thinking about the one important thing is related to genetic study. I mean, in the actionable genetic abnormality, that's probably different from the clinical abnormality, because that involves their family, the direct family. And so far, we don't have a good solution to that. How do you do that? Because in some of the study we are doing, we agree, we told them that we are going to provide verification, because theoretically you're supposed to have this verified by certified lab, and provide some genetic counseling. But that costs a lot of money. And so far, we don't have a good solution. So for this large study, what is going to be the solution for this? I think that need to be seriously considered. Because if you just give the result and they get a result, they don't know what to do, and they're concerned about their family, immediate family, and that could be a problem that they may not willing to continue to participate.
Great,
so
thank you. Questions are rolling in, and I want to we have 6 minutes or 15 minutes, I want to address them, and then we want to open them up to the participants in the community, in the audience and out there. So one of the things that I think is important for us is we have a wealth of, each of us has our own individual experience in recruiting, and I recruited 10,000 minority children. And I thought I was on a roll, and so I thought I'd recruit Asians, and I didn't realize that I wasn't Asian, and the Asian community looked at me as such. And so when I actually beat the pavement and went and tried to get community buy-in, I couldn't, and so I failed. So that actually, I know it's a tongue-in-cheek, but it brings up an important point. Many times there's a tremendous there's a tremendous disconnect in who's doing the research and who's being studied. Currently, minorities make up probably, URMs make up, and this includes Asians, about 10% of all scientists in the United States that are funded by the NIH. So it's not going to happen, but my question to you, the panelists, do the teams need to reflect the community at which they're doing the investigations? And if not, how do we get around it?
Let me just start with that. The teams probably are not going to reflect the communities based on the pipeline. And we can look around the room. The pipeline is very different than what we might advocate for. But I think it's very important to do community hires. And I made certain that my team does reflect the community. It might not be at the PI level. It is with me, but at the PI level in general. But having, I recruit from the community, hire from the community. I recruit from the community, hire from the community, and make certain those individuals become our peer advocates out for promoting our studies. As an example, we have a Center of Excellence grant for health disparities at Georgetown, but the idea that we have organizations that we've brought in and partnered with, and we've hired the individuals from those communities, we have met our goal for recruitment of all of our clinical trials, but it's because the face that they see is somebody that they are familiar with, comfortable with, and also we spend a lot of time educating at every level.
So for all of you guys, I'm going to put on my reviewer hat because I've been spent 6 years on study section, and I have a response for every solution you have. So the question is then, you're going to ask for more money to do minority recruitment. Is that fair to folks that are not studying minorities?
Let's go back to before women and minorities were in vogue at NIH in 1993. No one has ever cared before. So I think that it's important that we do ask for the monies that are needed to be successful to make our recruitment goals. It's not about because we want to get minorities in studies, we need more money. It's what is absolutely required to be successful in the study. When people fund studies that have, and you have to have so many percentage of minorities in a study, for example, and they're not willing to pay for the recruitment costs, you're going to be unsuccessful. So I said it has to fit the study. And I've been a reviewer for probably 25
So for
years.
people that don't know, whether or not you include minorities into your study section is considered a review criteria, but it's the last one, and oftentimes the grant's already been approved before that we get to that criteria. So I just want you to, the audience, to know. So you're saying that we need to revise the NIH study section. Is that what you're saying?
If people want minorities in studies, I think it's very important that they understand that you have to pay the people to help provide the support for the study. And it might be at the community level. And often I've seen where community level payments have been cut back because the reviewers didn't think it was feasible or they should be doing it. So,
Okay. I'm going to open it up, but I want concrete, positive suggestions. We don't need to point out the problems anymore. We know that problems exist. How are we going to fix it? And how have you fixed it in the past?
I just want to say about minority recruitment or recruitment in other types of populations. We've talked about lots of different kinds of populations that are underrepresented in research. It's not necessarily more money, it's different money. So if I look at the fact that, like you guys, my team is very representative of the community, and my team includes faculty, recruiters, and community members who are the community. I'm not saying it costs me more money because I look at my neighbor who doesn't do that, and she's not meeting her recruitment numbers, and she's not retaining her patients, and I am. So I find that our track records will show that we succeed in research, and that's what we're paying for. So in terms of efficiency and effectiveness, I think the money is well spent. So I don't.
So you
actually
just pointed
think it
out a
costs more.
problem that was raised earlier. You have two funded groups. One's recruiting, one's not. They both set out to recruit. What should we, as a scientific community, and what should the NIH do when you have someone that's not meeting their recruitment goals? I need an answer. You have the director of the NIH here, so you can.
No,
he's listening.
I think that we need help. I think we need to be honest when we're having trouble. This year, we had trouble. I'm developing an app with community partners. My community partners have never developed an app before. My people at NIMHD, who I love, are going to allow me 1 year of taking $1 so I can get my act together and then go back later. So there have to be stretches of models when we're dealing with different populations. It's not like you're bad, you lose all your money. It might be you need a longer time. We're not going to give you more money, but we'll let you stretch it out differently. And I think we need to help each other. There's people like you who know how to do it and you win.
You should be helping people who are trying to do it and don't know
Well, we
how.
have two different models. We have a model, the boots on the ground model here, and then we have Dr. Liu, who's organizing MESA and Cardio, which are national efforts. So what was been your experience?
Well, in terms of, well, there are several questions. First, in terms of the investigator and the staff, I think the PI doesn't have to be exactly the same representing the community, as you know, but the co-investigators, we do have the team has all different kind of ethnic, we're from different ethnicities that can kind of relate.
So you're saying have a diverse team?
Yes.
And we actually do this in healthcare for Spanish-speaking patients. We want Spanish-speaking providers and Asian-speaking. We want Cantonese and Mandarin. It's common. It's a business, makes business sense, right?
Right. And the most important thing is the staff. I agree with Lucille that the staff members definitely need to be, either we recruit from the community or they have some tie with the community, and that will help a lot with the recruitment and retention. But in terms of the second question you asked about what the NIH are going to do if you promise to recruit that percent of the minority, but you didn't. I think my experience with HLBI is they followed pretty closely. I think every year we have to report down what.
I wouldn't do that because I just showed you data that 4.5% of all studies included minorities. So that's not a good example. I want positive suggestions on what we can do and what if you could repeat your career. What did you do right and what did you do wrong as far as with respect to recruitment?
Well, I think as an investigator, I would definitely will keep our promise and do whatever we can to achieve the goal of the recruiting the minority. I think NIH as a funding agency probably has to also watch carefully, evaluate annually about whether the investigator reached the goal. I think in this way we can work together to accomplish the goal.
A little bit of a political question because if I, as a reviewer, and you're a reviewer, and we sit on review panels, I can tell you there are very few minorities. It's usually one or two minorities on those review panels. So when you talk about defunding people, you don't talk about defunding people because the people there will defend the people whose numbers have gone down. So I think that's a very political question.
And that's very insightful. These people here probably don't realize that there is a reviewer bias, and that's been brought up by the it's a campaign being taken on head on by the NIH and Dr. Nakamura. And along those lines, yeah, when I put in a minority only study, the critiques that I get is where are the whites? That's not only for R01s, but it's for publications. So we have 3 minutes before I open it up to you guys in the outside, but some emails and tweets have come in. So I want to take advantage of this. What do you recommend to sustain minority participation in longitudinal studies? What can you tell the audience here?
Based on my experience with the Black Women's Health Study, we've been at 80% for over 20 years, and we're still going strong. I think it's the continuous engagement, continuously giving back information. Every year, we're doing something with the community, with the population. They always are hearing from us, and either they like the design, they like the study, and it's feasible for them to do, and they continue to do it. So,
Okay. Next. Okay.
In both Cardia and MESA, we follow the people, both Caucasian, African American, Hispanic American, and Chinese American, and we follow for a long time, and the participation rate is still very high. So we definitely should. But I think there are several issues that we have to do that. I mean, in how do you accomplish this goal is important. You really like what we do is we have. I think probably you're doing the same thing. You send the birthday card, the holiday card, in some cases a sympathy card, and also newsletter, periodical newsletter to tell them the findings, and so make them feel like they contribute something. You appreciate them, and you have the periodic follow-up every 6 months or 1 year. You have to contact them, update their address, and so on. So all these things, and you have to have a very friendly, good, and persistent the retention staff, because my retention staff, like one worked for me for 25 years, and so they all the participants, they know her but not me, you know. so this is very important.
In my experience, because I recruited actually in African American, Hispanic, Asian, and white communities, and each recruitment strategy differed. So what I want to ask the panelists is, what sorts of incentives should we have, and should they be equal across the different study populations?
I'm not sure, like financial incentives different based on the patient population. I'm sorry, I didn't understand your question.
We want to encourage participation of research participants from a variety of different communities, different settings. That's SES, high SES and low SES, geography. And how do we incentivize them to stay in the study? And I realized in my experience, to engage African Americans and Hispanics was a different approach than it was to engage Caucasians and Asians. Dr. Liu?
Yeah, I think if you talk about them, well, what we gave them is the incentive that we give them a little gift, you know, when they come to the clinic, and we definitely pay their transportation. You know, that's very important. And in terms of monetary incentive, our IRB requires us to be equal. You cannot separate. So this we give more, and this we give less. That's definitely not allowed. And a little bit of monetary incentive will help. Definitely will help.
We also rely on our community partners and use stakeholder engagement. So we have people from the community, people who are like the study are going to be in the study, and say, what do you think it should be? What are the recruitment approaches? How much should we pay? How should we pay? Because they will know better than us.
Okay, we're going to open it up at 12:10, but we're early, so I will give the first one to Shriki.
Yeah, thank you. Thank you for those insights, and for challenging us to moderator, for challenging us to really talk about solutions. So I want to talk about educating people while they're in a study, because we know that there are social factors that relate to the expression of disease predisposition. And so you picture a cohort whose health is getting worse while you're watching them, because they're not getting information that will help them fix the part that medicine can't fix. And I just would like to hear you comment on that.
We don't have the formal education because these studies are observational studies. We don't want to influence too much. However, we do, if you are interested, I can send you some MESA and the Cardia newsletter. In the newsletter, we do have a finding. We also suggest the healthy eating and that kind of things. We give them the information. Also, we have the website, the public website for them to, participant website for them to see these things and so on. And so we send every 6 months a newsletter in MESA and the Cardia every year and so on. So these are the education, but we never done the formal educational session, like get all together to teach them how to do it, because that's a little bit it's an intervention that.
I just want to raise the question: is anything that we usually do, or our rules, are they up for grabs? Because it's come up. You know, the very first speaker said that we have our rules about how everything has to be done. Randomization.
No, the point was the rules need to be overhauled. I don't know if you heard that. The NIH review criteria needs to be overhauled. That was one rule that needs to be fixed. And we have suggestions.
Mine might not be a representative experience, but I have a community board and they have an equal vote, so I can't do stuff in the study unless my community agrees to it. So the rules are don't ask a question if it's inflicted insight and you're telling somebody they're screwed. So we can't ask depression questions if somebody screens positive and we don't have something to suggest for them. We can't do domestic violence questions. I couldn't do a sleep apnea question unless I could get portable sleep monitors for testing for people. And we did it all. So I don't know what that's going to mean for 1 million people, but we've worked really hard to get incredible exhaustive resource lists of what's in communities, because my community partners have said, don't ask questions that show people that they're. So I don't know what you can do with 1 million folks around the country, but that's what we do in Harlan.
Okay, we're at 12:10, and I'd like to open it up for the next 20 minutes.
Thank you, panelists. My name is Aaron Saib. I'm with the National Association for Trusted Exchange. And I think I heard one of the panelists indicate, part of the retention strategy is to get information back to the actual participant in the trial. And by doing that through the EMR, and I think that that's a very poor distribution channel, and we should be looking at how do we do distribution through initiatives like the Blue Button Initiative and other ways.
Yeah. The EMR was really designed for billing and not for management of patients. That'll need to be overhauled. Sure. All right, next question.
By the way, we in the study, we send the result letter to the participant directly, not through the EMR. We send the result.
So I want to
There's a question in the back there.
Latrice Landry.
Dr. Hudson, go ahead.
Okay, so I'll go and then you guys can go. So I have a question about returning information to research participants. And Carol, you talked about information going back to the physician, and that's sort of clinically validated, well-established information. What's your suggestion about what we do in the cohort? There's going to be some information that's going to be discerned that I think everyone would agree can be readily shared. What's going on with the cohort? What kind of research is going on with the cohort? What are the research results? And then individual information that we could probably enumerate that's well validated, important information. But what about everything else? You talked about potentially confusing people, but there's some people who are not going to be confused and would like access to everything that's known about me. I want to know it. And there's not that much information that I'm aware of, and maybe you are, of people who are actively seeking information, including research results, then having sort of bad things happen to them, right? We're worried about giving people information that they're not going to be able to understand and use effectively. And so maybe we don't want to force it on people, but what about the opportunity for them to access it if they're actively interested in
So in my experience of 11,000 patients, everybody's wanted the data back. The data is only useful in aggregate form, and it's only useful if we have CLIA-approved labs that are doing the testing, and that might have changed. But we don't give back information. At least my studies, we don't give back information. So we study genetics, and many of the genetic risk factors that we're looking for are only informative in aggregate form, so like with thousands of individuals. And by the time we sample an individual patient like me, my data is only good if there's an additional 9,000 individuals, and that's several years before I know that information. When we get information and we publish it, what I routinely do is we disseminate the manuscripts to all the participants, all the community participants, and usually I will go to the community clinics and actually give a presentation. Point of fact, when Dr. Collins was rolling out the 1,000 Genomes Project, I actually spoke at many community clinics for Hispanics, serving community clinics in the Bay Area, to inform promotores who you met earlier, or you heard about earlier, and they rolled it out to the community.
It's an interesting statement. I think the question that you raised, I think it's really important to have the input and buy-in of the communities, the different communities. They won't all be the same across, to find out what's going to be important. And I'll take an example. We did an environmental study, and we have indoor and outdoor monitoring. We gave back the aggregate. People wanted to know their individual. So we can tell them that they had these high indoor exposures. But then we had to send over environmentalists to show that, oh, you're storing gasoline in your house. in your living areas. You're doing all these things that you shouldn't be doing. So as long as you have a plan for following beyond just giving the results, I think it's okay. But I think, and as long as it's congruent with what the community says, but also if you don't have a plan and you come up with, and you send people some information, like the environmental data as example, it's like, we better call the environmental people to explain. And we started doing an educational program around that topic, which was not of interest to me at the time, but became of interest because of one of our results. And then they learned that, your biggest problem was not your house per se, but what you were doing within the house. So we could actually modify a change based on that.
So I'm going to go to the next question, but this is a little disclaimer. Each of us is giving our personal experiences of our own recruitment, and it's not the agenda set by the PMI, but our experiences and your experiences will be collated and will form the agenda. So the next question in the back there.
Hi, Latrice Landry. I'm a biomedical informatics fellow at Harvard Medical School on rotation here at the National Library of Medicine. My question is regarding physician engagement. In 2014, Research for America published a report highlighting physician referrals as a key determinant for minority participation in clinical trials. We've also had 3 of the panelists acknowledge the importance of physician engagement in not only the recruitment of minority participants, but also the translation and dissemination of those results. So I was wondering if the panel could address effective strategies for inclusion of physicians or engagement of physicians in the PMI cohort.
Can I just modify a little bit, not just only clinicians, but healthcare providers? And one thing that we have done to get around that in some cases, because when we talk about underrepresented populations or underserved communities, they often don't have their own physician anyhow. So I have on my staff a nurse practitioner. Actually, we have 2. So that, because nurse practitioners can independently, they don't have to be supervised, and they can evaluate, examine, and actually refer them into our studies if they meet certain criteria. So we use nurse practitioners, but also they help the physicians in general. We have a good linkage with our community-based physicians as well. So those people who do have physicians, we can get referrals from them. And we also include in our IRB letters of referral from the physician or nurse practitioner that has to be signed, especially if they have we do a lot of exercise interventions and all, and we need to make certain that they're not getting ready to have a heart attack today. But we also do stress testing. We do a lot of things up front, but we do seek the healthcare professional, but I have built into my staff nurse practitioners that can also help.
Great. Less 30 seconds. Go ahead.
30 seconds.
Mm-hmm.
Okay.
We got 14 minutes total, so I'm not being rude. I just want to be on time.
Okay. I'd like to say that in some places, in reference to whether or not the PI should look like the community. In some places, it may not matter, but in Jackson, Mississippi, it does matter. Jackson is 75%.
This is an important. We should discuss this because this is an important topic.
Yeah, Jackson, Mississippi is 75, 80, probably 80% African American. The county in which Jackson resides, which is the capital county, Hinds County, it is over 75% African American. And we had an African American PI for 13 years. So now there's a search on for a new PI. The community has come out very strongly and said they want an African American PI. The staff that was responsible for the groundwork, the community engagement, the community outreach was from Jackson State. And now we are a community outreach center. Initially, we were not. So the feedback that we get is, yes, this is what we want because this is what we think is reflective of our need. So I think the funding agencies need to seriously consider what community says. We can pay lip service for years.
So 2% of all NIH-funded researchers are African Americans.
Absolutely, I know that.
No, given that fact, given what you just said,
you have to look a little harder.
What's the solution, though?
The solution is an African American PI. That's the solution. You know, the staff is very diverse. It's a 3-partnership program. The University Medical Center, Jackson State University, and Tougaloo College. So, and we all have our roles. We're one study, but we also have the responsibility. Jackson State has the responsibility for maintaining the cohort. We have an almost 80% retention rate. We've been in business for 15 years. So it says a lot about who's on the ground and also who's at the top. Thank you.
You're bringing up an appointment. It's the elephant in the room that no one wants to talk about. No, it's not about you talking about it. No, I've heard you. I've heard you talk about it, and I agree with you. But everyone else has to talk about it because everyone else is at the study section deciding who gets funded and who doesn't. So given the numbers I just told you, I need concrete solutions. And I don't think we're going to get them today, but and it's something that we've all been working on for a while, the pipeline. And it's going to be impractical probably to have teams of studies reflect the communities that they're being studied. So we're going to have to be creative. So go ahead.
In 2015, it should not be difficult to get an African American PI. This is 2015. We look a little harder. We become a little more, we offer more opportunity. We make it more palatable. There are a number of things, a number of ways that it can be done, but it must be done.
And I keep trying to send names of people to recommend for that position.
We should probably go on to the next question. Next question. And I think she's been patiently waiting for 10 minutes or more.
But these were great questions. Beth Ann Baber from Nicholas Connor Institute, but I'm also here representing the San Diego Blood Bank. And as an example of an existing infrastructure that is trusted in the community, that sits hundreds of thousands of people across the U.S. of diversity in terms of economic status with their blood mobiles, in terms of race and sex and age, except for the younger ones, but there is a core blood bank to get together children information. But that is an infrastructure that's pre-existing, that collects biospecimens, that's highly regulated by the FDA, in some cases maybe the EU, so this is an infrastructure that could be utilized for some study to partner with researchers.
That's actually a very good point, and one that was raised in the last meeting in Nashville about blood banks and biobanks. Next question.
Nancy Roach, Fight Colorectal Cancer. And this is a suggestion. Most universities, I do a lot of different things with universities and cancer centers, and every single cancer center and university has a development office. Some of them have community engagement offices. The community engagement people actually do a great job sometimes of really engaging with the community, and there are lots of different models out there. I think if you go through some of the community engagement places, that might be one way to get into the community, and also really requiring in study sections that the rubber hit the road. I, as an advocate and a woman, I've sat in study sections where I've raised issues and basically been told that I was wrong, at which point I say, well, no, actually, I don't think I am. But it's hard to get that voice out.
I agree about the community engagement groups and all the diversity stuff, but at the big universities like mine, that's the first thing to get cut. So, sorry. Next question.
Hi,
wait. Spiro had a question. You're patiently waiting, Spiro.
Thank you. Spiro Manson, Centers for American Indian Alaska Native Health, University of Colorado. Two observations. First is I do think that we are beginning to make some important strides after the Ginther report in terms of the representation of racial and ethnic minorities in principal investigators.
Which report?
The Ginther report in 2011. In fact, under Dr. Collins' direction with the recent National Research Mentoring Network and the NIH investment in that of $20 million over the next 5 years, I think recognizes the problem and I think provides at least some possible solution in the short term addressing this. It's not without many other challenges. But, Dr. Burchard, you brought up the term incentivize, and then it was picked up by a couple. I submit to you that if we have to default to the term incentivize, we've already lost the battle, because it implies that there is no intrinsic value seen by whatever the nature of the enterprise that we're seeking to involve people in. I think that there are other sources and forms of value that they relate to the sense of control, efficacy, and personal investment and return, rather than a pair of Nike shoes for Indian diabetics to get them to participate, rather than $20 to encourage them. I think the notion of IRBs, for example, reminding us that compensation is the term. And what is compensation? What's the difference between compensation and incentive? Compensation is the recognition and the payment for the valued contribution that people make, not to entice them in to a scientific study. So I think it's really important that we understand those kinds of distinctions, and that and it places the burden back on us in terms of ensuring that what we do is of intrinsic value to the people we hope will participate.
This is Megan O'Boyle from Phelan-McDermid Syndrome Foundation, and I wanted actually the room to address the returning of data, but since we're talking about patient engagement and health equity in this session, I wanted to bring up the issue that our foundation has, or our disease group has, which is out of 1,300 people in the world, they're pretty much white and high socioeconomic because it requires genetic testing to get the diagnosis. And you have to have good insurance or be part of research to be in genetic testing. So my question is, will there be across-the-board sequencing or genetic testing for the million-person cohort?
We expect so, yes.
Excellent. But that information will not be returned, or that is up in the air to discuss?
Well, the purpose of these meetings is to gather information, and we'll make a decision collectively down the road. But your point is well taken.
Okay.
Next question. Jen. Go ahead.
Hi, Shaniqua Collier from George Washington University. My question is, to what extent, if at all, is or should how we define minority groups be on the table when thinking about recruitment and continued engagement? So we reference minority groups, for example, and Asians, for instance. When we're looking at a study that only includes people from maybe Korea or Han Chinese populations, and we define those groups as Asian, won't that affect not only our understanding of risk in those groups, but also our ability to meaningfully engage with people from particular subgroups?
Yeah, and that's a wonderful opportunity for me to talk about the most recent lawsuit by the Attorney General of Hawaii just sued Bristol Myers Squibb for marketing Plavix, which is a blood thinner and heart medication, to Asians, knowing full well that it doesn't work in 55% of Asians. So if you're Asian on Hawaii having a heart attack and you went to the ER, the likelihood that you got Plavix is high. The likelihood that you got a placebo is high. So they just pulled Plavix from the market in Hawaii. So that's an example of why we need to include diverse populations. Because if we don't, we're missing out on scientific opportunities.
Hi. So with regard to what Dr. Manson so very effectively said about incentivization, there are intrinsic incentives to conducting these studies. I didn't have to spend $1 in the study I conducted on asthma and sleep apnea to incentivize people to join the study. I had to find them, but once I found them, they started sharing what they learned about their kids with others, and they started lining up for the next part of the study. Ultimately, we didn't get that funded, but the reality of it is that we did manage to train a number of people in the community about how to get their houses free of dust that was bringing the dust mites that the kids were allergic to that was causing their asthma. We worked with the community leaders to help them to identify ways that they could participate in their own communities to make them healthier communities. And for that reason, that was the only incentive necessary. We need to reconsider financial incentives and identify ways to do something other than finance.
So we have 2 minutes, and there are two people with questions. Go ahead,
I'm
real
sorry,
quickly.
can we let the panelists respond real quickly to some of these things that they've heard?
Sure.
Okay.
Can I fully agree with you. If your goal is try to recruit patients, I mean, they have some health problem, and they probably are likely to volunteer without any, incentives or the other kind of incentives. But for the healthy population, like in Cardiac Mesa, we recruit the healthy population, we follow them and see who developed disease and so, and the etiology of the disease. Then it's probably very difficult. You think without any incentive, you get a very high participation rate. I just think this is something need to be think about, need to be considered. But the main issue is IRB does not allow us to separate. This we keep this we give that. We cannot do that. So.
I also think, I've had projects where people line up and are very happy to be part of it and the community introduces it. I think, for example, our biobank, where you're giving a tube of blood and you're not going to get any results back, people might feel differently about that. So if it's a well population or if the benefits, like you have a study with clear benefits to a population. Some studies don't have clear benefits and they probably still need to be done to somebody right away. So for those, it's difficult. I also believe that when it comes to compensation, I get compensated for my work, and if you're a participant and you're going to spend hours and hours over a long period of time, it is my absolute pleasure for you to be compensated as well.
Yes, I just wanted to directly contribute to answering Dr. Hudson's specific question about giving the results back, and Sue Bachman from Columbia University. And for our WISER cohort, we do directly give back individual results tailored to the participant. We designed the results, the strategy for giving the results back as innovative infographics designed for individuals with low health literacy. We designed it with the community, we tested it with the community, and then we built an electronic system to automate that so we could return the data to 6,000 people.
Could you elaborate on what study that was? And then
This is our ARC-funded Washington Heights Inwood Informatics Infrastructure for Comparative Effectiveness Research Study.
And the disease outcome that you're working on?
Hypertension.
Hypertension.
Yeah.
Wait, hypertension in whites? I'm sorry, I missed that.
WICER, W-I-C-E-R, is that right?
No, it's Latinos, Latino immigrants, primarily Dominican.
Can I say one word? I mean, just about Dr. Hudson's question. Well, in our study, we gave the result back. That doesn't cause any confusion. We told them that this is a research study, and these are finding. You need to consult with your physician for these results and what needs to be done. But I think for genetic, actionable genetic abnormality, that's different. It seems to be because that's related to their family. It's not just the person, individual person. That we need to think a little bit more about how we should do that. Maybe on the consent form, we should say we're not going to give you the result, or we should say we'll give you the result. We're not going to provide genetic counseling or verification, and it's your responsibility. We have to make it very clear to them, and then if they participate, there is no problem. Otherwise, people receive that, and then what am I supposed to do? It's really raised a lot of anxiety. So
we are close, but you've been standing there for 30 minutes. Okay, great. Well, oh, you work here, I guess. Okay. We all work here. So I have two things to announce. One is we have a face-to-face interview, NIH interview. They're kind of like the storytellers with NPR. It's a wonderful opportunity to talk about your view of precision medicine. Also, there's a face-to-face lunch, and we encourage active participation and dialogue amongst people that normally don't talk to each other. So thank you for participating, and we ended up pretty close on time.
This is session 5. It's focusing on establishing collaborative and inclusive governance in a large study, such as before us. I'm Spiro Manson. I'm from the University of Colorado and a member of the working group. We have this afternoon 3 presentations between 12 and 15 minutes each, which will move from a broad framework with respect to examples of governance and the principles underpinning that, to a more specific example of also principled governance, and ends with a very, very specific program of work that illustrates the lessons learned from implementing those principles in the everyday world. Our presenters in order this morning are Sue Sheridan. She is with the director, she's the Director of Patient Engagement at the Patient-Centered Outcomes Research Institute, PCORI. She'll be followed by Mr. Al Richmond, who's the Executive Director of the Community Campus Partnerships for Health. And in the cleanup position, we have Dr. Consuelo Wilkins, the Executive Director of the Meharry Vanderbilt Alliance, and Associate Professor of Medicine at Vanderbilt University School of Medicine and Meharry Medical College. Now, to this point in our conversation today, we've discussed outreach, engagement, recruitment, retention, critical questions cast within a disparities framework, and ultimately dissemination. My sense of it is that although those have been challenging topics, both in terms of theory as well as practice, there is a lot of experience in terms of implementation with good models that hold promise for doing those aspects of this work well. This particular topic on governance, I submit, has much less background with respect to successful models, although what we are privy to today will illustrate, I think, some wonderful illustrations of what's possible. I also submit to you that when we get to matters of governance, the conversation gets very, very tough. That there are lots of tensions that begin to emerge surrounding issues of control, direction, not just matters of inclusion, and to the extent that inclusion is part of the subject, there are real issues about what constitutes and how inclusion is defined and ultimately executed in the course of the work. And I think we'll see some wonderful examples in which, in 3 different ways, that challenge has been undertaken and holds promise for informing how PMI may move forward. So we'll begin with Sue Sheridan, move to Mr. Richmond, and to Dr. Wilkins. And I want to make a preparatory note, is that the members of the working group have had the opportunity for the first time really to participate as questioners and discussants. So I will pay particular attention trying to remain balanced in terms of ensuring that the general audience has an opportunity to ask questions, as well as attending to members of the work group, so that all voices are heard within the constraints of today's discussion. Thank you. Sue.
Thank you, Spiro, and good afternoon. I am going to take advantage of having a mic in front of me, and I'm going to wear 2 hats. And one of my hats is that of a patient advocate and a mom. So I want to build on what Susan Love said about women. I'm going to give a shout out to the moms in the room. I think Megan and Sharon and others in the room that I think that in terms of PMI, we could think of a strong cohort of mothers. They're powerful, they're change agents, and I know that CDC and HRSA and March of Dimes have an army of moms that I think could be really powerful in this initiative. And so I've also had the opportunity as a patient partner in research 15 years ago to see how just a little bit of data can spark change by connecting with others and making that data grow and looking at other data sets at DOD and at big healthcare systems. So when we think about PMI and people donating their data, somehow we have to share with them that a little bit of data can spark tremendous change and change outcomes. So I am a believer in PMI. I think the word that comes to mind, as we've heard this morning, is opportunity and passion. I'm really excited about it as a mom. I was, back in 15 years ago when I donated data, it was via Federal Express. I also did what we called back then a spray and pray when I donated my late husband's tissue. He had a rare synovial cell sarcoma, and so I did the spray and pray and just sent it to every researcher and every institute I could, not knowing if anything ever happened. So now with PMI, I think for enthusiastic people who want to share their data, who want to share their biospecimens, hopefully we can create something to capture that passion and their data. So today we're going to talk about establishing collaborative and inclusive governance in a large study. And I've really thought about this title, and we had the privilege of having a conversation last week in Boston that was organized by some of the PMI staff, and that there were little working groups that formed, and we looked at this word governance, and we thought, as Lucia said this morning, maybe we should start changing our language a little bit. And because governance actually didn't seem to really represent what's right now happening in PMI, at PCORI, in patient-driven research, where it's more a collaborative continuum. And so I don't know if governance is the right word, but it is important. Like Spiro said, we need to know who's making the decisions. We need to know roles and responsibilities, and so I will address that today. So I'm going to talk about a little bit about PCORI, the Patient-Centered Outcomes Research Institute. It was formed in 2010 by the Affordable Care Act. The underlying premise of PCORI, and this was our mission that was created by our board, is to support research that is guided by patients, caregivers, and the broader healthcare community. So PCORI is taking that quite seriously. They have two funding criteria. One is that all the research that we fund must be based on outcomes that matter to patients. And the other criteria is that patients and other relevant stakeholders, and the team approach, must be engaged as a team member. We're not talking about the subjects or the participants, but as a team member on that design team, creating it, planning it, conducting it, and disseminating it. So we shook up the research community a bit, but it's been fascinating to watch the evolution of research where patients and others are true team members. So we took that principle of engaging patients at every level, and we embedded that in PCORNet when that was started. PCORNet is a data research network. There are experts in the room who can tell you more. Rich Platt is here. We have people from our CDRNs and our PPRN, Sharon Terry, Megan O'Boyle. I think Sue Friedman's here. We have CDRNs here. So I would encourage you, if you want to know more about the data network, to speak with them. Today I'm just going to really focus on the patient engagement and other stakeholder engagement in the network and the specific programs. So again, a lot today has gone back to the word trust. And one premise that PCORI is built on is the premise that if we engage patients and others from the very beginning, it's kind of the Google principle, start with the end user and all else will follow. And so we believe by engaging patients and other stakeholders right up front that we will create research findings that are more trustworthy, more relevant, more meaningful, and we think it'll get implemented faster having patients there as team members. So as you can see up here, we have 11 clinical data research networks, or large healthcare systems, and then we have 18 patient-powered research networks, and you're going to hear from them this afternoon, that is really fueled by and driven by patients, their data, their communities, their families. So when we say patient-centered data research network, what does that really mean? And so PCORI kind of built this framework to help those who were applying to be clinical data research networks and patient-powered research networks to understand where we thought patients should be engaged throughout the development of this infrastructure. And so you can see here that we really encourage patient engagement in net recruitment and retention, which you heard earlier today, in governance that we're going to focus on during this panel, collecting and sharing of data, which I think you're also hearing throughout the day, and then network collaboration. I'm not going to read each one of those because I'm just going to really focus on the governance, but we really want to see patient engagement throughout each element that you see in this framework. Again, thinking that there's greater likelihood that patients will indeed participate in this research and donate their data and then get involved in the design of the research. So here is, we really are going to talk about the rest of the panel today, patients as partners in the development of the network governance structure, the roles and responsibilities, the development of procedures, bylaws, and policies for the network. And that's including policies for data sharing agreements, for what patient-reported outcomes are important to the patient community to collect and study, consent development process, and also topic prioritization. What are we going to study? We want to make sure that patients are engaged in determining what it is that's going to be studied, because we heard earlier today, if it's not representative of what the patient community is interested in, it may be difficult to recruit and really have a successful study. So in thinking about governance, again, I wanted to talk about, is this sending the right message, governance? And so when we were speaking last week together at the PMI event, we really kind of gravitated to today in governance, we're seeing, and I can say on PCORI and the research that we're funding, and others here in the room can probably confirm that within our PPRNs and CDRNs, it's evolving as almost a continuum of engagement rather than transactional engagement, piece by piece. It's more of a continual engagement with a multi-directional communication where people are wearing different hats at different times. So I don't have a real picture to show you, but we see this continuum of engagement really based on principles. And I think that no matter what the structure is of your governance, or of the governance of these PPRs and CDRNs, if the underlying principles are absent, I think this is going to be very challenging. So I can't stress enough the importance of these principles that we've heard at PMI last week, and we're learning within this engaged research community. In terms of partnership, something that was earlier mentioned, compensation, we see and we've heard from the patient community that when patients are designers and co-PIs and informers and consultants on the design team, that the patient community does expect to be compensated fairly and equitably. And PCORI just announced 2 weeks ago a compensation framework that's based on the level of engagement, what they're actually contributing. So it's a guide out there. It's not a dollar figure, but we think that is an important message regarding partnership. It's on our website. Co-learning. Want to learn from each other. Patients are learning from the researchers, and the researchers are learning a lot about the patients and their disease, their community, what's important to them. Reciprocal relationships, of course, transparency we spoke about this morning, and honesty and respect. And so when we were talking about is this governance, it's kind of a combination of roles, responsibilities, and principles wrapped into one. And it's kind of like, well, I'm getting married in 3 weeks, so I was thinking that maybe this is more like a prenup, like a science prenup, that we all come together with expectations and roles, and when working together, what we create together is community property. So we all create it, we all own it. So again, like I said, so I'm seeing the evolution of patient engagement. And when I say patient, I know that PMI uses participant, but it's ingrained in my mind. Patients and all the other partners who are necessary on that team, we're really seeing the evolution away from just a transaction of patient engagement, have a focus group, just get their data, just bring them in to design a research question. But we see it now as a continuum of, in a multi-directional communication. So at PCORI has, like I mentioned, we have created PCORNet. So we took a look at what is happening with governance in the PCORNet portfolio, and then I have some examples outside of the PCORNet in our larger research portfolio. So we really consider ourselves a learning laboratory. Like was said, Spiro said, There is no one model that we can say is the best, but what we're doing is collecting and looking at patterns and what we're seeing and getting feedback from the research teams. So here is one model, a governing board, and you can see the scale down at the bottom. So this is really one model where the governing board is patient majority led, or patient community majority led. Another model is with a steering committee and various committees under that, lower than 50% patients, but they're sprinkled all throughout the entire governance structure. And then a third model here is executive committee with a steering committee and other committees, but with a very solid 100% patient advisory council. And so this is also, we're seeing these three models are really what we're seeing emerging. Of course, there's variations. And again, no one model is showing that it's better than the other yet, but Corey's going to be following this. And I'm familiar with another model where it should be like concentric circles, where the patients are in the center, a board of governance of patients with rings of advisors. So there's research advisors around that, and then other agencies, the CDC and HRSA, the Joint Commission, other research institutes, other patient organizations, and then an MOU, or a Memorandum of Understanding, across that entire group that they all signed. You're going to hear Consuelo talk about their Memorandum of Understanding. So I'm going to go through just a few examples. I'm going to start with a CDRN, a Clinical Data Research Network. This particular example is a stakeholder-governed clinical data network that integrates data from 3 existing networks. So collectively, they actually have over 21 million patients at their fingertips. So when there's a query or there's research, they have this pool that they could potentially access. So this is the power of big data. And so there are clinicians, patients, patient advocates, caregivers. They all participate in the governance, along with the researchers and along with the system leaders. So this is a big governance structure. It's comprehensive, but it's broken down into different panels. So I'm going to just walk you through what one of the structures looks like. So in this CDRN, they have a stakeholder advisory board. You can see it has 26 clinicians and 20 patients or parents or caregivers and advocates. This particular advisory board is chaired by 2 patients. So they have a strong patient voice in this. Under this advisory board, they have 2 working groups. You can see that they have a governance work group, and they also have an education work group. And I'm going to talk about both of those groups. So the governance work group ensures that the network governance requirements and adherence. So this stakeholder board is kind of watching to ensure that the integrity of the governance is maintained. They also oversee and ensure and review all of the policies to make sure that they're as patient-centered as possible, that has integrated the patient voice. And then the education working group, the education working group really looks at the prioritization process. This really ensures that the patient voice is infused in deciding what research will be conducted based on what's important to them, what research questions and what outcomes. And then finally, they have a stakeholder research prioritization panel, and this is made up of 360 patients, clinicians, and researchers, and they provide input through a structured Delphi. It's an online Delphi tool. So it's it's consensus-driven. It appears to be very fair. It appears to be very robust. So we're eager to see the results from this particular structure. And I just want you to see that they have a really robust decision-making and deliberation process. They, as you can see, the patients requested to deliberate openness and transparency, individual choice, and safeguards, and they created policies based on the input from the patient community. And then they also had a prioritization deliberation process where they created criteria, the patient community and the other stakeholders, to really look at what would their prioritization process be and how would they deliberate each potential research area. And you can see that it was feasibility, scientific merit, and ethical considerations. So the last example I want to show you is the Patient-Powered Research Network. And we've got PPRNs in this room, so if there's questions specific to a PPRN, I would welcome them to come up to the mic and give your direct input. But I'm going to give an example of one PPRN that was really created by patients for patients. The PI is a patient herself, and on their governance, the patients have a 1-year commitment, and they have to go through research advocacy training, so that's a requirement. They also have a steering committee that meets bi-monthly, and they have an executive committee and work groups that meet weekly. So you can kind of see how robust, and when we talked about engagement earlier, it's engaging early and often. So this is a great example of early and often. And the executive committee and the steering committee, they actually created the profile and the roles and responsibilities of their governance structure. They have advocacy partners that are also partners, and they are on the network steering committee and work groups. And these work groups, the 3 work groups of the steering committee members, they're required to serve on at least one. So their steering committee is really active in really rolling up their sleeves and determining how the governance is going to take place. So I'm going to stop there. I have some in our dialogue. I can share what PCORI is seeing in terms of really engaging those to include diversity in governance. And we've got examples, but we can talk about that in our dialogue. So I will stop there. Thank you.
Thank you, Sue. It's wonderful. That phrase again was prenuptial. What was it again? It sort of works.
It's a partnership prenup.
Partnership prenup. It's great. And next we have Elrich Manel.
Thanks. Well, good afternoon, and hope you enjoyed your lunch and had a moment to kind of stroll maybe across the campus a little bit. And it's such a pleasure for me to be here, and I appreciate the fact that Bray reached out to me. And it's so ironic that Bray and Susan and myself were back in the winter. Were part of a roundtable that was sponsored by PCORI. And so when I received the invitation to come, I was trying to think through what might be some opportunities for us at Community Campus Partnerships for Health to really share the work that we're doing. And I want to talk a little bit about our organization and then highlight one of the programs that we are very excited about. It's kind of come to an end, but we have a new iteration of it, and how it, I think, serves as a guide for us to think about population health and to think about how we might address these issues around governance. I had my hand up in the last session, and I was like, nah, just take your hand down because you'll have an opportunity to talk a little bit later. And so one of the things that I'll talk a little bit about is really about the issue of trust and how we're doing this work. Hit the wrong button. So the mission of Community Campus Partnerships for Health is to promote health equity and social justice through partnerships between communities and academic institutions. We're 18 years old, and so we have a very rich and robust history as it relates to seeking to bridge the work that's being done both on the side of the academy but also in the community to address health issues, always with the lens of social justice and health equity. One such program that we worked with that we are very proud about is our community research processes. And so they're known by many different names. And so even today, I've been really excited to hear about the different variations or iterations of this work that's taken place across the country. And so the background of this work is the fact that even groups like the PMI group and others recognize that community engaged research has a critical approach to understanding and addressing disparities, and that communities are developing review processes to ensure the ethics of research that is done in their community. So we're all very familiar with the IRB process, which addresses protecting the rights of individuals. But the community review process is really about looking at protecting the community. So it really seeks to answer the question, who protects the community? And you've heard this morning several examples that have been kind of alluded to around issues as it relates to communities not having trust or feeling violated as a result of historic acts and even contemporary acts in research. And so our program, the community review process, had several aims. Number one, to articulate the research ethics and integrity considerations and experiences and outcomes of community-based processes for research ethics review. So the work on our aims have been focused primarily in helping us to understand what role might these community review processes play in influencing the research that's being done in communities, but also to address some of the ethical issues and ethical considerations. When I think about this work, I think about it in terms of the community review process actually is about placing the work in context. And we've been alluding to a lot of that this morning. We've been talking about where people are and what people are doing and the kind of describing the communities. But the community review process really targets the context in which research takes place. Oftentimes, I'm just kind of thinking about the fact that we think of individuals as, just an individual void of any community, void of any experiences, void of the culture and all of that. And so the community review process is designed to really take all of that into consideration before we go into the community and do research. So Community Campus Partnerships for Health convened a group of 5 very different community-based organizations across the United States that have organized a community review process. And you see listed the 5 different communities. They're very unique, they're very distinct. Each of them are working with different populations, addressing different issues. And so their community review process differs from one site to the next, but there are some common threads that are weaved through each one of those community review processes. So for us, we believe that the community review process provides a significant benefit to the community, but also it enhances the research. It enhances the ethical design and the conduct of research in the community. In many ways, the community review process places the community at the helm of the research. It really challenges the researcher in some ways to kind of give up this power. And Sue was talking about that power differential. And while we may those of you who are researchers say, well, I'm a nice person, I'm a good person, I'm an ethical person, I'm a moral person, I wouldn't harm anyone. One of the community persons said, it's not you that I'm concerned about. It's all the people that came before you and may come after you that I'm most concerned about. And so I think that the community review process actually takes all of that into consideration. It looks at the issues around literacy and the capacity and the ownership of the communities. It asks questions about who owns the data and who owns the research. It also talks about the work of what's been done before you came into the community and what's most important to the community. A lot of this work around community review process has been really championed by Native communities who, as sovereign nations, are saying that while we may have an IRB board, it's also important that you would take into consideration our culture, you take into consideration our traditions, take into consideration the morals and the values of this community as well. So as we were looking at these different community review processes, we recognized that there were some significant challenges as it relates to the operation of these different groups. And I've highlighted 3 of them, primarily around the area of inadequate infrastructure, funding, and respect and recognition. And I'll just say a little bit about the respect and the recognition piece, in that what we found is that oftentimes community review processes have to really work through the idea that they're not trying to undo the work of an IRB, but they're really trying to enhance the research by talking to the researcher early on in the process such that they can actually refine the research and improve the research that's going on in the community. So the review process might look at recruitment and retention issues and provide suggestions to the researcher around how that work is done actually in the community. And so as I was thinking about the work of the PMI, and Bray and I were talking, I was thinking this really provides an opportunity to kind of use this CRP process or framework as an opportunity for us to engage populations, large groups of people in our work, but taking into consideration the community and the context of all the work that we're doing. So there were several recommendations that were made in terms of on the part of the community. We recognize that there are issues around capacity, there are issues around knowledge and skill development. And so we highlighted several points that were made as a result of doing this kind of cross-analysis. And that was, we recognized, first of all, that we needed some professional development opportunities for those individuals who were actually serving on the community review boards or community review process. So individuals are coming to this as members of a community. They may or may not have an understanding of research, but they may have certainly they have an understanding of the community. And so therefore, there's some skill development that's really important. You know, as I was listening to the conversation this morning, and we were talking about how much information should be provided to the community, and I thought to myself, wow, why is it that we don't give more credit to the community? We really should give credit to the community. And I think about myself as an African-American male. I've been approached a number of times about being in a research study. So it's personal in some ways, right? And so therefore, I have the capacity to understand anything that a researcher puts in front of me, right? I feel like I have the capacity. I feel like my twin sister, who this week I asked her to participate in the study. We participate in a twin study. So I'm a social worker. She's a nurse. We feel like we can understand the process. We can understand the research questions and all of that. And I don't think I'm an anomaly. And I don't think other patients and other people in other communities are an anomaly. I believe that they have the capacity to understand the basic science. They may not understand everything, but let's give the community credit for what they do know. So also it helps us to join with allies in the academic community and the funder community that we recommend that they would actually come together to help support community review processes that are occurring in the community and across the country. As it relates to institutional IRB boards, we made several recommendations there that we would increase the number of community partners serving on institutional IRBs, and to also ensure that community reviewers are genuinely connected and are at the very least familiar with the community in which they're doing research. And they're not just, we've kind of talked about the helicopter researcher just kind of flying in. Maybe we overuse that and maybe it's becoming a cliche in some ways. But it really moves us beyond that to total engagement within the community. Additional recommendations for funders would include to provide funding for the development and the expansion of community review processes, but also to encourage funders who already support community engaged research to share best practices and lessons learned with their peers. And perhaps if, as we move forward with this work around the PMI, we would find an opportunity to share best practices and connect and build a network of community review processes in the United States. For federal policymakers, it would include to consider replacing the current IRB structure, which is radical, right, with a research ethics review board that are independent from the entities conducting the research. And so it makes it very impartial. So by engaging the community and working in tandem with the community as well. So the next iteration of our work has been funded by the Greenwald Foundation, and we're doing the Greenwald Foundation study, which articulates a set of ethical principles for community-engaged research. We felt like we had started with really a study several years ago looking at the over 100 community review processes in the United States. Then we targeted 5 of them and have been working with them, and that same cohort 5 are working with us now around drafting revisions to the Belmont Report, primarily to look at what are the ethical considerations for the community. Again, moving away from the individual, but placing this in the context of the community. I should acknowledge that our initial work was also funded by the National Institute of Environmental Health Sciences, and that this particular work, again, is funded by the Greenwald Foundation. I want to acknowledge our community members across the country who have been a part of helping us to better understand community review process and contributing greatly to a study that we've done. Our case study can be found at our website, and I would encourage you to look at that. Before I joined Community Campus Partnerships as the executive director, I was excited to see this report, and I feel that it really represents the best. It's a great example. It highlights the general findings of the work, but also highlights the specific challenges and issues that each of the community review processes have undergone. So again, thank you, and it's been a pleasure to be with you today.
Al, thank you very much. Those are two extremely stimulating presentations, and in particular, note your reference to American Indian Alaska Native communities, and of course, in the series of historical incidents in our part, the Barrow Alcohol Study, the recent Havasupai and Arizona State University issues, don't really come up at the individual level, but they are matters of community and control, regulation for benefit of the community, which is assumed to also benefit its respective members. So the pairing of those two presentations is just wonderful. We're next privileged to have Consuelo Wilkins describe her work in a very specific manner. Thank you.
Make sure I can stay on time a little bit. I'm thrilled to have the opportunity to tell you about some of our work in community and stakeholder engagement, and I will not take Spiro's comment that the other two presentations were stimulating as him expecting that mine won't be. but just in case, you had two stimulating presentations already, so let's go with that. I'll describe a little bit our framework or guide for how we typically design a project that involves stakeholder or community engagement. I have the pleasure of leading stakeholder engagement for our Mid-South Clinical Data Research Network, but also co-lead community engagement for our CTSA. And this is really a model that we have worked on for a couple of years now, and I think it's important to emphasize that engagement happens across the continuum, and often we are sort of stuck with what is the one way to engage people, stakeholders in our work. Many projects that we design have more than one level, not typically all of the levels, but I will give an example that has multiple levels of engagement. As the panel is focusing on governance, I will spend most of my time talking about that, but would just highlight on the figure that you see that there is a darkened line that's dividing the advisory groups, and in the lower areas are reviewers and consultants, knowledge users. Typically, people above the line are or have been in leadership roles and are engaged in long-term ways on the team, and those who are below the line are involved for a short period of time. It does not mean that their involvement is any less important or that the type of information that you get can't be used to really guide the work. So I want to highlight one specific program that we have at Vanderbilt, and that's our BioView. It's a biorepository. Many of you who are in precision medicine or work in this space are familiar with it. We have now over 200,000 genotype samples that are linked to electronic health records, and it has a community advisory board that's been in place for 10 years now. The community advisory board has been very active. It advises BioView on strategies for engaging stakeholders. It also is involved in how we communicate with patients. They review all of the patient-oriented materials, but they have the opportunity as well to critique, ask for information. They prompt the scientists to do more research. One thing that I would say that's important about advisory boards in a governance context is that many programs or studies will have an advisory board, but they're not often empowered to do anything. They show up, you read them some information, you give a slideshow, and you don't really give them a chance to provide input. That is not engagement. Engagement is bidirectional. There has to be an exchange of information. You have to learn something. You have to give them the opportunity to share that. One thing that I think is great about the BioView Advisory Board is that they get to deliberate in private. So just as you do with your external advisory board comes, they hear everything you get to say, and then you leave the room and they get to say what they want to say. And I think that is important. If you really want honest feedback that you can use to transform your programs, meet your recruitment goals, you have to give people the opportunity to think about it. You can't just bring them to the table and say, hey, this is what we want to do. What do you think now? Tell me right now. Doesn't really work that way. And I highlight this also. So we've published on some of our stakeholder engagement strategies, community engagement and BioView. This is important not just to the research enterprise, but also to the patients, the community members, to know that we take their input seriously, we're going to act on it, what have we learned, and so we're sharing that information broadly. Next, I'll switch to our Clinical Data Research Network. It is funded by PCORI and part of the PCORNet program that Sue mentioned. So we have one of the 11 clinical data research networks. You can see in the middle of the figure here is our patient and stakeholder engagement core. I did not have to fight to have it in the middle, but I do fight to make sure that it stays in the middle and that everything that's going around the circle is relevant and informed by our stakeholder engagement group, our team. Sometimes that's easier than others. I would say when it's the hardest is when decisions have to be made rapidly. So it's easy to sort of overlook things when you need to make a decision rapidly. But we have in place governance that helps to alleviate some of that and make sure that we have the voice of stakeholders at the table. So this is our stakeholder engagement strategy. It was proposed as part of our phase 1 of our clinical data research network. You can see in that second column from the left the number of people that we propose to involve in building the infrastructure, over 5,500 people. When I proposed this, some people thought I was crazy, and I think most of them probably still think that I'm crazy. But you can see on the right side the progress that we've made, and we have actually a couple more months. I would actually say that it's been more challenging to engage the clinicians than it has been to engage the patients and the community members. So those of you who are thinking that this is really hard to do, it is not as challenging as you might think. For our governance, we have 2 governing groups. So one is our oversight committee that is comprised of 12 members. 2 of them are patient community stakeholders. And then we have a stakeholder advisory council that has 8 members. 4 of them are patients. For our oversight committee, as well as the Stakeholder Engagement Council, we developed a memoranda of understanding for both. And these were developed with our patient investigator. So we had input from the key member of our team. What should be in the MOU? What should it look like? And so we provide, what is the purpose of this? What is the charge? And then we have the responsibilities. And not just the responsibilities of those on the committee, but what are the responsibilities of the academic team. So the oversight committee is to provide guidance, They're to help us solve problems, foster communication and linkages in the community. We try to be specific about, how often we expect them to attend meetings and respond to correspondence. They have to sign a privacy agreement to be involved. But what do? We have to provide training and support for them. We have to make sure that we're going to communicate with them effectively. We're going to compensate them, and we have a dollar amount, and how often we're going to reevaluate that dollar amount. We say that we're going to uphold the principles of partnership and community engagement. So if you're not familiar with them, happy to share them with you. But a lot of them are things that you've heard today: trust, honesty, mutual respect, building trust, I should say. Those are very important in whatever kind of partnership or engagement you have, especially if it's long-term. But we also specifically talk about, we will make sure that we're planning meetings at times that are convenient for them and in locations that are convenient for them. And I think having these written also not just express our commitment to it, but make it clear that we've thought about this. We're not going to schedule meetings in the middle of the day without advance notice and then wonder why we don't have representation. I'll also share with you a little bit from a study, not a study, it's a survey, I should say, of our patients in our My Health at Vanderbilt patient portal. So this is data that we collected since the last Precision Medicine Initiative workshop, which was held in Nashville about a month ago. So we were actually just finalizing the questions and got IRB approval, I think, the week following. We added these questions onto the 5,000 surveys that we're doing as part of our CDRN. So we wanted to know, what do our patients understand, know about precision medicine, and how important are these things to them? Now, what does that have to do with governance? If we're going to be developing policies and programs around precision medicine, they need to be informed by people. So, as I mentioned, looking at the continuum, it's not just important to have people in governance, but they need to have information to act on and things to do. So we're very proud that in about a 3-week period of time, we were able to get over 1,200 respondents to this survey. The majority of them are white or Caucasian. About 11% are African American. 2.5% are Latino or Hispanic. 2% Asian. This does not reflect the patient population at Vanderbilt, but reflects those who use our patient portal. So I want to make sure it's clear that we're not saying that this reflects all of our constituents. And in fact, we actually just stopped collecting data using our patient portal. We're about 4,500 of our 5,000. And looking at our priority populations, we're going back to the community to do more on-the-ground recruitment, which is what we did in the beginning, in the community health centers, at barbershops, wherever people are is where we go. So I won't spend a lot of time talking about what this group looks like, but would also highlight at the bottom there. I'm not sure if this was collected in the study that was conducted or talked about earlier, but we do collect data on health literacy, numeracy. We have 2 scales that measure trust, willingness to participate in research. So we will be able to look at this data with all of those lenses. I think it will be important for us to think about what this means in different populations, but realizing that it's not necessarily applicable to all. I will highlight some comparisons between African Americans and Caucasians. So we asked 10 questions, so I'm only showing 7 of them, but we wanted to know how familiar people were with these terms: genetic testing, precision medicine, and pharmacogenomics. And then we also asked, how important are these things to you? African Americans are in the lighter bluish green color, and then the Caucasians are in the darker green color. So we did find that there are differences there were statistically significant differences in what the African Americans knew about genetic testing, or how familiar they were. This was not a knowledge test with genetic testing versus compared to the Caucasians. As you can see, though, very few people knew a lot about precision medicine. Surprisingly, they seemed to think they knew, or at least they reported that they knew more about pharmacogenomics, which was surprising to me. But when you ask about what's important to them, it's important that the care is specific to them. They were very interested in making sure that their health information was private, but they also want to know and they want to decide who gets their information. And the way the question is worded is, I decide which doctors and researchers get my information. So being in control of their data was very important to them. I think it will be important from the governance standpoint to make sure that we're using this to guide what we do, and perhaps more education about precision medicine might also get us past some of the barriers that we'll have around participation. I thank you for the opportunity to share some of the lessons learned. I think we've covered most of them. I guess I would end with saying that your approach to engaging stakeholders should be deliberate. You need to think about how many, what groups you want to represent, and there have to be more than a few. You need to think about the power dynamics in the room, at the table, and you cannot forget that all of this also requires training and preparation for the researchers, not just the stakeholders and community members. Thank you.
Consuelo, equally exciting. And as I was listening, I was reflecting on, did someone leave a cell phone here? That they shared a number of things. One was each was principled in its own fashion with an enormous degree of overlap among them in terms of agreement about what those core principles should be. Each emphasized attention to capacity and a commitment to increasing capacity of all participants in a variety of manners. They also emphasized the fact that there's important and critical attention required to the process as well as to the structure itself and the mechanisms for enacting those principles. And I thought it was just a lovely series of complementary presentations highlighting some of the major issues before us. But more importantly, not only are they major issues, I think they give us a real note of optimism that these things are addressable, even at the scale that we're talking about at PMI. So let's open it up. We have 30 minutes for questions. Pearl, please.
Hi, Pearl O'Rourke. Thank you so much. I would love to hear from each of you. The importance of community is clear and early engagement, but then looking at 1 million or maybe more within the whole United States, how would you define community? How do we make it workable? Do we end up with like a state and federal level things? And then what do you do with people who are in multiple communities? I'm in a cancer community. I'm also in a Irish Catholic community. And I'm also in, you can make up a number as people go back and forth. But again, how do we logistically get the information we need from participants in a respectful way, yet a doable way?
So I will say that obviously I'm biased by what we think of as our guiding principle around that. And you have to accept that you won't be able to engage every community because there are hundreds, thousands of different communities. But what you can do is engage individuals who understand the nuances and similarities, but also differences of communities in general. I think it will be a challenge to determine what who you invite to the table until you decide what the table is, right? Who's at the table? So I would encourage you, though, to also think about not necessarily having to have, one of this person, one of this group, one of that group, but making that an opportunity to engage a broader group. So I talked some about this, Sue did as well, about these larger groups of panels of people that you can reach into to get specific information when you need it. I think that now that we can communicate so easily online rapidly, that's much easier to do than it would have been years ago. But also, if you're going to be inviting existing cohorts to the table, I think you want to tap into those, their advisory groups, because I'm sure most of them, if not all of them, have those advisory groups. So thinking about what, in some ways, the state level and a federal level of involvement looks like.
Am I on? Oh, there. Just to add to that, you asked a good question. What is community? And, I think that just from observing the development of different communities, I think community can be, I think the underlying issue is that they all have a common interest and it's beneficial to all parties. And what we see is community can be very geographic. It can be small. It can be rural, southern New Mexico. But community can also be national in scope, coming together around one issue that matters to them. So community doesn't always mean small. It can be huge. And just to build on what Consuelo said in terms of how do we deal with all these factions and all these separate communities, not to go back to the mom issue, but I think that we can tap into big groups that they would want to contribute data where a variety of different research could take place on these big groups. So if we can prioritize some of these big groups and approach it that way, I think it might be efficient.
I agree. I think that I was having a discussion with someone on the bus over here, on the way over here, about community. And for me, I have an evolving appreciation and definition of community. For community campus partnerships, we've often talked about kind of this geographic space, place kind of community. But I've, really come to appreciate the idea of community being persons living with lupus or persons living with diabetes. And so I think that, number one, providing an opportunity. Oftentimes we haven't provided people with an opportunity to be engaged in the process, number one. And then I think number two is to allow people to self-select. So allow people the opportunity and the ability to define for themselves what they want to be. So they may want to identify with one community, or they may choose to identify with another community, or they may choose to have a sub-community. So it may be Latinas with breast cancer, maybe a subgroup under Latinas, right? So we have to kind of think about that. And then the third point would be that one size doesn't fit all. So to try and force people into some community is really against all the principles that we hold so near and dear to us. And so again, I think it's about allowing people to self-select and provide the opportunity to do that.
Thank you. Next question.
Yeah, this is a great panel. I have a sort of a background question. Could a community be multifactorial? For example, autoimmune and neurological diseases have a lot of common factors. And I spent the weekend at Dr. Richard I. Horowitz's Living Well with Lyme workshop, well over 200 people desperately looking for ways to boost their, knowledge about what works, various practitioners. Same things are going on in, people dealing with mold and mercury and other things. And it's like, in my ideal world, there'd be like a coming together of great clinicians, great researchers, and great patients that sometimes overlap to look at what are the cross-cutting factors. And I know that's somewhat different from the paradigm of, vary one thing, name one disease, focus on one disease at a time. Are we there yet, or can we get to the multifactorial approach? Because as human beings, we are very multifactorial.
I think it's. I think we're certainly there. There's no one group of people that identifies with one single thing. So, to presume that any community is homogenous in some way would be a mistake, or that any specific community only has one voice or one opinion. So I think it's very complex, but also an opportunity for us to identify what the shared principles and views are. And that will be important as well as we're looking to link some of these groups. We often will focus on how unique some programs or groups are or communities are, but there's a lot of overlap and shared principles. We've talked a fair amount about trust, and I think it's an area that we need to better understand. There are different domains of trust, and we've talked, obviously we're talking about equity and underserved groups, but people who are have been marginalized or are vulnerable, the domains of trust that are important to them are different than if you have money and access. If you have money, access, and privilege, you make decisions based on levels of competence and where people went to school and where they got their degrees. You're able to make decisions about that. But when you don't have those assets, resources, and privilege, you worry about safety and fairness. And you have to create a different model of value proposition for people if you want to engage them. But that is also common among many groups that are vulnerable. So you might have to tailor your messaging to them or tailor your approach. But if you recognize that they need to be engaged and respected and educated, then those commonalities can help you build what those approaches might be.
Consuelo, I think that as you were talking, I was thinking about this whole issue of generational differences that there might be. So when we talk about the context in terms of community and, you know, around a lot of issues, let's take HIV and AIDS, wherein individuals in a community over the age of 50, myself and others, might feel a certain way about talking about the issue. But younger people have few inhibitions about talking about anything. I think someone alluded to that earlier today. They'll tell you whatever you want to know, right? Just ask me. And so I think that we have to take all of that into consideration. So again, acknowledging that there may be some differences are important. Context does matter. And so where people might live and what their shared experiences have been. And so I'm a Southerner, and that's something that I'll be for the rest of my life, and I'm very proud to be a Southerner. But I'm also a Black Southerner. And so when I think about the context and what's going on in the country now around just Charleston, and that context matters, and where we're doing this research and who we're talking to and how we're pulling people together and the language that we're using, and all of that is so very important. So I would say we may want to tread lightly as we think about this work, recognizing that there are going to be lots of nuances over time, regional differences that we would have to take into consideration.
Those are both great comments. They remind me of the fact that working in the community, two things. I often hear someone say, well, the community, as if he or she represents singularly the community and not being seduced into conceding that. But the second thing is the changing evolutionary nature of community. And I thought, Al, your last comment about the generational differences in the context of HIV really underscores the importance of anticipating that the community can change over time, particularly when we're in studies that are 10, 20 years in duration.
It just challenges me to think about, while I was presenting on community review processes, I think it's important that if we were talking about a community review process in a certain community, that again, that community board or process could not speak for everybody in that community, right? So they might be able to speak to some of the cultural, contextual issues, but there may be some nuances, and there may be some people in that community that just might say, you know what, they don't speak for me, and may just decide to kind of go off on their own. So it might mean that we would have multiple processes going on at the same time.
So I'd like to follow up on this really interesting discussion, because you've highlighted the matter of trust in vulnerable communities in particular, and thinking about how to project that into a national cohort where we're talking about combining data across the nation. And secondly, regarding the issue of trust, one of the goals of the PMI is also to make this data as widely accessible as possible, to allow people who might have a great idea of a new way to analyze the data access to it, with the idea that this is not going to be going through an iterative process of every idea has to go through a formal review process. I'm wondering how to protect the interests of vulnerable populations in this context.
I would say first to recognize that there are vulnerable populations, to recognize that people come to the table with different lived experiences. As such, they may respond in different ways. So acknowledging that, giving voice to it, and not being afraid to just kind of tackle it head on, and asking very difficult questions about what would stand in the way of you participating in a large scale project. So Consuelo, it would be interesting to take that last piece of research that you were doing out of that survey and kind of stratify that by age, as well, and look at what people might say, if younger people versus older people. I don't know if today maybe, I know why. Today is Consuelo's birthday. So I figured I would get to it sooner or later, right? so tell Consuelo happy birthday when you see her later on as you go out. Yeah. So I think that you have to recognize that it is a barrier, it is a challenge, and kind of again hit it head on.
I'd just like to add to that, just in terms of trust. Looking at other large-scale attempts at bringing patients into research, and the lack of trust, and just the, like Al said, the importance of, number one, bringing that community into building what they are going to be doing, or having their voice in, like, being part of what research will take place. What will that governance of that cohort look like? I think that bringing the community in from ground zero will be very important. Another issue is that just in terms of community, just across the board, whether they're vulnerable communities or underrepresented, I mean, all patients really, like Al mentioned, opportunity. There was research done at WHO, I think in 2006, about patients wanting to be engaged in assuring better outcomes for themselves. And the number one answer was that they wanted an invitation. And so I think we have failed, or we can do better here in our country in terms of research by issuing an honest invitation and having an honest dialogue about the benefits. I think some of the best ways to ignite our community is by showing the benefits of research to their community, what's happened in the past.
So when I think about PCORI, patient-centered seems like an oxymoron to me, right? Like, duh, like that's what we should be doing. But we have to convince people that we're really serious about this, right? That we really do want to know what you're thinking, and we really do want to engage you. And one of the strategies that I've been a part of is that my family's participated in several research projects at our family reunion. And I served as a spokesperson for that research. I kind of vetted that research, my sister and I, and we talked to family members about it. We talked about the collection of tissue and all of that and how important it is in making a contribution. So I felt like there was an honest effort made by the researcher to reach out to me, and then I in turn could kind of like help shepherd that work within my family. Consuelo?
My sense of it, if just to interject here, is that people will be very forgiving of imperfect process. They will not be forgiving of absent process.
I like that. I would just add, though, to that point, we have to remember that Al's presentation about community, community is different than participant. So as we're thinking about what this looks like, engaging a participant, an individual person or group of participants who have similar characteristics is not the same thing as engaging a community. And we're probably going to have to do some of both. So when we design a study or program that will allow people to have access to data, there may be certain things that we will not let them have access to. So it might be important for Native people to say, I don't want my information to go out with identification with my demographic information, with my race or ethnicity identified. And that might be hard to say no to, but we do know from the recent past that there have been, communities have been marginalized and there have been challenges because of that, and we have to respect that. Not everyone who wants to do work with this data or with this resource will respect that they can't just put these labels, these social constructs on the genomic data and make conclusions because they might be erroneous. So there may need to be some process where there is a community level review for some of the requests, but not all of it.
Thank you. Lucia?
Yeah, so Lucia Savage, ONC. A lot of people think I miss practicality, and I guess my question sort of turning from the philosophical to the practical, one of the things I would be interested in hearing about each of your experiences, how do you translate the governance consensus that you've built into actual ways that people use, touch, disclose, et cetera, the data, and if you have gotten that far yet, and if you have, are there learnings from that when we think about the hybrid model that PMI is proposing?
I would welcome, we have some PPRNs in the room that you might be able to give really detailed, a detailed response to that, how you are really formulating policies that define what data can be used, when it can be used, what it can't be used for, what kind of privacy policies you want. Not putting you on the spot, but I'm Sharon, I'm looking at you, and Megan, you. I mean, I think you've got the true experience at your fingertips of operationalizing your governance in terms of really how the data is used and how your policies are created to govern that.
That's a great invitation. So in the interest of time, if just one of you could.
I'm speaking in the next panel, so if Megan, wherever you are, you want to do. Oh, that's right. Okay, we're both on the next panel, so stay tuned.
So I think that's a deferral, right?
Yeah.
In the far corner.
All right. Hi, I'm Allison Ryan from Academy Health. Thanks so much for the great session. I was really intrigued by the models that you've presented and echoing some of the sentiments this morning about early and often engagement of patients and consumers. I'm wondering if you could speak a little bit about how that's been applied in sort of determining what data are captured in your systems. So it's one thing for people to say, I want you to research this question, but if the data actually aren't built into the infrastructure to address that research question, I'm wondering if you've had to actually go back and sort of reconsider, based on those requests.
So I would say it's certainly a newer process for us to elicit questions from our patients and participants. And a bigger challenge is that when we do elicit questions, we have to find the researchers who are interested and willing to try and answer those questions. So we've tried to actually do that in a way when we're asking for them to prioritize topic areas. And so that has, for us, has gone to what our RFA looks like for our community engaged research program. So it may not be a specific study that's designed with with the patient or the community member, but those topics that are identified guide what our RFA might look like. I would also say that we have, over the last year or so, looked at some of our approaches to specifically try and understand how has the research changed due to stakeholder engagement. So not necessarily just at the governance level, but what specifically can we do, can we pinpoint that has changed. So a lot of it has been around recruitment, increasing recruitment, where we recruit, how we recruit, but also designing the tools. We specifically have been using a process that some of you are familiar with, our community engagement studios, where we might go through actually a survey, question by question, with a group of potential participants, or from that participant background, to say, what makes sense, what doesn't. And that might change the number of questions. Sometimes it goes down, sometimes it actually goes up, because they want, if you're going to ask me this question, this is relevant, and you should be asking about my pain, and I don't think the doctor's note's going to be right, so you really want to ask me instead of trying to get that information from the electronic health record. Ask this question first. I'm offended when you have the option for demographics as a domestic partner. Ask that in a different way.
I can address that from almost the PPRN point of view. I mean, the patient-powered research networks are kind of tipping the model on its head. And actually at PCORI, we're seeing, not outside even the PPRN, but we're seeing this phenomena where the shift is somewhat moving. And now when we've issued funding announcements, and we see patient groups tweeting, saying, we've got data. You come to our table, and basically we've got research questions that we want you to come into our world and do what we say. So it's really fascinating to watch this shift, and Sharon and Megan will probably talk about this. Now, when I was a patient partner 15 years ago, we had 17 partners at the table, including professional societies, NIH was there, HRSA was there, and the patient, there was an overarching request to do a different research question, and the mother group that was the governing body would not budge. And so it delayed the research by about 18 months. And but it was deliberation, it was very thoughtful, we looked at all angles. So sometimes that will be a challenge in research when a research question comes in and it's not of interest to the community with the data. And that's something that governance really does have to work out, and that's why MOUs and other mechanisms like that, and plus the collaborative spirit, wanting to get to the better outcomes for the community really helped us through when we had a different kind of research question on mind.
Thank you.
Hi.
This may be close to the next to the last question.
So I have two sort of disconnected thoughts, but I'll share them and then you can react or not as you wish. The first is that in the wake of healthcare.gov, when we've been really looking at how government puts forward good technology that works for people, one of the ways we found we were not trustworthy is by not providing services that were user-friendly. And so it didn't have to do with, like, are things protected or do we have good policies, but rather actually have something that works for my life. So having a participation model that's smartly designed that involves my feedback. And so first question is, like, to what extent is sort of trust also based on you're making this useful for me, you're making it easy for me, you're making it frictionless for me, and I trust you because I can see that you're doing that for me. The second kind of disconnected thought is it's one thing if I come in through a patient community. It's another thing if I come in through a delivery system. But if we're going to envision a direct-to-participant option where I'm kind of just coming in on my own, people have trust in people. They don't really have trust. Even if it's an organization, it's because they know somebody. And I'm just trying to figure out, do we actually have to cultivate a relationship there? Like, do we have to have somebody who's there, like, emissary to that person? Or, like, what are the ways in which if someone's coming in directly, do we create a feeling of community and trust for them, even if they don't want to be part of, like, a governance board? So those are my, feel free to respond if you'd like.
So I would say around trust, again, there are multiple domains or content areas related to trust, and every individual has a trust system. Some people do have trust in an abstract construct of an organization, not necessarily a person. So there will be people that you can tweet, you can post the information, and they will dial in and log in and upload their data with little effort. But you'll have to be willing to upfront invest in opportunities that will allow people who have varying levels of trust, but also have different domains of trust that are more important to them. Again, getting back to communities that people who are vulnerable, safety, fairness. They want to know, and I think that was, one of the things Ms. Brandt said earlier today about, randomization. That's an honest thing. People don't trust that they're going to be treated fairly. Will minorities be more likely to get the placebo or the more toxic treatment? This might not be, it might seem from a scientific perspective, we don't even need to talk about randomization because that's the gold standard. But the actuality is if we don't talk about it, if we don't have thoughtful conversation about how to educate and put systems in place to make people more trusting, then we are not going to be able to get to those points of doing that work.
Buddy, I'd like to address your question about technology and making things easier. I agree with you. I think that this is important. I think we've missed some of these maybe easy pieces. I wouldn't say it's easy, but some pieces that I'm thinking of some research that PCORI funded that required the participants to use a laptop to enter some information. And it was a Latina community that came back to their PI and said, don't think so. We don't have laptops, but I've got a cell phone. And so they changed the way that they communicated, and it increased the participation. So I think that message, because I think just as human beings, we trust other people like us. And so if we get some kind of something that doesn't fit our culture or what we're thinking, we think they don't understand us. And so by changing maybe some relatively, I don't want to say easy again, but things that we're missing to make things easier, I think that would increase trust.
Isn't it ironic we talk about personalized medicine but not personalized research? Bray, last word.
Thanks. So quick question. Before I worked at Duke, I used to do street outreach with the unsheltered homeless, out on the street every night, building relationships. After this with PMI, so we've had our workshops, we've had our tweet chats, the White House has done stakeholder engagement sessions. We've engaged with a lot of you. How do we build out on the concentric circle? How do we go out in the community? And what are the plug-in networks that you guys think we should attack next and take our message about PMI to the streets?
I think that a good place to start is around dissemination of the information in public places. And I think what that would look like is engaging a number of outlets where people get information. So that might be newspapers.
Names.
Yeah, so I would say, the Black Newspaper Association. I think that having information disseminated through Hispanic newspaper groups, national organizations, the National Medical Association, La Raza, other groups that have deep connections and a mission into certain communities is going to be important. And I would build on what you said, engage early and often. I think that's what you said is like engage now, engage some more, and keep information going. And I think what you also would have to then do is think about how to personalize that information. So can you highlight stories about individuals who are participating in the PMI project, right? So not just this great project, right? But Al Richmond, who I might know and looks like me, or, Consuelo Rodriguez, who looks like me and talks like me or whatever. So all of those, it's going to take us in a place where we've never been, and we have to change the language. So we're not writing for peer-reviewed journals. We're writing for the people that we want to be a part of this project. Make it plain speak, and engage people and share it. We need to get on some urban radio stations. We need to get on Spanish-speaking radio stations. We need to try as many opportunities and outlets as possible to get the word out there about this.
So,
Consuelo, and Sue,
and it's
there's
directly relevant to that point.
And I missed this question, so it's my fault, so blame me. So this is the very last question.
Okay, and it's really just going to the issue of trust and communicating. And you just said you're from the South, so you know, I'm at the Cancer Center down there. We go straight to the black churches and we find people who are trusted. We know we're not going to walk into a community necessarily and build immediate trust. So one community is my religious community in the southeastern United States, where many of these vulnerable populations are residing. That is generally a trusted institution. So I think saying the newspaper is great, but if you don't read the newspaper or you don't listen to the radio, you're not going to get connected. But if you're in places, and it's not just the churches, there are a number of institutions with trusted leaders, and those leaders are going to have to be engaged and be the role model, be the advocate for participation. I had wanted to make one very short point. If people come from multiple communities, and all of us are in multiple communities, if they're sitting on an advisory board, will it be clear, either through an MOU process or something, what community they're representing? Because those communities may be in conflict that they belong to. If they're going to represent a group, somehow it has to be clear what that group or groups are.
One last response from the panel, and then
I'll just perhaps respond to Bray's comments. So I know the work group has to make decisions quickly. You need to be inclusive. You need to identify opportunities. My suggestion would be that your deliberate strategic approach include a plan to engage people to help you understand which groups you want. Once you identify your priority population, then you identify those groups of people, those connections that you have, and then put together a planning process of how you're going to engage them. So the low-hanging fruit are the people who will easily respond in the cohorts that already exist. But then you have some time built in to develop a plan that will be deliberate. So before they're participants, they're advisors. So who are you going to bring to the table to help you develop that strategy to reach those people?
Join me in thanking the panelists. They're wonderful. We now have a break. Bray, is it fair to say it's 15 minutes to 3:20?
No, let's go. You get a 10-minute break. Sorry.
10-minute break to 3:15. Okay, I tried. Thank you. It's lovely.
This panel today is what would you expect a direct from participant cohort model to look like? And I'm happy to say that I'm Kathy Giusti, the executive chairman of the Multiple Myeloma Research Foundation and a multiple myeloma patient. And I am incredibly proud to be moderating this panel of no shrinking violets, can I say. I can promise you this is going to be a very lively panel. And the reason that I'm so happy to be with this group is because these are amazing women who have built their own organizations and their own data sets, and they have shown that you truly can build trust in the many people that they're working with. So I think they're going to be able to share a tremendous number of insights with us on how you build trust with your participants and how you build those data sets and how those data sets and their knowledge might be utilized. So I'd like to introduce the panel. Dr. Susan Love, who is our Chief Visionary Officer of the Dr. Susan Love Research Foundation. Megan O'Boyle, who's the Principal Investigator for the Phelan-McDermid Syndrome Data Network and a patient advocate for her daughter Shannon. Sally Oken, who's Vice President for Advocacy and Policy and Patient Safety at Patients Like Me, and Sharon Terry, who's President and CEO of the Genetic Alliance. So the way we're going to start this panel is I'm going to ask each of these ladies to provide us with an overview of their own organizations, the data set that they've created. Why did they create that data set? For example, what question were they trying to answer? And if they had it to do over, what one thing would they do differently? So I'll start with Susan Love.
There we go. Okay, sorry. We started a while ago, and I can't remember when, but it was a long time ago. And we started because I was really frustrated that there wasn't enough breast cancer research being done on women, and it was all being done on mice and rats. And when I complained to scientists about this, they said to me, well, we don't know how to find women. And I said, well, I do. So we started the Army of Women. And I went on, we got some funding from Avon, and we went on Good Morning America, or it might have been the Today Show, I can't remember which one. But within a week, we had about 300,000 people signed up. Women were very eager to be part of research, and we now have about 380,000 still in the Army of Women. Over the years, we've done about 86,000 women have been in studies, and we've done over close to 100 studies. And what the Army of Women is it's a big email list. We don't collect any data, and what we do is scientists come to us with their studies that they would like to recruit from us. We have a scientific advisory board, half advocates, half researchers. It gets reviewed. If it's been already peer-reviewed, we just review it for whether it's applicable for the Army of Women. And then we e-blast it out to everybody in the Army. And we have people with and without breast cancer in the Army of Women. And the reason we put it out to everybody is what we've found is they then virally send it on. And so even though you live in LA and we send you a study going on in Illinois, your sister lives in Illinois and is perfect and you send it to her. We actually had a study. We're not as diverse as we would like to be, and we had a study for Vietnamese people in Northern California. We thought we're never going to get this one, but we put it out. We had that one fully enrolled in a day because we had the right Vietnamese person in the Army of Women, and she knew everybody else. So sometimes you don't need to have everybody in your cohort to actually, you just need to have the right people to do it. And the big complaint from the Army of Women is not enough studies. And so the other advantage of sending it out to everybody is at least they know there are studies. If you keep a registry and you keep all their data, then you got a match, and then if it changes, they get pregnant, they weren't pregnant, they got breast cancer, you have to keep it up to date. This way, we only have to keep their email up to date. So that actually works very well. Now, to respond to the fact that we didn't have enough studies, we started the Health of Women study with CA Big, which some of you will remember a while ago. The Health of Women study has over 50,000 women who fill out questionnaires on a periodic basis. We have about 10 data sets now, health and environmental, quality of life, and collateral damage and other issues. And we put out serial questionnaires and collect data. We're still, we're having some struggles, IT struggles now in terms of cleaning and studying it, but we do have an ongoing cohort of people who will fill out questionnaires for us. What we've learned from all of this are a couple of things. One, as I said, is that you don't need everybody, that if you just have the key people, you can actually get things out there without necessarily having signed up everybody in the community. You need the right people. They may or may not be the leader, but they're the ones that know everybody else. We felt that there was a risk about collecting samples, so we don't have any samples. And the risk is you collect it with the technology of today, and then it doesn't work for the study of tomorrow. So you collected it in saline, and it turns out it had to have been collected in alcohol to be of any use for the new kind of analysis. So I do worry about these banks that we're collecting them with what we think is going to be the technology that may or may not be valuable in 5 or 10 years when we go to use them. And so it's something to keep in mind. And then the other is not enough research to keep everybody busy. And so I worry we'll build a cohort and nobody will come. And so you have to make sure that, and some of this is research incentives, that the incentives, in our academic community are really to do a study, get it done, publish it, to get a grant, and it's a lot faster to do that with animals. And when you're doing research with people, even if you've already got the cohort existing, it takes a lot longer. As we heard, it's a lot more involved. You've got to get community buy-in. And so I worry that we'll build it and we really won't use it to the degree or have enough desire to use it as we think we will. And finally, how to recruit. I said this last week, I guess, in Boston, but I think you just go on the media and you can recruit quickly. And I do think you go through the women, because women control their kids, they take care of their parents' health, they take care of their spouse's health. And so if you can recruit women, you get the whole family. And you can then recruit for studies at all the other different levels.
Hi, I'm Megan O'Boyle, and I'm with the Phelan-McDermott Syndrome Foundation, and more importantly, I'm Shannon's mom. And this is a very different model, but it's what works for our community, which is very small. It's considered a very rare or ultra-rare syndrome. It's a genetic deletion that has caused more common conditions such as intellectual disabilities, autism, and epilepsy. But it's, in terms of the diagnoses across the world, I think we're at 1,300 patients in the world. If there was more genetic testing done, we would be in tens of thousands. So this is a very different model than breast cancer. It's a very small, rare community. Because of genetic testing making headway in the last 10 years, it was not as easy to detect 20 years ago. So most of our population is pediatric. So who else is desperate for a treatment for something but a parent of a sick child who's nonverbal and has something so rare that none of their doctors know anything about it? So consequently, we had fabulous parents start a foundation. I was not one of them. And 5 years ago, a very passionate parent contacted me and told me to start a registry. And I didn't know what that was. And 5 years later, we have a registry with 65% of our world population registered. We collect genetic reports and a lot of other things. We have also decided that that wasn't enough, so we have a biosample collection with iPS cells. And then we got, figured we should keep moving, and so we had research community apply for grants for a rare disease clinical research consortium. So in a short period of time, we've come a long way, and it's because of the passion and the cooperation of our families who want to be part of research, who are not as concerned with privacy and security and HIPAA as some patient groups. And I think both groups need to be respected. Those who would like to openly give, and give a lot and give often, and don't want to slow down research by muting what they have. And also respect for those who are more concerned with privacy, and we need to make sure that we protect that. What we are is we are a foundation who was built upon support. We are collecting a lot of data. We are established our own governance within our own registry, and now we are part of PCORnet. And our families have a say in who sees the data and what can be done with the data. And it's important. And we had to educate our families about what research could do with data. They only knew about what their own child had. And I think the last session was very important. Governance is not easy, but it's important, and you can't think about it after the fact. And I would say, in terms of, Kathy, your questions were, barriers is access to getting medical records for our families. They need them for not just for research, but to manage their children's health. And what would we do differently going forward is, I was warned about this. We ask a lot of questions, and that can be a burden. And if there's a burden on a patient or a caregiver, then you may not have long-term buy-in. So we have to find ways of making this digestible, and so that you're collecting important information, but not too much that's not important, because they won't come back. Did I answer the questions?
Yeah. All right, well, thank you so much. So I first want to say that I was not one of the founders of Patients Like Me, but I have been there over 7 years, so I think I've had some long-term track record. But in 2004, when Patients Like Me was developed, there were a few goals in mind. One was to invent an open and a transparent, patient-first, health-related, research-based social network. So that's a big mouthful, but it was really something that was rather, quite different and disruptive in terms of thinking about how patients themselves could be a participant in something that was really sort of out of the box and out of the traditional model. We wanted to demonstrate that patients can and should be the drivers of health, of care, and of research. And we really ultimately wanted to bring credibility and value of real-world patient-generated data into research and into care delivery, and then to use that data to understand the meaning of health as defined by real people. So I think where we have come since then, in the 10 years that we've been doing this, I feel like we've delivered pretty well on those goals, and we continue to identify new ones over time. We've succeeded in driving the notion of patients first in care and research, and currently have about 350,000 members, providing data on over 2,500 different conditions. So we have the benefit of that cross-pollination model that was being talked about earlier. We currently have over 25 million structured data points in the system, and I can't tell you how many millions of pages of free text and narrative conversation that we have as well. We've succeeded on inventing what we believe is a novel and at times, dare I say, disruptive health-related social research network. And I believe we've paved the way for others who are now following that path, and we're very proud of that. We've established that patient-generated health data is indeed credible. It has real value. And actually, I would also dare to say that it may well be the ground truth that's long been missing in big data. So where some of our challenges have been on scalability and integration with the traditional healthcare ecosystem. So we believe that intentional creative collaborations are actually really needed, and part of PMI is an opportunity for that, where traditional care and research colleagues can work with non-traditional ones like ourselves in an emergence of a more diverse health ecosystem that actually moves along complementary but parallel paths. We don't need to be on the same path all the time. We can be doing different things to answer different kinds of questions. So ultimately, when I asked Jamie and Ben today, the Haywood brothers who founded Patients Like Me, what would you change if you started Patients Like Me today? And Jamie's first response was, well, you can't know what you couldn't have known. So the technology environment and the healthcare ecosystem within which Patients Like Me emerged has changed dramatically in 10 years. So that said, we always saw this as a long-term journey. This was going to be a long-term opportunity for us to think hard about where we would be in some time frame where patients and caregivers and family members and real people were actually engaging in answering and sort of defining what the questions were. So essentially, our model really mirrors what it was set out to be in 2004, to generate meaningful insights and answers to questions that really matter to patients. What we've recognized, however, and one of the things that has been a challenge and something we probably would have tweaked a little differently, was that we may have focused too much on the research side of our model, frankly. And while that has given us needed legitimacy and has attracted some funding opportunities that maybe we wouldn't have had, we feel like it did distract us some from addressing the real problems and questions that patients need answered in order to manage their real lives every day. And then to integrate that into the point of care. So actually, we're intentionally doing that now. So that's a shift where we've actually started to think more intentionally about care and the point of care and how that can be improved with patient-generated data. So our next generation of the platform will capture, measure, and network what really matters for living every day with chronic illness while ensuring its applicability to the research and care ecosystem. It's the difference, I think, Jamie and I talked about this yesterday, the difference between a low-resolution assessment of black and white data and really starting to add technicolor to that data. The nuance and the context of actual human conditions without which research would really fall flat. So we feel that the Patients Like Me model really brings that nuance, that context, that richness that we actually really need to get in a model like PMI, without falling prey to the need to be too traditionally focused on the ways we've always done research. So thank you.
Thanks very much. I'm going to answer with 3 different hats in 3 minutes, since that's the requirement. I know I can't stay friends with Brea if I'm not going to do this. With my PXE hat, which is I'm a mom of 2 kids with a disease called pseudoxanthoma elasticum, with my Genetic Alliance hat, which is shepherding essentially about 1,200 disease groups, and then my PCORNet hat, I coordinate the patient-powered research networks. So we built our first registry in 1995, and the reasons we built it were we needed to really grow up research right out of the community because no one was interested. We essentially wanted to collect biological information with phenotypic information and did that out of the gate. My kids can tell you about the ovaries next to the ice cream in the freezer. We wanted to find phenotypic characteristics that you wouldn't typically find in a 7-minute clinic visit or out of the medical record or in the 4% of people enrolled in clinical trials. We wanted to herd the cats, so we learned really quickly that there wasn't sharing going on, and we understood that if we owned the food, we could move the food and the cats would follow, the cats being the researchers that we wanted to get to share, and so we required sharing. And we also wanted to look at cross-condition, cross-pathway, cross-disease issues, lifestyle issues, et cetera, and so we had to build a system to do that. The goal it delivered on, I think, and still delivers on to some degree, my password back in, sorry, is that we had traditional results. So I pretended I was a researcher, and we have 40 peer-reviewed publications based on the data from the registry in pseudoxanthoma elasticum. More broadly, in the years since then, when we upscaled all of that and essentially created cross-condition research communities and registries, we were able, I think, to move the advocacy community from being gatekeepers, which very much in some ways mimicked what we were seeing in the academic labs. You know, I'll decide who's going to use the data, to giving that control to the individuals. And even my language is really wrong there, giving it. No, really enabling the reclamation, the reclaiming of the right to control where my data will go and how to dynamically manage that. Individuals have many affinities, and we're really looking at how do you be all the things you are and have all the conditions you have, and how do you manage that. And then I think the other things that were really important were ready cohorts. So we wanted precision, so I want guides that look like me, that speak like me to make the decisions, dynamic and granular engagement, gamification to give me immediate results, standards and connection to data models. And then most recently, we now accept direct, thanks to the National Association for Trusted Exchange. What would I have done differently? I kind of agree with Jamie. It's so hard to project what would have come. I think I would have been bolder sooner and worried less about being respected and welcomed into the traditional research community. And so I would have risked more and been more fearless. Thank you.
Well done. Well said. I think what we just got from all of that was that, and this is consistent with what we've heard today, people really do want to participate in research. Patients especially want to participate, and so do families. I think we have a bias that moms, women tend to be very dominant in the healthcare side. That doesn't mean that men in any way should be excluded from this. I think you've heard that third parties are very good at engaging these people and have built some major databases. You know, when you're talking 350,000 people, and some of our databases go deep with genomic sequencing, and some are broader where it's just an email system, but both are quite effective, and simpler is better. So having gone through what we've learned from being a number of groups out there generating data sets, I asked this group the tougher question, and it's kind of the elephant in the room today, which is, I find that being on the working group, we all have a vision of what this 1 million patient cohort looks like. And yet when I actually ask people on the break what their vision of this cohort looks like, it doesn't look anything like my vision. And it doesn't look anything like the next person's vision. So I thought, why not get the elephant out of the room? And I'm going to ask a few of these brilliant women to respond to what they actually think this cohort looks like, and then we can talk a little bit about that framework. So who wants to go first? Go ahead.
So this is fun because we're in the creative stages, right? So I think that the direct-to-participant community, because that's a cohort, because that's what we've been asked to reflect on, maybe should get rid of the cohort, first of all. The word, I think, is kind of weird for this kind of stuff. But I think we'd want to identify communities with strong community engagement. So that's really different than what we've been saying all along about how should it be rare or common diseases, should it be this kind of people or that kind of people. I think for the first thing we would look for is strong community engagement. And I would definitely agree with all of what we've heard today: churches, daycare, baseball teams, service delivery sites, those kinds of places, and grow up the researchers in that community. Now, that might sound like, oh, we're talking about 25 years from now, but I think we want to broaden our definition of researcher. I think we've seen enough examples of researchers who don't have the credentials. I think we also then want to cascade from them to interested friends and relatives, connecting the dots, because I think we keep saying we need to educate. I think education is boring in the sense that it's hard to do if people are not interested. We have way too much noise in our lives to want to learn anything new unless we feel compelled to learn it. And so, again, like, nobody pays me to use Facebook. We need to find compelling reasons, and a lot of the time that's friends and relatives. I think we also want to chill on rigorous inclusion criteria. And I think what I mean by that is I think it's been really hard for lots of studies to enroll because they are requiring very strict kinds of inclusion criteria. And this time I think we get a chance to be broader and to be more inviting. And I think the other thing that will be really important is to engage first and foremost and really break down the cultural barriers that we've built in the biomedical research system. And some of that is going to be having whatever this is be boundaryless. And that doesn't make a lot of sense because I know we're trying to define 1 million, but I think we want to define that in such a way that all the people who want to come can come, and all the networks that already exist can join and be part of this endeavor. And that kind of boundarylessness, I think, will build the kind of actual culture change that I think is probably going to be the greatest result of something like this.
So I would totally agree, and I think I'd take it even further. I think the other thing about anybody can come and not having very strict criteria is it changes. And so today you may not have breast cancer, and next week you get your mammogram, and now you're a breast cancer patient. Or, you know, your kid is born and has a problem. Or so life is you know, keeps changing, and we don't fit into little boxes at all times in our lives. And also, I think we need to make it so that anybody who has a good research idea can do it. So it's not just credentialed researchers, but maybe there's a way to either partner with somebody who can help you, but to allow, because the good ideas sometimes don't come from the research community, who are so hidebound in the way that we've always thought about things, but really come from the people in the community. So I think the more open we can make it, the better, and that people can go and even look on the, you know, have the data open. So you could look, if you want to see how many people who had gallbladder disease on Thursdays also got breast cancer on Saturday, you know, and just take a look at it. And that gets people more engaged in research, even if they're not doing an actual study. So we really have to build up the research literacy of the country, and to do that, the more we can let them play and be part of it and see how it works, the better that's going to go.
So I couldn't agree more with my colleagues here, and I also would echo the notion of getting rid of the word cohort right away and really focusing on community. We learned early on, you know, when Patients Like Me was first set up, we were walled communities of individual conditions. And by 2011, it was very obvious to us that that was not the right design. We took the walls down, but I have to tell you, it took us months to do it in terms of infrastructure. And then we took 2 months where we actually darkened the community for no new members, so our existing members could respectfully understand what it would be like to now have the walls down. We learned a huge amount. They respected us a lot by being able to say, thank you for giving us the opportunity to get used to this. First of all, now an ALS patient is actually able to talk with an HIV patient, and et cetera, et cetera. But I think that the ability to do that actually in our insight came from patients themselves who were trying to hack the system to tell us about their diabetes when in fact they were there in the MS community and it wasn't quite working. So listening to that and paying attention to that was really important. I think the other thing, a couple of things I'd like to also reinforce is that, you know, I think we need to step outside of the traditional boundaries, as Sharon has suggested, and really identify that there's lots to learn from other sciences, design science, user experience science. There's a lot of information that I've learned as a result of being around people like that in our company. I'm a clinician. I came from a very different kind of background. I use different kinds of words. I learned from them the ways that people would actually start to talk. So I think the other piece is that really an important lesson. is to fail fast and learn faster. So don't expect that we're going to come out of the gate perfect. And if we did, that would be, not really paying attention to the ultimate human condition, is to not actually always succeed, that we will have failures and we will have limitations. And so if we just recognize that right out of the gate and accept that failure will happen, but that we learn, and we learn as fast as we possibly can to make the improvements we need to get it better.
So I'm going to ask this question because I think I only have time for one more question, slightly differently. When we've been talking, we kind of view this cohort in some ways to be, there's a group of patients that might come in because of NIH studies, academic studies. There's a group of patients that might come in through trusted third-party groups. And then there's a group of patients that might come in through Google or Facebook, just, completely unknowing of everything else that was going on out there. But when you look at trusted third parties and patient advocacy groups, there are three ways that I see these groups playing a role. One is someone like a Susan Love can be a trusted face of the oncology community, right? So if she's going in and sharing data, doesn't that mean that that's a good idea and many other cancer patients might do the same? That's one way that we can be engaged. A second way we can be engaged is we have huge databases. We can send out information to all of our patients who we know are interested about the PMI and make sure that they get interested too. And then the third way is we have our own data sets. Some involve genomic sequencing, some involve registries, whatever they may be. So I'm going to ask the question differently and say, of your situations, would you do one, two, or all three of those?
Well, it's going to depend on how it all looks in the end. I mean, how it evolves. But I think we certainly would encourage, theoretically, we would encourage the people in the Army of Women to join. We might look into ways of putting some of our data that we have on our cohort study in it as well. And certainly we would be interested in, or willing to be spokespeople to say this is a good thing to do, and you should do it, to show up on Good Morning America or wherever you have to show up.
I mean, we try to encourage our families to participate to the best of their ability, and remembering that many of them are not getting much sleep and have a lot of burden as caregivers. The way we've consented our families in our registry is that their de-identified data can be shared, but I'm not sure if that de-identified data is going to be valuable to this community collection, which we're not calling a cohort. I'm kind of formerly known as. I am kind of the very naive ilk that on day one we should say to anybody who wants to be part of this, this is your consent. We like to ask you for everything all the time and identified, but if you don't want to do that, indicate so, and and they have levels. Because I think there are people that are willing to share a lot more, and things can be learned a lot faster. And I think that there is this culture of fear in research about IRBs and regulation, and that we need to be, you've never heard this before, have you? And that the patient, the participant needs to be protected. And frankly, I don't want to be. And I respect you if you want to be, and we should have a way in our initial consent on day one of indicating that, because those who want to share, whether it's biosamples, whether it's my Fitbit, or whether it's mine and my child's genetic sequencing, should be able to, because there are things that could be done that are very valuable, and that's my soapbox.
So I would say that absolutely. I would say that our first step would actually be to go to our Patients Like Me members and sort of suggest, there's an opportunity here. We'd love your input as to how best to harness this opportunity. I suspect what we'll hear is that they want to be intentionally invited to be a volunteer, that they would like to still maintain their Patients Like Me community status, and then have that be some part of the PMI initiative and identified as such. And I think that those are ways of being able to give them some status within our community as PMI volunteer, we would probably have that iconically demonstrated on their profile, but it also gives them the opportunity to virally start to get some energy around it. We need to make an infrastructure commitment to that. That's a decision we would have to make. Our platform right now is open and transparent. When you are in the garden of our community, I can see your profile and you can see my profile, and we share that data, and there's a real openness commitment to that. We recognize that there would have to be some ratcheting up of that kind of privacy layers in order to be able to allow people to participate, have the data coming into us, and then have that data going into the PMI initiative appropriately and protected. So I kind of imagine it that way, but I would suspect that, for us, we would want to be sure that the Patients Like Me identity is part of that as a trusted entity, bringing in what we've spent a long time building and operationalizing, helping to teach the PMI initiative about some of the ways we do things, and then also for our participants to be able to be identified in that sort of status way.
So we would do all three, and the reason we would do that is because it's sort of built into the platform for engaging everyone responsibly already this way. So guides are local, they belong to the communities, they give their impression about being involved in research writ large. The individuals have already made decisions. About 95% have indicated a willingness to participate in research all the way to big databases and involvement in projects like this. And then there's also a method of contacting all of them. So the information part of it, data could flow, and it would flow even sometimes with contact information, because a large number, 85%, have said, contact me, because they want to be involved in research. So we would do all three of those. And then I think, putting my PCORnet hat on, I think this is exactly the kind of thing that PCORnet is being built for, and we're engaging tens of millions of lives in PCORnet in various ways. And again, I think when people see something in front of them that they actually can meaningfully connect to, they enroll, they decide to participate. I also, though, direct to participant, because that's where we're looking here, is not just rely on the somewhat now traditional structures we have built. I mean, my registry is 20 years old, run by a layperson completely. That's old, that's old model. So I think we want to look at what would happen if we partnered with motor vehicles, and that it was part of the registration for your license to choose or not. There would be maybe bigger lines, yes. Kathy, don't rain on my parade. What if we partnered with cell phone providers? What if we all love to use our grocery store loyalty card, as Kelly Edwards and I were talking about yesterday, because we get $2 off on something. What if there was something connected to our walk-in clinic or to our pharmacy? So I think we want to think much bigger than our kind of walled and semi-walled and boundaryless communities to the bigger world around us.
Exactly. Okay, so it's time now for us to open it up to questions. So I'll look around for the mics.
So I'll take the opportunity while we're waiting for our mic people to get up and circulate the mics. Thank you. So this is a paradigm shift. Some of the most esteemed researchers in our country are now walking around with mics and have been confused with help. So yes. Anyway, Sharon, I wanted to ask you a question. We keep talking about the us and the them and how we need to end that. And then you were talking about, to be successful, early on your key to success was actually looking more like a researcher and doing things in a recognized space. So we see the patient community moving over here, getting into registries and becoming more like researchers. What can researchers do more to move closer to the patient group? And then where do we land and get to the we?
Yeah, that's a great question. And as Susan said when we got up here, none of us are tweeting now. So what's happening to the Twitter sphere? Because this is exactly the conversation. Thank you so much. So I think, what's so striking to me, and I've been doing this more and more, is like listening to language in these rooms. So I just came from the Precision Medicine Initiative of California, which of course they have to have their own, and from big data, from big data conferences in Boston and all kinds of other things. And when I listen to the language, I find the researchers, and I'll say us because I really do want to use we language, saying, let's build a bridge to them, let's do that for them. And I think if we even just start with our language, so start with, when those words want to come out of my mouth, why am I saying they're over there and I'm over here doing this work? And how can the researcher, which is, you know, part of all of us, and the patient kind of come back together? And I think the other part is supremely personal. And a very good friend of mine, Diane Baker, once said to me that I had really perfected kind of the researcher thing, and I was giving great talks, they were fabulous, but I neglected to let myself be there anymore because I had to be professional. And I think if each of us could just release that, where you're really concerned about your mother right now, right? And you're really concerned about your kid right now, right? And let that come through, we'll stop saying them and we'll start being us.
And the other thing is, the only difference between a researcher and a patient is a diagnosis. And I said this 3 years ago, and then was diagnosed with leukemia. So, you know, the idea that it is we and them, you know, we would, in our research hats, we'd like it to be we and them because we really don't ever want to be the patient. But in actual fact, we're all going to be patients. So it's really a false dichotomy, and I think we do it more because we'd like not to be the sick person. But we really just need to consider it people. And, you know, I said this the other day, but in surgery, we consider everybody pre-op.
Okay, to the right, please.
Okay. Hi there. My name is Aaron Mahone. I'm actually an MBA summer intern at PPD, working in the Corporate Development and Strategy Group. I've been waiting for the perfect time to ask this question, so it might not be the time, but I'm just going to ask it. And so it seems like most of the stakeholders and the focus in this room is on clinical trials that have that are trying to make advancements in research and academia, and just basically drawing statistically significant conclusions. And my question is how is the approach to engaging participants going to shift for clinical trials that are more focused on drug development? And when you're running these clinical trials, the focus is more on getting patients who meet inclusion-exclusion criteria rather than making sure that you have a specific set of socioeconomic background, genetic makeup, and other biomarkers. And so there's a bit of a different focus. And so how do you translate what you're trying to do with the research to actually developing new drugs?
But is the goal really to develop new drugs? I mean, partly, but that I don't see that as the goal of. I see understanding disease and this precision medicine idea is that we're going to figure out what causes disease and what causes it to be worse, as well as the collateral damage from a lot of the drug treatments. But we have a clinical trial mechanism in this country. I don't see that as what we're trying to develop.
But as my understanding is, the way when a big pharma company develops a drug, they're looking at, as we've discussed earlier, to affect a significant portion of a population in a certain type of way, and they're not taking a look at why is it affecting certain populations in certain ways. And so, if that's not their focus, and they're not collecting data to make that argument for who is this drug actually targeting, they're continuing down sort of this old path that we've already tried, and you are proposing a new way of doing things, and they're not on board with it necessarily. Right. And so I'm just wondering if there's a plan to sort of like merge these two paths.
Yeah.
Go ahead.
May I? Yeah. So it's a great question, and in truth, it's not either or, right? We really do need both. The purpose for this particular project, though, I think, is to probably generate hypotheses and raise questions. So to Susan's comment, it's really going to give us some insights that we can share with pharmaceutical and biotech companies and help them point their tools effectively in the right direction. So there's got to be a collaboration. There is no us and them, back to the point that's already been made. And these don't operate exclusively to the exclusion of each other. We really do have to collaborate. But there's so much we don't understand about the correlation between the genomic basis and the biological basis of so many diseases that this particular community-based genome study, rather than cohort, may actually give us some great insights that will allow us to form deeper collaborations with the industry.
Okay, to the middle.
One comment. Azadeh Stark, and one comment. First of all, thanks to the panel. They have brought very important issues. And one comment is about change of lexicon, change of language, which panel suggested changing the cohort into community-based participation. And when we talk about research and patient, if you change the term volunteer to contributors, instead of 1 million volunteers, 1 million contributors, you're closing the gap between the researchers and the patient population. You're also encouraging this concept of adherence to research participation. Researchers cannot do anything without patients' contribution to their research.
Right. Well said. Shariq?
Or partners, I guess, too.
Thank you. So I'm finding this very informative, and I have a question that's basically about men. And so I challenge Susan's comment. It won't apply to all age groups, and it won't apply to all ethnic or socioeconomic status groups, and I know that you know that. So one thing I wanted to know is, are there men who lead organizations like this from what you know, or are there men leaders within? I mean, I've met, the last meeting we had someone from a sleep apnea, but I just would, if you could talk about it, since you're all women, and, we wouldn't want to leave the impression that this aspect is all female.
That it's purely a coincidence, because if you look at it, like she said, Patients Like Me was started by Jamie Haywood. Look at prostate cancer with Mike Milliken. Look at cystic fibrosis with Bob Bell. I mean, we could,
my organization is my husband and I, so
they're men. There are.
We've seen them once.
We see them every now and again.
Dr. Platt questioned me on that once. He asked if it was just moms, and I said no, but when you have a sick family member, the person who makes the least often is the one that has to quit. And the stay-at-home person is the one that deals with the burden. And they're the ones most motivated to move the research and the science forward, because they want to make it better for their other children or their sick child or parent or whomever. So I think that's sometimes where the female part comes from.
And let's be clear, we love our men, and my husband actually has my son at the doctor right now while I'm sitting here. So, okay, who am I missing? In the back? Okay, and I missed somebody else.
I'm Holly PA. I'm with RTI International and the PI of the Duchenne Connect PPRN. So several of you have mentioned the fact that patient communities and well communities have different research priorities than perhaps epidemiologists who may have different research priorities than clinical researchers. I wondered if you could talk about, given the limited amount of resources and time that are going to be involved in the data collection, we can't collect all the data that everyone's interested in. Could you talk some about how to prioritize among those competing interests in different kinds of data?
I'll take a stab at it, and I'm gonna use a question that we developed many years ago that actually has guided much of what we do, and actually I'm happy to hear it being repeated in different places. But I think while priorities may be different, I think at the very bottom line of this, it's really, given my status, how am I doing? What do I have? Who am I? What's the best outcome, which hasn't been something we focused a lot on? What's the best outcome I can hope to achieve, and how am I going to get there? I think that actually states a priority that we can all sort of get our heads around, to say this initiative should be able to answer that question for any one of us who's participating. It may take longer time for certain questions to get answered that can tell me about my status. Maybe we don't know enough yet about what my genetic background would look like if I put that against potential outcomes and interventions. But that one fundamental question actually I think is a common prioritization of what we really should be thinking about doing. I'm not sure that answers your question directly, Holly, but I think it's a fundamental shift that we need to take. And I would encourage us to take it.
And it's not just one time. You can go back and ask them for more information. I mean, if we suddenly find out ingrown toenails are related to breast cancer, or we think they are, we can go back and ask them about ingrown toenails, which we may not have asked them about the first time. So I think you have to think of it as a living kind of database, not a one time you collect the data and then that's it forever.
Yeah, I think we forget to apply, and Holly, speaking to the choir, kind of the things we learn in our own lives about how data can be incrementally accrued, and then how we can also shift our needs. And I absolutely get that the strict methodologists would say you can only use these data for the things for which they were collected and not for something else. But again, we can go back to people. And the other thing I think is, that doesn't really answer. So if I had to make the checklist right now of what data, because this is not a lot of money. This is like not a lot of money. The other piece for me, though, is what can this enable in terms of the culture change and new methodologies and new technologies that would allow us to do this on a much more massive scale? Do we want to say in 10 years this country understands that all of us being an answer to understanding health and disease is a goal? And that kind of stuff, I think, would increase vastly what we could do. And that doesn't mean we do one thing and call it one thing, but we do many things and let network effects really rule.
Kathy Hudson first, and then I'll.
I was just going to make an observation. Earlier in an earlier panel, folks were talking about when they submitted research proposals or publications with only minority participants, people ask about where the white folks were. And when we have all male panels, we don't get questions about aren't there any women researchers. So I just wanted to point out the irony.
Hi, my name is Aaron, and I have a Y chromosome.
We won't hold it against you.
And for the last 2 years, I've volunteered to operate the National Association for Trusted Exchange, which we're thrilled that Genetic Alliance is using and invite anyone else to use as well. My question is actually kind of a segue from the earlier question about capacity. Once we actually activate the consumer, the patient, the family caregiver, we'll have so many biospecimens that they will go to waste, I think, given the capacities that we have today. And is there some science that we can apply to be sure that we get the most out of those things? And how do we start preparing for that onslaught?
So I think we have to broaden the doors and open the tent to other kinds of researchers. So we have traditional researchers that have been working in this field, and I think we're going to need to figure out, and I'm not suggesting that people do put ovaries next to the ice cream, but I do think we're going to need other ways for other kinds of scientists to get involved. We're also going to need other technologies to rapidly turn, for example, samples into information so that that could be shared and stored, et cetera. And I think we're going to also want to watch the market effect of something like this, because I think while right now companies are trying to develop a drug with $3 billion and a 95% failure rate, there will be other companies that will want to be in the game of moving things quickly, and the kind of same open space stuff that happened to other industries like music and to publishing will happen in this field as well. So I think we haven't imagined yet what in 5 years this conversation would look like.
And in some specimens, you need to catch at a certain point in time, like tumor tissue and things like that. But other things, you may want to wait and just collect it. You have this whole group, and then just collect it when you need it, because the technology and the way you collect it may be different.
And I'm in the army of women, and I like that Susan says we're kind of just walking biobanks, right? That we're right here, we're ready whenever she needs
Just in time biobanks.
Paul Kimmel, NIDDK. This has been a fantastic panel. So I'm wondering if you could bridge the gap a little bit and talk about how you've been successful in getting the underrepresented, the vulnerable, because I'm just wondering if it isn't a panel of thousands of billions of high socioeconomic groups with particular diseases or particular interests, particular literacy.
I'm going to split that into two questions. How we have been successful is that we've returned data, aggregated data immediately to our families. So we may have burdened them with an hour's worth of survey questions that were very emotional for them to answer, and they may have had to dig out their medical records on their child. But at the end, they were able to click on a question and see how their answer compared to the other patients across the world. And that's the reward. It wasn't a gift card. It wasn't, any of the other incentives. It was knowledge. And when you're talking about certain communities, people that are unable to get out and meet other people with their condition, knowledge is empowering. It helps them take care of themselves and their family members better. So that's how we've been successful. But your question was, how are we successful with the underrepresented? And we're not, because it requires genetic testing. And that's a socioeconomic issue and an insurance issue. And until there are sequencing done widely and that information can be returned to the patient, not just used in research, For instance, if everybody with autism or everybody with intellectual disabilities or everybody with epilepsy were referred to genetic testing, our community would be much, much bigger. But right now, it's only the people that push to get the physician in a medical center that's going to give the referral, because most people would be okay with any one of those three common diagnoses. So we have been unsuccessful, but these guys may have done it.
We've been successful in multiple myeloma, which does skew older male and African American. And we did do a sequencing project of 1,000 patients, and it was very representative of the patient demographics of the disease, but we paid for the sequencing. And it was incredibly expensive, and we looked for the community hospitals that actually would see that patient population and enrolled as well. And I know we still have a few more questions, so I'm going to, do you want to answer real fast?
Only because I think we take all comers, and so it is a little challenging to think about that. But I think one thing I would like you to know is that when we intentionally start to develop a particular community, we actually do a very strategic engagement and ethnographic approach to that, and really reach out and try to find as much representation as possible. So where we have done that, we actually are quite representative of the communities. So in epilepsy, organ transplant, IPF, which is a pretty rare condition. But true enough, I mean, across the board, we skew female, we skew a higher education level, but when we strategically think about the condition we're going to be fully developing, we intentionally reach out to as many diverse groups as we can.
Okay.
Yeah.
Sorry.
Okay.
Hi, I'm Sean Sigmund. I'm with Oracle, but I just wanted to perhaps propose that it seems like most of the conversation, kind of traditional patient engagement via clinic environment, clinical studies, kind of that engagement. And I'm curious if kind of broader corporate partnerships of either encouraging companies to volunteer their employees that may participate and proposing greater kind of partnerships. The blood bank idea earlier, pharmacies to recruit, kind of leverage the channels that already exist to do patient engagement, and perhaps companies that have certain socioeconomic employees like Walmart or Denny's or different groups could already target some of these things once you've got your protected or group that you're really concerned about maybe being underrepresented.
Yeah, so we actually don't work in clinical settings at all, and all of our work is in communities. I don't think any of us do, actually. No. Even our MD doesn't. But we have, for example, Coronet just partnered with CVS so that the PPRN conditions, of which there are 100, will be listed on their website and then distributed in the Minute Clinic. Genetic Alliances work with Walmart on family history with their employees only, because that's certainly a large enough community to do that. And then with corporations in different parts of the country sponsoring, for example, working in Appalachia or Westchester County with African Americans, that sort of thing.
I think back to the right.
I just have a couple of comments. And one is with the numbers that we're talking about and the systems that we'll be engaging, we're going to have to be very, very careful about these groups. I mean, there's going to have to be a lot of training that's going to need to go on where these cohorts are, whether they're community health centers or health systems or whatever. The people who will be managing or helping you to manage or bring them on board, because they're, the FQHCs have a number of minority populations, previously considered vulnerable populations. So I would think that there's a lot of legwork that has to be done to even educate the people that will be helping to do that. The other comment is that at some point, there's going to have to be a benefit. What are you giving back? I mean, people are being researched, but what are the services for when you find out all this stuff that's going on? And with this number of people, somebody like me is going to say something. Because I'm a member of a cohort. So you need to be prepared for that. What are the services? What can you do to help them? Okay, we know this, but where do we go from here? The other comment is if we're not careful, there could be a really be a backlash, research backlash, which would not be good. That's it.
One more, I think.
My name is John Birch. I'm an angel investor, and I have a question that involves not creativity but imagination. Could you talked about how much has changed in the last just 5 years. Look ahead 5 to 10 years, please, and consider the possibility of not a cohort of 1 million, but a cohort of 320 million. All Americans, all American patients' data being available in one place, accessible, so on. Disregard the technicalities of getting there from here, but let's just imagine, what would that cohort look like? Ask the same questions that you ask about this cohort. Consider for a moment, what a cohort of 300 million would look like.
Are you asking a question, or do you want us to comment on that, or?
Well, that's a question. What would it look like?
Okay. Well, I mean, if it's all of the U.S., I think it's represented, but I think the question comes back to the survey that we saw earlier this morning, which showed even the variability of, 21-year-olds and what they would be doing versus the older people and how you would be talking with them. And I think for the younger generation, they tend to be much more about prevention and wellness, and everything is on their phone. And I think they've seen enough illness in their lives that they're not necessarily going to be anything like the 50 and 60-year-olds that would be in this cohort. So I think it would change a lot. I think you'd have half the cohort looking at prevention, the young ones, and then you'd have the older cohort looking at the next generation and trying to take care of them and doing it altruistically, and it would change everything. But I don't know if we shouldn't be considering that when we look at the survey results that came in. That was the first thing that was going through my mind of, we saw the survey, but we didn't really understand in that survey how it changed based off of age and who was really going to be engaged in this. And I'm a big fan for, you want people that really want to do this and really want to get involved, and will give you as much information as possible and give you that low-hanging fruit, because you want to see a few wins, because everybody's skeptical of whether we, the government, anybody can get anything this bold done. And I think we have to show some short-term wins as we get started.
The other thing is, when we started out the Army of Women, we said we wanted 1 million women. And then we realized we wouldn't know what to do with 1 million women. We don't have enough studies for 380,000 women because, we have to get the researchers along. So we have to be careful about, I think we'd need a single-party payer healthcare system if we had that, probably. Huh? Well, we do, but that's a whole other. That's another panel. But I think that we have. I think you have to be careful about. It sounds great, but you really have to think through what you would do and what all the ramifications would be with that.
I would just also add, I think that it opens up a huge Pandora's box, right? Where you're sort of like, oh my gosh, we have everybody now who's in this. But I also think that there's a lot to be said around selective perception. Every single person is going to come to something like this with their own set of perceptions about what it means for them, what they want from it, how they view it based on their own behaviors and their own beliefs. And some of that will, I think, be opportunities, and some of that could also bring weaknesses to the community that could actually then need to have to sort all of that out. So it feels to me like having every person born in this country at some point being able to be followed and clearly understood over time in terms of what their health opportunities and some of the disparities might sound like it's a wonderful place to be, and maybe that's where we will be someday. I just think that's going to come with lots of different other questions and issues and concerns that every single person who potentially could be involved is going to have to start asking questions about. And that's not going to be relevant to every single person who would be enrolled in what you've just described. So.
Last word, Sharon.
I also think we could imagine that it will be frictionless and invisible. And so we will have been engaged to the degree we want to be, and some of us will be intensely engaged and others of us will be more passively engaged with permission. But that because of that, it will be in our pathways, part of our lives, the way lots of other data collection is about us, with the right safety and privacy protections, but so that it will be part of the fabric of who we are and not be a heavy lift.
So with that, I'm going to say, Sharon, you had said to us that you wish you had been bolder and more fearless. Well, let's hope this project is bold and fearless. And thank you to the panelists. And now for the next panel, I'd like to introduce Sachin Khetarpal.
I could have the panelists come on up, that would be wonderful. We don't have any prepared PowerPoints for this session. We've got 4 panelists in 1 hour to address, I think, a very exciting question, which is really, what are we thinking about data sharing here? We've talked about it. We've kind of gone around it. We've heard different perspectives on it. I think in this panel you're going to see some consistency of thought, but it might be through different experiences. In particular, it might also be in conflict with what the survey results we saw this morning, which was a lot regarding privacy and a lot regarding me deciding what happens to my data. So what we're going to do is address 3 important questions. Fundamentally, what are some successful models out there for data sharing in a broad way that have incorporated the participants' perspectives? And to address that, I'm going to ask the panelists in sequence to give their perspectives on it. First, we have Laura Bayrou, who's a professor of psychiatry at WashU. Instead of a lengthy bio for each person, I've chosen a few pithy words, and she's called herself the Queen of Vice because she focuses on addiction, both to tobacco and to alcohol. Then we'll have Matt Might, whose brief bio is a research vigilante. Many of you already know Matt's background. His son has a disease that they didn't know what it was until Matt came along using his computer engineering background at the University of Utah, figured it out, and helped create a world of collaboration around it. Next, we have Rob Ring, who has transcended industry all the way back now to an advocacy group at Autism Speaks and is the chief science officer there. And then Nancy Roach, whose latest title and latest amazing advocacy effort as a research activist is for Fight Colorectal Cancer. So with the concept of what are some success stories you've heard or you've experienced, Laura, if you want to get us started on that.
So thank you. So I work in the field of addiction and looking at the genetic contributions of addiction. And so one of the issues that I've always had is I touch on many of the IRB issues that is a great concern. I'm dealing with substance use, which is often protected data, illegal activities with drug use. It's often in underserved populations and underrepresented groups. So through my studies, I've collected over 15,000 samples with genetic data, which have been deposited into the national repositories. And so 25 years ago when the study started, we had these models of consent with multiple layers of consent. Can we share with industry? Can we share with investigators outside of our university? Can we share with investigators in the world? Can we share studies related to alcohol, drug use, and related aspects? And about 5 years ago, I simplified our consent forms and moved them to really all or nothing sharing. And the reason we moved this way was severalfold. One is essentially all of our subjects, regardless of race, gender, educational status, agreed to this broad sharing. The second part was that when there were different check marks of sharing, at times there wasn't consistency. There was conflict of they would agree to sharing in one part but not sharing in another part, or sharing with investigators around the world but not sharing with investigators who are outside of Washington University. So since we had these check boxes, though we saw them as kind of a logical step, the subjects would check different boxes. So there wasn't a logical kind of group here. The other issue had to do with our IRB and how groups started interpreting our consent. So we asked questions about alcohol and related diseases, and we asked questions about their alcohol use, substance use, their psychiatric illness, and their medical illnesses. And I viewed all of this and the investigators, and we thought the subjects also viewed this as alcohol and related conditions, all of these conditions. So what happened is as we were depositing into our data into dbGaP over about a 10-year period now, so we were some of the first studies, but we've deposited further data, we got approval to do this very broad sharing of data. The next time, about 5 years later, we went to dbGaP, the medical illnesses. got cut off because it was alcohol and related conditions. So medical conditions were not related conditions. So the next time we went to dbGaP, the psychiatric illnesses got cut off. And so now we, are only allowed to submit the alcohol and related conditions, which is drug use. So again, though I believe our participants, as they signed our initial consents, believed in this broad sharing, that we as the investigators believed in this broad sharing, it has become narrowed over the years. And I think it's because of IRB conditions. So with this, about 5 years ago, I really broadened our consent as wide as I could get the language, which is incredibly broad by our IRB, just kind of, recognizing that I have 25 years of consent forms, so there's been changes over the years, but to really try to say, our intention is as broad a sharing as possible. And we have over 90% of our participants from our previous studies agreed. If someone does not agree to the broad sharing, we recognize those preferences, but we've decided that we're not going to recruit them into the study. And the other issue about this has really simplified our research recruitment. It's also simplified our database management because I have significant concerns that I want to uphold our participant preferences. And when we have all these different levels of consent, I live in fear that I will not be able to do that. So broad sharing, that's where I go. I love broad sharing.
And your participants want that.
And my participants want it. And it's for things that I could never imagine, is going forward.
Matt, your experience in a very motivated community that is driving data creation, curation, and disease solving. Your experiences there.
Yeah, so before I get to my own success story, as it were, I need to confess that I'm an extremist on this matter. But there's huge advantages to being an extremist. When you're an extremist, you get to have simple answers to complex questions. So for complex questions like, should a non-PMI researcher get to have access to my data? Or should we share data back with participants? Or should we share data between participants? My very simple answer is, it depends. And let me first address what it should not depend upon. So it should not depend upon whether there is a commercial interest in keeping a patient's data private. And since there are some academics in the room, it should not depend on whether there's an academic interest in keeping that data private. And I know that hurts. It hurts me as an academic too. And it should not depend on whether or not some IRB says that a patient needs to be protected from their own data. As far as I'm concerned, the only thing that matters when it comes to determining what you should do with participant data, it's the answer to the question, what does the participant want you to do with it? And that's it. So, if a participant wants their data shared broadly, then go ahead and share it broadly. If they prefer to be kept with a single researcher or a single institution, keep it with that institution. If they want to see their data, show them their data. If they don't, don't. In fact, I think, if I were designing some of these forms, I would have options for each parties for which they might share. I would list may not share, may share, and must share. I think sometimes we're in danger of undersharing. And my attitude is, if Facebook can figure out how to have really fine-grained, user-defined control over sharing of data, then certainly medical research can do that too. And I say this because I think we spend a lot of time trying to protect people from their own data. And of course, I also say this as the parent of a child for whom radical release and sharing of data has been critical to trying to save his life. So I've seen the promise firsthand, and so let me share some of that promise with you. So 3 years ago, I was told that my son was the first and only case of his particular genetic disorder. And in order to find others like him, I had to release his data. I had no choice but to dump all of his data on the internet. That's what I did. I dumped it all in a blog post designed to find other patients. And it worked. 3 years later, today, we have 37 cases around the world of this disorder. We have a community that's dedicated to tackling, understanding, and treating this disorder. And all that has come as a consequence of sharing data. In fact, even through engagement with that community, I myself have started to shift some of my research in computer science into biology. I'm to the point that a couple of weeks ago, my home institution of the University of Utah even gave me a seedling grant to start developing a platform for therapeutics into this disease. So these are the long-term consequences of what can happen when we allow data to be shared very broadly. But I've also seen firsthand how not sharing data can drastically impact patients. For instance, I still don't have access to my own exome because an IRB is concerned that I might injure myself with it, even though that's the tool I need to help save my son's life. And we're wasting a lot of time and effort getting ourselves resequenced as a result. And this is not unique to our community by any means. There's a lot of people who, because they can't get access to their data, have to recreate that data at their own expense. And because we had to wait for the publication to come out to push out this blog post and to announce it to the world, there was a year-long lag between the discovery of the disease and actually finding that second patient and launching this community, which is tackling the disorder. So I don't know that dumping all of your data on a blog is a scalable model for success. And so for more reasonable systems, I would actually cite Sharon Terry's peer. I think that's an excellent system, actually, for letting participants define how much control they want over their data. And I would say in the end, speaking as an academic now, I think those at greatest risk from more data sharing are not actually the patients. I think those at greatest risk from data sharing are actually the scientists that are shackled to a publication grant and tenure system that not only fails to reward sharing data, but also actively punishes those that have the moral courage to do so. Thank you.
Excellent point. As an academic dealing with the tenure issues, I completely agree. Rob, I don't know if you speak for Autism Speaks as the entire community of it, but you've dealt with some very unique issues of getting people to share some of the most personal things in a very controversial area of science right now where there are some very charged camps, yet you've been able to get thousands of patients to participate and freely release data. What allowed you to succeed there that we need to learn from that as an Autism Speak representative?
There we go. Well, I think we have a very motivated community, certainly, and it's been interesting to go back and look at how the nature of the consents have evolved since we first started collecting samples. And most of my learnings in this area, most of what I'll share throughout the conversation comes from our own experiences with a program we call our Missing Project. And this simply is a program to build one of the largest databases of complete genomic sequencing information in the autism field. And this is whole genomes, not exomes or anything lower than that. And we benefit from this because we've had over a decade of work collecting samples from the community, not just individuals with autism, but their entire family. So we have more control genomes, if you will, than we have affected individuals. And this would not have been possible without great partnership with the National Institutes of Mental Health, who helped build the AGREE repository. But we have, over the past year, built a database partnering with Google. This is one of their exemplar programs for how they would like to develop a business for genomic data storage. But the idea here really is to sort of address those shackles, if you will, to disrupt the model of access to genetic data, and being a funder of research, actually fund the sequencing of samples and put it in a database without the skin in the game associated with needing to publish or to justify that. And so we've actually embarked on this. Our goal is to have 10,000 genomes in the database by the first quarter of next year. We're actually around 4,000 sequences into this. We're well on the way to doing this. But I can tell you it has been quite a journey. The technical side of creating petabyte scale data sets isn't as difficult as you might think it is working with a partner like Google. But it truly has been the legal and ethical dimensions of trying to build an access policy that truly opens up and levels the playing field for the research community. And I'd say some of the models beyond just the learnings we're happy to share is we've partnered into the Global Alliance for Genomics and Health, who've been a really amazing platform working very hard to develop tools and policies to help, I think, disrupt this space and open up the sharing of data. And I would encourage folks to look at the work products of that alliance as we've drawn on those. I think, I would echo some statements that were made earlier. There's a real need for outreach to IRBs. who may not quite understand where we are in the evolution of the technologies around sharing and the privacy and security, achievements that are out there. But I think if we've run into one challenge along our path, it's just that education, the burden of educating IRBs on what's possible now and interpreting the various consents in the past that have been used to bring the samples into our database. We have a research portal that will launch in actually just a few weeks, but it is really, I think, the greatest achievement for this program will be the community portal that comes after that. Beyond the returning of incidental findings, we think it is an obligation to return genomic discovery to the families who are our key research partner in all of this. It's not going to be easy, but technically creating ways for lay people to interact with their own genomes is going to be tricky itself. But being able to connect families who are sharing the same genetic discovery, if you will, with one another is a lofty but important goal for us.
And who has access? I think in our conversation earlier, that was the very exciting. Who has the planned access to this data set?
So our goal with the Missing Project is quite literally to achieve this level of access. You come to the database, you're presented with a pop-up window, you self-identify yourself as someone with a valid question to ask of the data, and you agree not to do evil with the data based on the terms presented there. You check a box, and you're in. And that's very ambitious, we understand, but one of the things that have made this possible in our early conversations with IRBs is in addition to having all our data already de-identified, in addition to having the level of security we have in the Google Cloud, we don't allow the downloading of data. We literally creating a database where all the data lives there. Individuals bring their innovation, their ideas, their questions to that database and are provided all the tools and compute resources necessary to crunch, ask, and annotate, visualize that data in whatever way they want. They can come in using turnkey solutions. You can code your way in through a command line and recall every variant if you'd like, but you can't walk away with that data. And in that context, one might argue that this isn't even human subjects research. And so that's a very progressive argument that is out there, many of you know, and may actually allow the kind of open access that folks, particularly our families, are very interested in seeing happen.
Nancy, your experience as founder and chairman of Fight Colorectal Cancer, among many other initiatives, your involvement on quote-unquote the other side as well with NCI and a lot of the organizations. What open access, what data sharing experiences have you had that you could bring to this effort to say, make sure we do X if you truly want to get people involved in this from a data sharing perspective?
Okay, technology always fails me. First of all, I am basically an odd duck. I'm a full-time volunteer. I'm on a couple of NCI advisory committees. I've been on a study section. I serve on research committees. I do review for DOD. I deal every day with patients, walking them through, what is it like? How afraid are you? How can I help? And I've also gotten passionately interested and involved with the efficiency and efficacy of clinical research. So that's kind of the mindset that I bring with my DC hat. I also live in a small town in Oregon, a very rural environment that's heavily Hispanic, a lot of Native American. There's a huge underserved community, and the scientific literacy there is very low. So when I go home and I talk about this stuff, people are like, it's organized how? You mean my data is stuck? They think they own my data. I mean, that's when I say, if you're in a clinical trial, who do you think gets that data? And they go, well, it's out there for the public good. And I'm like, no, it belongs to the researcher who's running the study. And they say, well, no, it belongs to me. So that's kind of the mindset that I bring to these discussions, because I do think that most patients really believe that their participation in even just clinical care is going to help other people. There is getting people to share data is almost impossible unless the funding agencies incentivize it. And the system incentivizes it. And I've seen it's public and private. That's the problem. There are a couple of examples, I think, that are interesting. Project DataSphere is something that was done by the CEO Roundtable. It involves sharing the comparator arm of phase 3, a bunch of phase 3 cancer trials, both industry funded and publicly funded. It took literally years to get people to agree to do something like this, but they recently had a prostate cancer challenge where they said, okay, we have all this data in prostate cancer, come up with ideas and submit them. And they had, I think, over 300 submissions for the prostate cancer arm. So it is possible to do it. I think patients expect it. Patients want it. They're much less concerned. Although I have to tell you, my 26-year-old son, when I talked to him about PMI, he said, I'm not going to do that. They'll clone me. And I said, they'll clone you? You think you're that special? Okay, all right. But that's I think there's a lot more fear about data sharing than I think the amount of fear on the patient side is much lower than what people think.
Right. How do we reconcile then, you've got motivated communities, sometimes disease specific, sometimes community specific, because not always people who are ill, that are very motivated to share data as much as possible. We've heard one model, which is a all or none consent. Matt, you had mentioned a bit more menu-driven approach, this versus that, not perfectly a la carte. How do we balance that with a community if we're going for people who are not yet sick, people who we want to get the distributed direct from consumer entity? Is that an entity that you found to be as sharing avid, or is that a community that you think would need different strategies to get them to say all or none, go for it?
So I recruit from the community, and I recruit people. I need to compare people who have addiction to people who do not have addiction. So I'm often recruiting 25-year-olds who have no illness. And actually, last summer, I piloted a study of 1,000 subjects. I mean, when would I, a few years ago, if I said pilot with 1,000, that would have amazed me. But I recruited 1,000 subjects with genetic data using 23andMe. And it's CLIA certified lab, and I downloaded their genetic data, got it back in 4 weeks. They say 8 weeks, but they're so good it comes back in 4 weeks now. It's great data, looked at it, compared it with other genetic data I did, and then I handed it over to the participants. So I think people are ready to share. I'm ready to share. I think it's time for us to go for it, and I'm just not scared.
And those healthier participants didn't have incentives or compensation?
That we did pay them $25. So we paid them $25 to come in, for a compensation for their time, because they filled out a survey, a questionnaire where we asked them about their substance use. And their compensation was also, they got the 23andMe results.
The results, right.
So both of those were incentives.
You've got some healthy patients in the Autism Speaks cohort as well.
Yeah, and I've been thinking about this problem, ever since the initial PMI, objectives, if you will, were laid out. How can we recruit typicals, if you will? And actually, it's just been since we've talked in the lead up to this that I've been thinking about this. Our approach, from day one with our AGREE repository, the repository of samples that we're digitizing and putting into our missing database, is focused on families, focused on an individual, a proband who has autism, perhaps a sibling with or without autism as well, and their unaffected parents. And so our database itself is more populated with controls than they are with affected individuals. And they're very happy to participate in the research because they understand the power that focusing on a family rather than a case control offers. And this may very well be a vehicle to help deliver more typicals, because I think the second question that might be of interest to that parent, other than trying to understand, is there a genetic story behind our autism journey? What's the story behind why we don't have it? And can that be of value to the greater population. So it could be through partnerships with organizations that are focused on family, multiplex or simplex families, that one could accumulate a great number of typical controls for a much larger cohort, assuming you could work out the standardization of the consents and such that are needed for that.
Next question, which goes into the communities that you represent and have learned from, where do they want this data to go if it's not a kindred spirit? So one very controversial question is, if we're not dealing with health systems or with provider networks that are submitting this data, if we're dealing with those direct participants or otherwise, do they want this going to, who's that third party? Is it the NIH? Is it a not-for-profit? Is it an academic medical center? Who would people feel comfortable being the central repository or the sharer of this data from your community's perspective?
I think where the data lives is less important than who's in charge of it. And that's where I think governance really matters. It needs to be multi-stakeholder. You have to have trusted people at the table. I mean, people would say, the NIH thing on the survey made me laugh because I wonder if people understood that NIH is the government. Because because I run into things like that. But that's where the governance and the real substantive involvement and the transparency is really critical, I think.
So I'm going to echo that. I think that it's not who they're willing to share it with, it's about trust. So in our community, the patient community itself has the best repository of all patient data. And there's trust amongst the patient community that the leaders of that community will make good decisions when we share it and with whom we share it for the benefit of the patients. There's a sense that when we share that data, we're sharing it because we're trying to make a difference towards understanding and treatment. And I think that trust is what's critical, and also having that control so that that trust is enabled.
I would only add to that as I've interacted with families in the autism community, zero concern about seeing data exploited if the individuals exploiting that, even if they get rich developing treatments that improve outcomes for their family members, they're quite comfortable with that. However, the ground rules in which that data is accessed and exploited is a very different matter. So I think it is that trust aspects of who's owning the access to, not so much the exploitation of that data that is of concern. And in that regard, I think there's a significant level of comfort for anyone who doesn't have a skin in the game, so to speak, from an exploitation point of view. So patient groups and IH would both fall, I think, into that category.
And so the data from the studies that I run have been deposited into dbGaP, and I have been very pleased with dbGaP. Actually, I was the first investigator who had a data breach regarding dbGaP because there's an embargo period where, as the investigator, I had sole access to it for a period of time, and another investigator actually breached that and published the data in my study prior to the end of the embargo period. So even though I am the person who had that occur to, and there was a nice article in Science about this, I remain fully committed to data sharing, and which I think is really key. And I actually would argue that my career has been better because of data sharing, and we have mechanisms to encourage data sharing. At this point, so I'll be a little controversial here, is the data sharing component of grants is not considered in the scientific evaluation. And this is something, again, we could think about with CSR, is should the data sharing be considered part of the scientific value? And I think it should. So I think dbGaP actually acted very quickly when they recognized the embargo. And I know of no breach of the patient data inappropriately with dbGaP as of yet. And that's been going for many years. And I think that that's been a great example. And my data set has been requested by over 300 independent investigators. And I have no say in it. And it's great that it's being utilized. Yes, there is a policy in place, and so the question was when there was the breach of the data by the investigator, did something happen? And yes, it actually happened over the Labor Day weekend several years ago, and NIH worked over that weekend to initiate certain aspects, and Dr. Collins wrote an editorial after that, and several things changed. So again, I'm sad that it happened, but things worked out well, and we need to make sure that there are protections in place that if anything happens to these data sets inappropriately, that something happens to those people.
Out of respect for our timing for the afternoon, we've got about 25 minutes left. We are the last session before you get home, so we're going to open things up to questions at this point. Pearl, if you want to get started.
Yeah, sort of a question and a comment. I could not agree more with broad consent being the way to go and broad data sharing. But I would note, and I live in the IRB world, so I'm like the vice person in the other way, I guess. The difficulty exists in where that data goes. And I would just like to note, in the NIH, the Trans-NIH Biomedical Informatics Coordinating Committee, there are 65 separate repositories listed. There is some commonality of rules. There is not routine, there's no standardization. So I think, Laura, the way you described how the consent kept changing, that's what we're getting from ICs at NIH. And so I think what we need to do is to take advantage of this broad resource. We need to have some interoperability and to get some consistency. So I think, maybe is another good thing that could come out of this.
Well, the concept maybe we actually establish that IRB application. For once, we don't let University of Michigan super smart lawyers come up with their additional clause, and each entity has to show that they're uniquely intelligent in a particular way, and this may be the political force of this organization, and this effort may allow us to make progress. Got a question in the back?
Sue Freeman from Force. So I just would ask Robert Ring to clarify with regard to the comment about patients don't care if someone makes some money off of it or exploits it as long as it helps their families, and kind of circle back to the idea of making sure, though, that the technology developed off of people's data is accessible to them and it doesn't drive the cost of the technology up so high that they actually don't get access, because I think that will do a lot to erode public trust.
No, this is a fair point. And what I may have fallen short on characterizing is really more that risk-benefit equation. And it's not to say that it's fully, in favor of one, or that it's not a zero-sum reality. But more often than not, as I have experienced it within our community, there's a great interest and a great tolerance for the exploitation of data if it is going to generate improved outcomes at the end of the day. It's not to say that one enters into that recklessly without any concern for how the progeny of that access, the reductions of knowledge to practice in the form of patents and whatnot, intellectual property created from the exploitation of the data, is not managed appropriately. There's only so much one can do to enforce all of those downstream actions. What we would simply like to achieve is more of a level playing field to begin with on the access to data. Because at this point, I would argue that the access to data is not uniform, and oftentimes it's the delay in the sharing of genetic data, for instance, that oftentimes slows the progress of research.
Can I ask a question?
Can I just make...
We've got somebody waiting over here. Yeah.
Okay.
Hi, this is Megan O'Boyle, and if I could clap and hold a microphone, I would, because this, and if I could tweet, I would tweet, but I don't know how. This is the best panel. Kathy's going to teach me later. I'm just amazed at how calm this room is, that everybody up at that table says, share data, share often, share it all, and nobody's fainted, nobody's died, everybody's still in the room. So I think this is a good sign, and I think that PMI is the opportunity for our nation to say, it doesn't matter what we've done before, it doesn't matter what the rules were, it doesn't matter what the IRBs used to say, this is time for a restart, and we're going to try it this way, and let's see if it works. And I think that it's going to work for a lot of people, and it might not work for some, but there's the old model that they can use for what they want to do. In terms of the healthy patients, as Dr. Love said earlier, the only difference between a patient and a researcher is the diagnosis. But what I would say is also, if anybody in this nation doesn't have a relationship with somebody that has a condition, chronic, rare, common, then they need to get out more, clearly, because I have a mother that passed away, and she had early onset dementia. I have a child with a severe genetic syndrome, and I have kids that have exercise onset asthma. So it runs the gap. So I don't think finding healthy people that have incentive to be involved should really be something we really have to worry too much about. And if I didn't say it before, I think returning data is the best reward you can give them.
So I'd just like to respond to that, because I was at an IOM meeting in the fall where I almost fell off my chair because there was an ethical researcher in the panel at the front who basically was saying we have to protect patients from their own data, and we can't. And that's the mindset. I don't think those people are in this room, so that's going to be the problem. And the lack, I'm just going to toss out there, the lack of leadership from OHARP, I think, is a real problem and a real issue that once I finally figured out how convoluted that was, I was really angry. I'm calm now, but I was really angry.
Yeah, I think if you look at the standards section, we discussed this on some of our phone calls earlier, the IRB, the vulnerable populations, by trying to protect them, we're really harming them. Let's be clear, by calling them vulnerable, it's very paternalistic, and we've underrepresented them in research, making them more vulnerable, not somehow less, and it's time to change that pathway.
Can I add something to that? Because I am a psychiatrist by training, and one of the populations that's often not considered vulnerable is the mentally ill. And they can't consent, all these different ideas, we have to protect them. And it is such a mistake for us to do that. We really need to return results. We need to include everyone. And I actually don't know how to divide mental illness from medical illness. This border, I don't know how to put this border down, and I really fear that we're going to cut out mental illness from PMI.
Gentlemen, yeah.
We have mental health and physical health, and we all have.
Yes, sir.
So Megan basically said everything that I wanted to say, so I thought of maybe a contrarian question to ask the panel that's very serious.
You don't have to ask a question.
Yeah.
Yeah.
When I'm a healthy cohort participant, I may be willing to participate, but I become an alcoholic. I recognize my alcoholism. I may not want to participate. This is a longitudinal study. Have we put any thought, is it built into this, my rescinding my sharing of data? And maybe you guys could share about that.
I think a lot of initiatives include a revocation clause in there, build a ton of infrastructure around managing it, and then hardly ever see it being used. It's been our experience, the Michigan Genomics Initiative, is that people can pull out afterward, and no one really does. That takes way too much energy, as it turns out. Yes.
Hey, Joel White with Health IT Now. So just from a patient engagement standpoint, I'd like to point out this side of the room is doing much better than that side of the room.
They're tweeting, just for the record.
They're tweeting, okay. Because we don't know how to tweet on this side of the room. But I'll side with Meg on what she's talked about on patient access. But a question I know we've been focused on IRB and maybe some of the common rule issues. But, HIPAA was enacted 96. The rules came online 01. Is it time to rethink and maybe more importantly, rewrite HIPAA that would allow additional access and data sharing?
This is the bully pulpit for that.
We did that in 2014. It's been updated.
Yes, if I could just jump in on that, I think it's definitely time to rewrite HIPAA. Certainly, there would be cases where privacy can protect patients, but privacy can also kill them.
Well, and the fact that they can do health services research without consent, so they can help hospitals make more money, blank bluntly, to improve the quality and quantity of care, but you can't do anything to help patients. That makes me crazy.
So real quick on a follow-up, so not just should we, but how should we?
I think you have the people in the room, they're going to help drive that. And when I, complained about a regulation, Kathy said, yeah, we'll go talk to the Hill. I didn't know that was a response I would ever get. So I think you saying that is going to make about an hour topic of conversation in the closed session tomorrow, probably.
But it is worth noting that we have far fewer restrictions if we actually put all of what we want to do into the IRB approval and actually have IRBs that are willing to see the future and work with us on this.
So I wrote my first master's thesis on why HIPAA would fail. And actually, really, it was, and one of the many of the things that were addressed in there were the patient privacy issues that protected researchers and prevented patients from being participants in the research beyond just donating their information in exchange for a $20 gift card. Having said that, the HIPAA update of 2014 did do a lot to make those changes. But that wasn't, while that was pertinent to what was just discussed, what I was actually asking about, though, is Dr. Beirut had said that she provided all of these data, DNA, genomic data back to the individuals that were in her study. At a very, very large cohort, whatever the term of the moment is, of 1 million, how much would that, we were talking about the 1 million cohort, whatever the term now. How much would that cost? Who would bear the cost? And how could we possibly afford it when we are looking at a 100% cut in AHRQ funding, a 30% cut in ONC, and et cetera?
So I used 23andMe.
Can I just say that the funds set aside for PMI are not going to detract from existing funds for other research at other agencies within the NIH. So that's a moot point. So go ahead.
So who in this room has done anything like Ancestry.com or 23andMe? So, I'm just amazed at the way that they're able to do this efficiently. It's a business model. 23andMe, $99. I get the mailings, the DNA is processed, and then they have their beautiful website where they put it back. So it's incredibly efficient.
Can I expand on that? Because I tried to get this for our university, and we did. We got a $50 discount. So it's $50 per person. What I want to know...
You got a better discount than I got.
Well, that's because it's me.
California.
Actually, this is very important. 23andMe came here a couple months ago and presented. They have a wonderful website. They're very nimble. And what I wanted to know is the FDA blocked what they were doing. So how did you get around that?
So I am not getting around the medical conditions at this point. The only thing that's going back to the participants is the ancestry stuff. And I'll tell you, the subjects love the ancestry stuff. They just really love it. So I got my 23andMe early enough that I actually have all the medical stuff that they did before. They did a really good job. And I think that we're, again, at this issue of regulations, that I'm not into all these regulations, but the way the FDA approves it is like one variant at a time testing, as opposed to we're going to have 3 billion variants tested. And how do we get through that regulation moving forward?
Spiro?
Yeah, one of the reasons why people aren't jumping up and down and screaming is because most of the discussion has been couched in terms of person or patient-centric permissions and approvals. And if you go back to 2 previous panel presentations, we saw a distinction drawn between person and community. So that, for example, I work in American and Alaska Native communities. And frankly, the cultural sense of self and the way in which we are defined is not nearly as individualistic as most communities in this country. And as a consequence, we actually, and being dependent domestic sovereignties, actually have codified that sense of self so that, for example, yes, an individual tribal member may agree to participate and may agree to the uses to which these data are put, but at the community level where the governance is managed, for a whole host of reasons, there have to be certain provisions met with respect to the use of those data, independent of what the individual subscribes to. For example, the Barrow alcohol study done in 1982 was famous in Native communities, in which the epidemiologic data characterized the Alaska Native members of that community as essentially alcoholics, with screaming headlines across the Washington Post. And as a result, the city bonds, about $18 million that were going to go into civic improvements, fell apart. And we have dozens and dozens of examples of that in Native communities, where there has not been brought to bear the sensitivity and the appreciation for the implications of the use, interpretation, and release of data. And so today we're seeing in Native communities particularly not the same degree of easy acceptance of the views presented here. And I think that's also true in many other communities across the country. So I think it's important for us to keep in mind the difference between the individual and the community level understanding, approvals, and support of these kinds of issues.
I will add that that is specific to the Native Americans, and every community is different, and that's what we try to highlight this morning. And we have a speaker right here.
Hi, Carol Hartz from Mount Sinai. I echo your excitement that all these people should want to. Everybody has sick families, and I'm so excited. The room is excited, but I want to go back and see if we can shine an equity lens on what we're talking about and the discussions we had earlier of communities who do not feel this is going to be in their best interest, who do not feel a trust in this, who don't understand how this is going to help. Things don't seem to have helped communities before, and it's not that people don't have sick relatives or that they don't care. Or that they're not literate. It's that they have very significant life expectancies that are kind of screaming in their head otherwise. And so I just was hoping you could reflect a little bit on how to take this excitement and take somebody from a different kind of community, somebody in Harlem where I work who really may not agree with any of this at all, and make it so that they feel equally welcome in this and that we can involve them in this initiative.
So I really love to comment on this because I've recruited about 6,000 African Americans from Detroit and St. Louis. I've recruited also, in the St. Louis area of whites who really have low educational attainment. Half of my subjects do not have a high school diploma. It's just astounding. And really, what I find, though, is engagement. We do a couple things, and I'm looking towards this aspect to really engage in many different ways. So we do snowball recruitment, where you get someone engaged, and then it goes out. I think we're going to need to do internet-type recruitment of explaining it on the internet. My research assistants really are extremely good about explaining it. We read our consent to all of our subjects because I know the health literacy is incredibly low. And so after it's painful to me. We have it now recorded because, it goes on with all this legalese. But then at the end, we do bullet points of, okay, these are the main things that we wanted to make sure, are in here. Do you have any questions? And I'm not having any problem with engagement. I'm just not having problems. I understand the concern. And actually, when you made a comment about if there are no resources, we don't ask the questions, terrified me because there aren't resources for substance use. There aren't resources for mental health. So that's another way that we could stigmatize illnesses that aren't getting enough resources. And it becomes a circular problem.
I have a comment. When we talk about broad consent, that scares me. All I can think of is Henrietta Lacks. Mm-hmm. When you talk about not really going through the consent processes for additional studies once you've gotten consent and making a broad consent, that confounds me, how we could even talk about that.
Kathy, your thoughts?
Not that how we could talk about it, but the fact that so many things have happened, so many atrocities have occurred over the years, and to think about redoing HIPAA or to broaden HIPAA or change some of these protective measures that have been put into place because of things that have happened in the past. I guess I need more conversation on that, more education on that, more information on it. Thank you.
So I'd love to have more conversation with you and others about that. I've had the great honor of the last couple of years of working really closely with the Lax family. And in fact, they have been one of the big catalysts for us proposing a concept of broad consent. Henrietta Lacks was not asked for her permission, nor was she informed that her tissues were used to generate the first immortal cell line. And her family now is, I would say, among the biggest advocates for broad data sharing and broad participation in biomedical research. And they have been a big catalyst around reforming the common rule and putting forward a proposal for broad consent. That obviously requires additional conversation. I'd be happy to talk more about that.
Yeah, there's lessons to be learned from the Henrietta Lacks experience, but it's not that we shouldn't have a broad consent. It's just that we should have a consent. Tim, you.
Yeah, I would like to say the other problem about narrow consents is it's very hard sometimes to figure out where they end. Somebody gives a consent for using their specimen for cardiovascular disease, but somebody wants to come in and study the relationship between PTSD and cardiovascular disease. Is that inside or outside the limits of consent? And so you find that investigators and IRBs have a great deal of time struggling with this. One thing about a broad consent is it's unambiguous as to what it means. And I mean, so you definitely will have people that are uncomfortable with it, but I'm uncomfortable about narrow consents because in the end, somebody else is going to be interpreting what that means. And neither, they're not going to really understand what I was thinking, and I can't really understand what they're thinking. Just a thought.
I think that would echo the experience of the panelists, so what I've heard over and over again. Yes, sir.
I'm Tom Insel from NIMH, and I wanted to respond to something that you had said, Dr. Birut, which I think was really, really very helpful. The idea, well, there were two things. One was your advocacy for including people with mental illness, I think is spectacular. On the other hand, the comment, which was we are looking for people who will give broad consent, and those are the people that we include. And that makes a lot of sense, right? And maybe that for this effort, the PMI effort, that's just the kind of policy that we want to adhere to, because those are the people who will volunteer and who will work with us. My question is, with respect to your comment about mental illness and about other groups, does this bias our sample in some way? And is that going to be a problem for us if we say we're only going to take people who will agree to that kind of consent? What are we losing as a result?
I think that that's a great question. I'll tell you, I'll speak from my experience, which is I have seen no meaningful differences across any variable that I have looked at. Men and women equally agree to the broad consent. Across racial groups, equally agreed of the broad consent. Educational attainment, equally agree. I mean, I could go on with the list, and with mental illness. The barrier, so I do think there is a barrier, and where do I think the barriers are? So one of the reasons that I think African Americans are not included in many genetic studies has to do with the barrier of reaching that individual. So we were doing, when I was recruiting through phone calls in the St. Louis and Detroit area, we were recruiting through driver's license and then getting the phone numbers from the driver's license. The phone numbers for the African American community had changed more often. They were no longer at the address. And I think it had to do with poverty, of moving from house to house. But once I got a person who was African American, they consented to participate in my genetic study at a higher rate than whites. So I think it's actually the outreach. So we need to make sure we do outreach into the community with mental illness. It'll be very easy not to do outreach. You know, where do they live? They live in, group homes, they may be homeless, a variety of things. It's the outreach that I think is the main thing. And so my fear is it's going to be higher socioeconomic status. I'm on the internet. I could click in, and that's who we're going to get in the PMI. And we have to really make sure we reach into communities that aren't getting health care and are not generally represented.
Wrong one. Okay. I'd just like to add that, you know, when you were talking, I had to smile because you said my research and subjects. And it's like, no, it's partners and our research.
I apologize.
She's
you
one of the
are
good guys.
absolutely correct.
I know. It's just, it gets on. I say subjects sometimes.
And you know what? It's not my data.
Yeah, right.
It's
That's right.
5:15. I think we have time for comments that don't require a response. Unfortunately, is all we have left. Pearl's been waiting very patiently, and as of you.
How
Pearl.
odd that I was patient.
Uncharacteristically, you were patient.
I would just add, back to the discussion of overprotecting people from their own data, I think another group that we've already referenced during the day is the need to educate clinicians and researchers. I mean, a lot of the protocols we get are overprotective. We also have difficulty, particularly within psychiatry, of accessing patients to see if they want to participate in studies. So I think that, and yet that is part of the whole PMI, and I think just reiterates the need to do that.
Absolutely. And then we got one final comment.
Carl Sorkin, I'm with MIT, and I guess I have three hats. I'm a trans person, I have a BRCA mutation, and I have a son with Perthes disease. So I guess my comment, just to be brief, because I know we're at the end, is just that I think in many cases, at least in the BRCA community, the data sharing comes up because it's been really apparent to us that one of the huge barriers to kind of making progress is around the variants of unknown significance. And now that we have panel tests, we're getting more and more of those to some degree. So I think a lot of this discussion has been around consent and the sort of what happens if a patient wants to give their own data or give their own specimen. But what happens when the genetic testing company itself does not share the data, right? And the patient wants the data to be shared, because that's sort of what happened with Myriad Genetics. And I feel like as much as the community is aware of this, really nothing has happened to correct it in any way, and the other companies are not in fact doing that. So I don't know if anybody can respond to that, but
I don't think we'll have a chance to respond. A great point that we need to be aware of. I want to thank the panelists for enlightening session.
Okay, so thank you all so much for your energy and your engagement and everything that you've brought into this discussion today. I think it's been really exciting, and I love that we've heard a lot about the issues and the challenges, but also that we've heard a lot about the solutions and people and groups that actually are doing some innovative things and doing them successfully. So let's give you a brief overview of the workshop from day one, some of our upshots. We have a huge opportunity here to partner with researchers and research participants. Trust, transparency, and continuous communication are key to fostering long-lasting relationships in the cohort, which I should just take a line and draw through cohort, because I think we're now actually a community-based genomic study, right? This got changed as the day went on. People need to see intrinsic value of the research and want their health information. And we need to come up with a new language. We have an opportunity for new definitions for traditional research terms and certainly around partnership. So here is our Twitter overview from all of the twits in the audience who were twitting. So we have 1,773 tweets. We had 15.7 million impressions, and I think our last workshop we had 9 million impressions, so we're going up. We had 330 participants, and then we had 440 people who tuned in for the video cast, which I think is awesome. So thank you, those of you that were on the video cast and will be back with us tomorrow. We know that we moved around the room with microphones to kind of stimulate discussion, and we appreciate your patience with that. So here are some key upshots from our welcome session. So this is playing along in real time because the NIH staff has gratefully made these slides for me, so this is going to be really fun. Okay, so this is me. On 4th of July, we celebrate the birth of a nation and the birth of a research cohort. And PMI Network launching We the People of the Precision Medicine Initiative with me and Dr. Francis Collins. So we are here to liberate the patient data. And then to the NIH director, participants will play a significant part in design of PMI Network. Today's workshop lays ground for how around real engagement. And that was actually by Dr. Francis Collins, tweeted by Kelly Edwards. So session 1, envisioning a cohort that's participant-driven, inclusive, and diverse. Sharon Terry, watching our language. Building bridges. If we actually start in the community, there's no bridge needed. Why do we start here and not there? And then Dr. Daryl Roberts. I asked Branch, so Vernell, how to engage underserved populations in research. She said, make the results useful to them. How do we access them? Kelly Edwards again on Vernell Branch. How do we reach people? Get boots on the ground and go to where people are. And then Sean Sigmund on PMI Network. Social media needs to, I'm going to assume, be leveraged to simplify clinical trial recruitment and consent process. Session 2, public perspectives about a PMI cohort. Claudia Williams. Major conclusions from PMI Network. Survey participants want to be equal partners and really value getting health information back. Donna Young, during Vince Bonham's talk on the RFI results. So Vince on community engagement strategies, meaningful engagement, continuous communication, transparency, and partnership. Continuing on, we have more faith of participants equals more responsibility of NIH researchers, says Dave Kaufman during the FNIH survey result presentation. And then we have a great point from the audience. Community time is not institutional time. You can't always meet unreasonable deadlines. I think this was in reference to grant cycle times. Session 3, inclusion and engagement goals related to health equity. Positive disruption in research practice goes beyond us, them, to the new we. It's risky. Real changes are hard. Thank you. We keep hearing some of these themes that are building throughout the day, and I think it's really exciting coming to this from the participant side of things. So nothing mentioned today is insurmountable. We can do anything, but we can't do everything yet. Comment by Dr. Rick Kittles, must be careful that precision medicine isn't built for the privilege and that it increases health disparities. Session 4, challenges in recruiting and retaining disadvantaged and underrepresented populations and the best practices for overcoming them. So we have Spiro Manson, contribution versus incentivize. If we incentivize, we have already lost the battle to engage. And then Allison Ryan again, we have dollars for research. Don't necessarily need more dollars to increase minority participation. We need different dollars and flexible models. Challenges continued, and then best practices for overcoming them. Let's see, +1, must be inclusive of all levels, abilities, health, and tech literacy, financial status, and language. And then Francis Collins points out that the main PMI network study is longitudinal. Session 5, establishing collaborative and inclusive governance in a large study. Al Richmond's call to action, let's give the community credit for what they do know. And then we have Lucia Savage under the revisions to the Belmont report reflects interests of the community, ? That'll be a good read when it's done. Anna McAllister-Slip, Al Richmond again. We have to convince people that we're serious about patient-centered and that we want to know what they think and what they want. And then J.B. Smalley, who's here from Pecori. We have Consuelo Wilkins talking about the importance of bidirectional communication for engagement. Session 6, what would a direct from participant cohort model look like? Megan O'Doyle, congratulations, name change. Megan O'Boyle. PMI should accommodate health data sharing from 0 to 100%, enable those who want to share it all. And then Anna McAllister-Slip again, Dr. Susan Love. We need to make sure that the NIH and PMI network lets research be defined by the community and not just credentialed researchers. Continuing the direct from participant model, Sally Oken on patient-generated data. Adds Technicolor to the black and white data generated through traditional research models. Megan O'Boyle again. There's a culture of fear in research. I don't want to be protected. If you do, that's fine. Lucia Savage, Matt Might. Only question is, what a participant wants done with their data. And then Kathy Hudson, who's a new tweeter, and I think she's getting the training wheels off. Laura Jean Beirut and her research participants love broad consent. We need to make sure IRBs and institutions don't stand in the way. Laura Beirut again, my career has been better because of data sharing. And then Dr. Susan Love, where the data lives is less important than who is in control of it. All right, so our champion top tweeter award is a tie between Dr. Susan Love and Sharon Terry, and Sharon had to run to another meeting. So congratulations, thank you. If your thumbs are tired. Okay, and then I'm going to go through a couple photos of our lunch challenge. So remember this morning I said, here's the important, we're creating the we, we're not the us and the them. So I want you to ask yourselves, did you do a great job at lunch of mixing with other groups that you don't know? All right, so the first photo, and I apologies to Megan O'Boyle, who's like mid-bite. Several of you were, and I'm sorry. So we have mostly or entirely a patient community table, unless Allison is at you and you're from Academy, so maybe get a little credit there. We have an NIH table. You came later, I saw you. But this was like a good half hour, everybody knew each other. I'm gonna go with our academic table. And then we had this table that was actually mixed on the bottom right-hand corner that was academia, government, patients, and regulatory. And I was at that table, so sorry, yeah. Okay. Pearl, thank you. So let's see again. I think we got a couple of folks that actually know each other and maybe didn't venture too far outside their circle, so we'll challenge that. And tomorrow you'll have an opportunity to come back and circulate on our breaks. So with that, I want to say thank you so much to all of our panelists for coming in again and for participating. And certainly the audience, you guys brought a lot to this, and certainly you have given so much to the working group for things that will be useful to us as we're having to write this report. And thank you to all of our ACD, PMI, WG members who moderated and who jumped on our crazy bus to organize calls and support their speakers. So tomorrow we have the meeting starting at 8 a.m. and it wraps at 12:30. If you haven't shot your PMI Faces or your Faces of Precision Medicine video yet, you can still do that until I think 5:30. No, actually it's 5:30 now. They said they'd stick around for 30 minutes. So you still have time to shoot those today before you start drinking. So again, thanks everybody, and we'll see you tomorrow at 8 a.m.